And let's begin. We have an entire hour. So, and there'll be plenty of time for questions as well. But I'll do this in the context. Oh, I have to show the pictures too. So that's 2000, when I had a little less hair, but 2013 with Nalini, and this was the 48th conference in 2018. So I'll make a plug here for an international foundation that's been formed recently that I urge you to take a look at or send your patients to if they're looking for support, other patients to talk to around the world who are struggling with particularly adrenal cortical carcinoma, which will be part of the focus in today's talk. Feel free to take a picture of that QR code if you like, or I can share it with you later for that matter. Okay. So I work at the University of Michigan in the center of our country, and in an endocrine oncology group that focuses on mostly hormone-secreting tumors, tumors of endocrine-secreting glands like the thyroid and the adrenal. And I'll say we have a long history in Michigan of over 7 decades since Kahn discovered primary aldosteronism at our university. And the program has been able to grow over the years since the 2000s. And I'm delighted to say our adrenal group is quite large now, really across the translational spectrum, from basic biologists through translational researchers, clinical trialists, and care providers. And it provides a nice network and framework where we can really do our best to push science into the clinic. But always, of course, in endocrinology, it requires collaboration, not just clinically with our endocrine surgeons and our oncologists, but also with our international colleagues, which is why I'm delighted to share that, as you may know, there are 2 large groups that we've formed, the Endocrine Network for the Study of Adrenal Tumors and the A5, the American Australian Asian Adrenal Alliance. These each contain groups of over 50 universities each. So over 100 universities around the world who focus on adrenal disease and do our best to develop guidelines, and really steward the field forward so we can do our best to, again, provide the best care for our patients. So we're going to focus today on the adrenal gland, okay? Which I don't need to introduce too much about the adrenal gland for anyone in the audience. But suffice it to say, we're going to focus on human adrenal gland today, not on mouse studies or other studies, which I love, but we're going to focus on clinical disease today and really dive a little deeper in the second half of our discussion into adrenal cancer, a very rare cancer that we all see occasionally. We had the first ever adrenal cancer conference in 2003 at the University of Michigan, and we were a bit too excited about it. And we thought we were going to develop a consensus statement in 2 days. And what we realized that day was, in 2003, that 1, we didn't know each other. 2, we all treated patients differently. 3, we weren't even sure if we trusted each other. And 4, we didn't know anything about the biology of this disease. So we had to really go back to the drawing board over the last 10 or 15 years and really dive a bit deeper into understanding the clinical course of a disease, the genetics of the disease, to begin to understand the heterogeneity of adrenal cancer, and with the hopes of being able to provide more personalized medicine. I'm happy to say that 15 years later, we and others have developed a number of guidelines for adrenal tumors, be they benign, malignant, cortical, or medullary, with both surgical guidelines, the most recent being from the American Association of Endocrine Surgeons that I list in the middle there, the adrenalectomy standard of care guidelines in 2002, plus others for adrenal cancer and the workup of nodules. So I certainly draw your attention to these if you'd like a little more deeper dive into these guidelines that I'll provide today. But I'll use these as a springboard for discussion as I go through cases. I thought that would be the most fun way to go over new developments, to go through about 10 cases, but we have time, that highlight different aspects of practice management that either have evolved or still need evolvement, for which the cases can provide food for thought for you as you move forward in the care of your patients. And why is that? Well, there's still practice gaps in every field, and for adrenal tumors, particularly adrenal cancer and metastatic pheochromocytoma, we still have problems with diagnosis, getting patients the right referral, endocrinologists, endocrine surgeons, medical oncologists, and getting the right therapies to these patients, albeit there are not hundreds of therapies for adrenal cortical carcinoma or pheochromocytoma, but we need to be able to really advance that, educate our community about the available therapies, and develop standards of care, whether it's first-line therapy, second-line therapy, or third-line therapy. I know those are obvious, but that's why I think this is an important discussion. So let's start with the following. Most endocrinologists know that adrenal nodules are incredibly common, up to about 7% of our population. That means in this country, you have close to 100 million nodules a year. Of course, those are not all removed, and they shouldn't be. But you need to, all endocrinologists need to know how to evaluate these masses. The most common mass in the adrenal is an adrenal cortical adenoma, right? And we think about these quite frequently when you hear the word incidentaloma. I don't like the word incidentaloma. It doesn't specify much other than it's a nodule in the adrenal gland. Not cortical, not medullary, you don't know where it is. That's the most common, maybe 30 to 50 million cases per year by the cases per year, about 50% of the cases perhaps. 30 to 40 cases per million per year. Next is probably metastatic disease to the adrenal from another cancer. The data would suggest maybe 8 to 16, even 20 million cases per year in India. This is important to realize that this is most important to think about, well, in every patient with a mass, but certainly in someone who's had another cancer in the last 6 to 12 months. If they have a new adrenal lesion, it is more than 50% likely that that lesion is the MET, okay? And then what endocrinologists think about most frequently is also the pheochromocytoma, 10 to 20,000 cases per year if I'm doing my math right in India. Not many cases of malignant pheos, but I think it's more than that. I think that's from an old slide. And then the very rare adrenal cortical carcinoma, that is a disease that I study, I try to study quite avidly, and we'll talk a bit about today. Okay, so aside from those four, we all need to think about the fact that lesions to the adrenal can be, of course, intrinsic lesions, most notably cortical or medullary. Yes, we do have primary adrenal lymphoma, we do have sarcomas of the adrenal, but cortical and medullary lesions, but they can also be anything. They can be hemorrhage, infection, granulomatous disease, et cetera, et cetera. So, what I'd like to illustrate today, because of the frequency of adrenal cortical adenomas, one of the questions we need to be able to ask is, can we preoperatively distinguish the most common benign adrenal cortical adenoma from everything else, particularly a metastasis or a cancer, preoperatively? And then if it happens to be the ultra-rare adrenal cancer, an interest of mine, can we postoperatively determine which patients will recur, right? Because if it's high risk, you may want to treat them with something even though they have no evidence of disease because they're going to recur. And you'd like to know if they're low risk, maybe you won't treat them at all. And of course, with recurrent disease that's metastatic, we need to develop therapies for them. So those are the two bookends of the questions we'll ask today. So we'll do that through a series of cases. Here's the first one. A 30-year-old man with gastroesophageal reflux presents to an outside hospital ER with abdominal pain. And we all see hundreds of these. Incidental adrenal mass is found after a workup for appendicitis, and a non-contrast CT shows a 3-centimeter left adrenal mass. Patient is sent to you for evaluation. And you only have access, by the way, to a CT report, and there's no measurements of density of Hounsfield units in the report. How often have you seen that? Right. So the question I'll ask you first is, okay, if the CT density was 17, which of the following lesion does this most likely represent? The answer is an adrenal adenoma, and those of you who are thinking 10 was the cutoff, that's why I'm giving you this, that's why this is written here, okay? It's now 20, and you'll see why. But what if the Hounsfield units were 45? Different question. If there's trainees in the audience, this is a classic board question, okay? Which of the following lesions could be ruled out? Is it the adenoma? No. When it's over 20 Hounsfield units, the lesion can be anything. That's the trick question, and that's what you need to know. Less than 20, great, adenoma, done. Greater than 20, anything. A lipid poor adenoma, for example. So, next question. Oh, sorry, let me go back one. Okay. So when you see the patient and see the CT scan, do you want to biopsy it? You want to get another CT scan, do a hormonal evaluation, or some combination therein? Well, this is the crux of the matter for any workup of an adrenal mass, right? You need, I don't know where my... The answer, of course, is D, which is B and C. All lesions need both a functional and an anatomic workup. The functional workup, of course, is to determine if this is a lesion of the cortex of medulla, is it functional? And two, the imaging studies are to determine, do you think it may be malignant or is it clearly a benign adenoma? Those two things must always be done in any patient with any adrenal mass. And that's the number one take-home message, the workup of adrenal mass. And most of the guidelines will agree, all the guidelines agree, that you need both these two different workups of an adrenal mass. And that's, I show in these little boxes our international adrenal cancer guidelines, co-developed by NSAT and the A5, published now a few years ago, but still relatively up to date clinically. Okay. Now, the anatomic workup, forgive me if this is, again, drawn out, but for the trainees, the anatomic workup is predicated on the fact that the adrenal cortical adenomas are the most common, and two, the adrenal cortex stores cholesterol ester as its lipid, and that cholesterol ester is the precursor of all steroid hormones. So if you can prove that there's a lot of steroid ester in the lesion anatomically on a CT scan, you can say it's an adenoma. That has value. Okay, and what we've learned over the years, simply empirically, and by the way, this has nothing to do with the function of the tumor. Even though cholesterol ester is used to make steroids, the level of cholesterol ester doesn't tell you if it's functional or not. That's not what it's used for. It's just to tell you this is a lipid-rich adenoma or it's not. If it's not, I already told you, it could be a lipid-poor adenoma, a carcinoma, a pheo, a met, a hemorrhage, granulomas, anything. So very specific to rule out malignancy. So specificity is very high. Sensitivity is not, meaning greater than 20 Hounsfield units, okay, it's not a specific, not a sensitive test. It may very well be an adenoma, it's just lipid poor. Okay. And a lipid poor mass can be anything. Now, why do I say 20? For those of you who are thinking 10, which has been in our brain for decades. Here's why. A great study done by, and size has value only because we catch cancers late. All cancer starts as one cell. I've seen plenty, over 2,000 ACCs. I've seen plenty of ACCs that are 1 and 2 centimeters. You never see them, or rarely see them. But so size has value just because you're picking them up late. Okay, but I'll get to that in a minute. So Irina Bancos did a study from the Mayo Clinic of over 2,000 patients. And this has become the gold standard 4 boxes that I want you to remember. Okay? When a lesion is less than 20 Hounsfield units, particularly if it's small, okay, it's a lipid-rich adenoma, you're done. You're simply done. Okay? If you see a large tumor that's over 20, you better be nervous. A large tumor greater than 20, you must be nervous and thinking ACC, because in her study, albeit somewhat biased because of the adrenal center at Mayo, you have a 40% chance it's an adrenal cancer. I wouldn't say 40, I'd say or a met. Okay. So those are the 2 nervous points right there. Upper left, you're okay. Lower right, you better think hard about taking that out if there's no other disease. It's the purple boxes that you need to be a little more thoughtful about. Okay? Let's first look at the upper right. Okay? Greater than 20 Hounsfield units, but small, my concern there is it's just a small met. That's what you'd be worried about. A small met, or it's an ACC that you picked up early. That patient cannot be, you can't tell the patient to go home. That patient needs to be followed. You need to either get a repeat CT scan in 6 to 12 months, or you need to take it out because you're nervous. But you can't let that patient go. That's where a lawsuit happens. That patient recurs with lung mets everywhere 12 months later if you don't follow. Now, it may be a lipid poor adenoma, but you don't know that. Lower left box. Lower left box is a weird case. Okay? Think of it this way. The lower left box is a patient who has an adenoma and totally independent of the adenoma had a cancer form in the adrenal. So when I see a patient less than 20 house units, okay, and it's large, that's when we scratch our heads and say, do I need to follow this patient? Those almost never come out. But we may follow the patient with a CT imaging one time and make sure we don't see anything emerging. But that one patient that Irina saw is most consistent with a rare cancer forming in a very common adenoma. But it's not related. So again, green, you're comfortable saying, I'm done anatomically. Red, you better be very concerned. Oncologic workup, which may include more, as you'll see next, and perhaps even take it out. Purple boxes, think about it, and don't let them go. Okay, that's number one. So there's a lipid-rich adenoma, less than 20 house units. That's cholesterol ester, cholesterol with a fatty acid attached to it. That's a myelolipoma, which is actual triglyceride, which is actual fat, black, on a CT scan, benign. And they're not removed, of course, if they're non-functional. That's our patient. Small, greater than 20. Or that's a patient. It's our patient, greater than 20. So that's the one. I'm more concerned about that patient than a large 5-centimeter lipid-rich adenoma. That's the patient you do not let go. Doesn't mean I take that out, though. That I might just follow and make sure there's nothing else, okay? But if you notice, the edges are a little scallopy. It's not perfectly round, so you might be nervous about that. I see some folks shaking their head in agreement. Okay. Because remember, the sensitivity is only 70–85%. Okay. So again, unenhanced CT scan less than 20, it replaces 10. 20 is the new 10. And the size, size, as I mentioned, has some value just because of the nature by which we pick up these cancers. And as you may know, some specialty centers are now doing urine metabolomics. The metabolic precursors and products of all steroid hormones of the adrenal end up being quite different in an adenoma versus a carcinoma. And so if you do that, you can get a little more data that this is more likely an adenoma than a carcinoma. Most centers aren't using this, but I'll have more about that later. But I mostly want you to remember the 20 and the purple and green boxes. Okay. So there you go. There's our patient. And it was 45 house units, by the way, on our patient with a 3-centimeter mass. So what would you have done? Well, you would have followed it, let's say. But the patient was lost to follow-up, as many patients who go to the ER are, and they never even came to see you. And 8 years later, they show up again. Where? In the ER, same thing. And this time, you see that. So that's not good. That's obviously grown, and now you're quite nervous because now it's heterogeneous and it's quite large, 7, 8, 9 centimeters in size. Now, would you do additional imaging on this patient or just take it out? Another trick question. In this type of patient, we would always get a chest CT, always. I've seen hundreds of ACCs like that have 30 lung metastases. So a case like this, if you're concerned about cancer, now in this patient, you probably wouldn't be concerned about a MET because that's all they had the first time, let's assume, was that one lesion. But now you'd think about a primary adrenal tumor, and you'd be worried about metastatic disease, and you should get a chest, you should stage the patient before you do anything. Okay, so the answer is yes. So let's assume they had that, and it was negative. Would you obtain biomedical testing? Well, yes, of course. We went over that already. They should have done that the first time, because you need a separate evaluation of each, and we'll get to that in a minute. We'll do it now. I don't want to go through all the diagnostic tests today for primary aldosteronism, Cushing's syndrome, secondary tumors, and pheochromocytoma. I'm not going to do that in this session. But these days, unlike 20 years ago, when you have a individual adrenal mass, whether they have symptoms or not, you rule out all 3 cortical hormones excess and medullary hormone excess, period. And without going into detail, I can share the slides later if you'd like, but primary aldosteronism, we don't always see hypertension and hypokalemia, of course, as you now all well know from the recent studies, but we're looking for autonomous production of aldosterone. So we're looking for a high aldosterone in the setting of a suppressed renin, so we're looking for a high aldo-to-renin ratio. You can choose your cutoff. I put 30 here, and an aldo at least 12. Now, why is that, trainees might ask? We're looking for a high ratio, but a patient who comes in with a low aldosterone of 5 but a renin of 0, their ratio is infinity. They don't have primary aldosteronism, they're volume overloaded. Okay, so all patients are ruled out for PA. Cushing syndrome, they don't always have the classic sequela. You now know that subclinical Cushing is referred to as MAX, mild autonomous cortisol secretion. So not all patients have robust symptoms like the patients I present here, but also all patients are ruled out. I'm not going to go through the screening tests. I prefer a 1 milligram dex suppression test in this setting. We're again looking for autonomous cortisol production in the setting of a suppressed ACTH. Sex steroid tumors are almost never incidental. Women will be presenting with hirsutism, clitoromegaly, amenorrhea, or acne. And men, even if it's androgen producing, just like a bodybuilder using anabolic steroids, they still present with gynecomastia due to aromatization of the testosterone, libidinal erectile dysfunction. It's almost never incidental. Oh, and remember, trainees, DHEA is a precursor of all androgens, including in the testis. So a DHEA is almost always meaningless. You must look at the sulfated DHEA, DHEAS, which is adrenal specific, and when elevated, will confirm an adrenal source of that antigen. And we're looking for very high DHEAS levels, right? High levels, 8,000, maybe 8,000 nanograms per mil, maybe 20 micromoles per liter. A high DHEAS, which is autonomous as well, but DHEAS doesn't suppress ACTH. So ACTH isn't going to help you much because ACTH there's no feedback between DHEA and ACTH. So a normal, or sometimes it is low, for reasons you'll see in the next one of the cases. Okay. So a high DHEAS. Okay. And pheochromocytoma, well, Carol was going to give us a great talk today. I talked to him on the phone, but he couldn't come due to his own reasons. But I'm not going to go into pheo in much detail today. We don't always see the classic triad either of hypertension, sweating, and palpitations, the rule of tens. No, but these days we only look at metanephrines, as you know. For this disease, for autonomous adrenal nodules, we consider that a high-risk patient for a pheo, as opposed to an elderly female coming in with spells. Okay. An older gentleman or female coming with spells, you don't want to overdiagnose the disease, particularly if they have no symptoms. And so you don't want to choose plasma metanephrines for that test because it's incredibly sensitive, 99% sensitivity. So in a case where you don't want to miss the diagnosis, you want this test. And an incidental lesion in the adrenal is a high-risk patient, so you want to capture every possibility that this is a pheo, plasma metanephrines. Okay. As I said, the urine's not very sensitive. So case number 2. 54-year-old woman, 3-year history. Now this should be easy. New hypertension, 3 minutes. New diabetes, 40-pound weight gain, spotty menses, loss of menses for 5 months, new hair growth, deepening of the voice, new clitoromegaly. Your index of suspicion is high for which of the following, even without labs? Right. Adrenal cancer. And here's why. Well, let's just say first, you actually get labs, and it confirms your suspicion, at least, about the hormone excess, because ACTH is suppressed, DHS is elevated to 5,000, free cortisol is 170 micrograms in 24 hours, 170, or 469 nanomoles per day, and DHS is elevated. So you're still thinking the same thing, of course, right? And the reason for that, well, yeah, don't forget, you still need imaging in this case. You're not done. You have a functional workup. You're thinking ACC. You need to know what you see. So that's obvious. So only about 40% of patients present with symptoms when they have an adrenal cancer, okay? Despite the fact that about 60% have hormone excess. Excuse me, let me go back one. Have hormone excess. 22% cortisol only, and then another 17%, so almost another 20% have cortisol and androgens both. Now, a few of you in the audience may disagree with this, but I have never seen a case of autonomous autonomous cortisol and that high DHEAS levels that's not ACC. There's a couple cases in the literature that Nalini may know of cases of weird oncocytomas that made a little bit of DHEAS, a little bit of cortisol. But when you see levels like this, it's ACC until someone can prove to me otherwise with a case report. So when you see those two, you better be nervous. Now, you still need pathological assessment, of course, to rule out benignity versus unknown malignant potential or malignant, of course. Case 3, 55-year-old alcoholic, coronary artery disease, congestive heart failure with new florid Cushing's, diagnosis already made. I show the labs anyway. Again, incredibly high cortisol levels. A chest CT that shows a 12-centimeter heterogeneous mass invading or compressing the IVC, the vena cava, and the right lobe of the liver, and maybe encroaching and encasing the superior mesenteric artery. Functional status has declined over 24 months. The patient can't get out of a chair without assistance, has worsening diabetes, is on 3 blood pressure medications, blood pressure is elevated, on 2 liters of oxygen, has bibasilar crackles, peripheral wasting, 2+ pitting edema, multiple bruises, skin is extremely friable when you put tape on it, and the albumin is 2.9, creatinine is 1.8. This is a bad situation. So the patient's in bad shape. The question is this, clinically. What option would you choose for this solitary mass? Solitary. Take it out? Start chemotherapy? Start steroid suppression? Or radiate the primary tumor? So this is the kind of case that oftentimes comes to a tumor board for evaluation. In this case, 99.9% of the time, we would recommend C. These are the patients that die on the table. They get cut open and they can't be put back together again at all. I've seen it happen. They die on the table. They can't be sewn back together again. And they can't get chemotherapy either. They can't tolerate any chemotherapy. This patient needs you, the endocrinologist, 1,000%. If a surgeon calls you and says, I want to operate, and then can you manage post-operative replacement? The answer is no. You should send the patient to me. Oncologist says, I'm about to treat this patient with a toposide doxorubicin cisplatin. Will you help with steroid management? No. The patient needs you. So first, you have to have the Cushing under control to increase surgical fitness. Second, you may think about chemical debulking. By the way, I'm not talking about chemical debulking for steroid excess. We don't do that anymore. We don't operate for debulking steroid excess. The drugs are too good now. You don't need any debulking ever for steroid excess. You don't need surgery ever for steroid excess. These drugs, if you have access to them, they work incredibly well. Okay? They're relatively newer, oscilodrostat, metirapone, levoketoconazole, for example. You're debulking at times. At times we will debulk the tumor if we can, if a major organ is at risk. Okay, not in this case, I'll tell you why. Third, you may then operate if there's stable disease and a tumor response and no new metabolic disease. So this patient, by the way, it's encasing the SMA, right? You lose the SMA, the patient's bowel is dead. Okay? No surgeon that I know will operate on this patient. 1, because they're metabolic condition. 2, because the SMA is encased. So you want to both get the Cushing's down first so they can tolerate chemotherapy, then chemotherapy, can you chemically debulk, and then maybe surgery after that for this borderline resectable case. Waiting gives you time. Time oftentimes I find is either our friend or our enemy. In this case, it's a little bit of both. But it has to be more of our friend than enemy in this case. And so we have preferred metyrapone for many, many years because it can get a cortisol of 3,000 to normal in a week or two. Osilodrostat, which may or may not be available to many of you, is a newer drug in the purple box, which is so good. It's the first drug I've been able to use that I can block and replace, even someone with a cortisol of 3,000 in the urine. You can get their cortisol down to 0, almost always with ACC, and then actually replace them. A little bit tricky to do that. I'm not going to go into the nuance of how we do that, but it's possible. And the usual drugs for mineralocorticoid excess. There are, by the way, new aldosterone synthase inhibitors that are getting approved now in the US by the FDA that are very effective for primary aldosteronism, for elevated mineralocorticoids. Okay, case 4. 38-year-old patient referred with a new 11-centimeter non-functional mass found on a chest CT during workup of a chronic cough. 11 centimeters, non-functional. In your review of the chart, you see a brief op report by the attending who says complete laparoscopic resection of the mass, no minimal bleeding, sent to endocrinology. But you, being really diligent, read the extended op report by the resident. And it says, peeling of the tumor off a superior pole of the kidney with a minor tear of the adrenal capsule and challenging removal in the morcellation bag. What would you have done differently? Oh, the answer in this case is many, many, many things, okay, is the answer. This really is the meat of the matter, and it's the workup of a new adrenal mass, which I discussed earlier. This part is about who do you refer a patient to, how do you operate, how do you read an op report, and how do you read a path report? And as endocrinologist, I urge you, with every surgery done on your patient, to read the detailed op report. I actually take the detailed op report and put it in my note in part of the HPI. The surgery report is in the note, as is the path report, of course, in the results section. But the op report is in the HPI, so everyone can see what the surgeon did. So, in recent guidelines that we've written, one, the NSAT A5 collaboration, the most recent one was the American Association of Medical Surgeons, that a bunch of us, me and Irina, I think, participated in this, is the following. Ideally, you need a surgeon who knows how to operate on the adrenal and it knows how to do an oncologic resection, number 1. High volume center. 2, complete en bloc resection, like a cancer. Even if you're not sure it's a cancer, like a cancer. If you're concerned about it, then do an oncologic resection. 3, open resection is the norm. Yes, there are some surgeons who will do a laparoscopic resection who have a lot of experience. It is an oncologic resection. Even almost all, not all, will still argue, as we wrote, as the guidelines were written, even by the surgeons in the last one, open resection when you think it's adrenal cancer. You have one shot. I have seen hundreds of cases of peritoneal carcinomatosis for a capsule that is torn. Hundreds. And they die miserable deaths. You have one chance. Lymph node resection is debated for the primary resection. Okay, so case 4. Question then becomes, the path report shows KI 67 of 7, 11 mitoses per 50 high power fields, vascular invasion, areas of necrosis, discontinuous capsule, danger right there. With cells in the periadrenal fat, margins are negative, but cells in the periadrenal fat. Remember, all the organs in your belly and your retroperitoneum are like garments in a closet. The garment is the capsule. Cells spill out of the garment bag, they're in the closet. They're in the abdominal cavity. So what is this? Well, this is an adrenal cancer. Okay? Adrenal cancer is diagnosed by the Weiss criteria. There's 9 criteria here. More than 3, so 4 criteria or more by definition, it's adrenal cancer. The most important ones are in the red boxes, which are mitoses greater than 5 per 50 high power field. That high power is 40x magnification. Vascular invasion, adenomas don't do that. They just don't. And adenomas never break the capsule. Those are the 3 most important. I'd give necrosis perhaps the 4th. Different than hemorrhage. Adenomas hemorrhage, they don't necrose. Okay. Says adrenal cancer. Okay. What aspect of the case, even without positive margins, oh, I gave you the answer already. results in a high risk of recurrence. Is it that it's non-functional and less differentiated, like most cancers? The less differentiated, the worse most cancers are. The large size, the level of mitosis, well, I gave you the answer, it's the capsule. Okay? So here's what we've learned about recurrence rates. Now, I remind you, a recurrence of a cancer is not a new cancer. And patients have to be told this all the time. The word is a misnomer. It is not a recurrence. It is, by definition, cells left behind at the time of surgery or predating surgery that when they grow big enough to see, we say, oh, you've recurred. No, they've always been there since the time of surgery or before it. So, what we've learned about prognosis, stage 3 disease, it's a risk. Stage 1, less than 5 centimeters. Stage 2, greater than 5. Stage 3, past the capsule. Stage 4, metastatic disease. Once you're past the capsule, high risk of recurrence. 2, grade of disease. Low grade, less than 20 mitoses. High grade, greater than 20, or Ki-10. I find this to be most important. Size, to me, not important. In this case, through the capsule is important, and a mitotic rate is incredibly important. These are high-grade patients that like to recur early and through the bloodstream. So high-grade ACC makes me very nervous, even when it's 3 centimeters. And then, interestingly enough, we'll get to it at the last slide, is cortisol production. It is a risk factor for recurrence for a number of reasons that I want you to think about while I'm showing other slides. And then we'll come to that at the end as to why cortisol is a bad prognostic sign, other than your body's in bad shape. There's a biological reason. Okay, so what is the recommended for this patient after the surgery is removed? After the tumor is removed, will you give mitotane, stereotactic brachyradiotherapy to the adrenal bed, surveillance, just watch the patient, or give them high-dose chemotherapy? So this is the case we would, first of all, think about radiating the patient, because there's been spillage at the tumor bed. This is a classic case where we would very likely radiate the adrenal bed to kill cells that we think are there, even though the pathologist said there's nothing, the margins are clear. I don't care. There's been spillage into the closet. Okay? So the first piece was, surgeon says, got everything, careful. Second, pathologist says, well, it's clear margins, be careful. Read the report and use your head about what it means to spill things in the closet. We'll get to mitotane in a minute. So we've published a bunch of papers on this, and indeed the guidelines now recommend or suggest, they suggest against routine use, but in cases like this where you have a stage 3 or an incomplete resection, we certainly radiate. So, a little nuance to what I said, okay? Because of the concern for tumor spillage. Okay, so after surgery, again, when there's no evidence of disease, the challenge remains risk stratification is still difficult to predict who might recur. I told you about stage 3 high-grade cortisol, but these are still really relatively, as you'll see now for the next part, relatively crude clinical measurements to predict who's going to recur. We need to do better than these simple clinical observations. We really need to know, who do we treat? And what do we give these patients, by the way, other than the radiation I just told you about? The ideal goal should be to treat early those with high risk of recurrence and avoid treatment of those who are at no risk. Now, those are the ends of a spectrum. No risk versus, yep, you're going to recur. How close can we get to those outcomes moving forward as we see our patients? I'm going to tell you. So that's what we use the term adjuvant therapy for, right? Treatment following surgical cure to kill cells that might be present. The challenge being they might not. Okay, so let's talk about that. Stage 1, 2, 3, and 4. We operate on stage 1, 2, and 3, usually when it's confined to the adrenal or even when it's stage 3. But as you'll see, that's about 50% of patients. 50% recur in stage 4 with metastatic disease. The problem is not this. Well, first of all, very few are diagnosed in stage 1. The problem is that even with complete resection, 60 to 70% of these patients recur. 60 to 70%. Okay? But not all. That means 30 to 40 don't. Who are you going to treat? Okay, so here's the problem. If you look at grades, that was stage. The 40% who recur, right? With grade, this is a great graph to show you a separation of two populations of patients, low grade, high grade. But let's use our heads for a minute. There are high grade patients who don't recur at all. They look just like low grade. And there's a high number of low grade patients that look exactly like high grade. This is a great stratification protocol for a paper. It stratifies two groups of patients. But for an individual patient, it's not very helpful. It gives you a little bit about risk stratification, but we need better than that because there are low-grade patients that recur in 3 months with metastases everywhere. They look like a high-grade patient. And high grades that don't recur, so we need to do better. There's marked heterogeneity in this group. So you can even use multiple different clinical scores. The S-GRAS, pioneered by Christina Ronke in Birmingham. This is great. Now you see 5 groups, but look at the marked heterogeneity. It's still helpful, but look at the marked heterogeneity within the groups. So I'm going to argue that it's time for genomics, and that we'd like to be able to stratify patients better, and don't treat patients who we think will almost never recur, and aggressively treat patients who we're pretty darn sure you're going to recur. This is going to be bad. So we've published about 4 papers on the pangenomics of adrenal cancer that gives us some clues. I'm just going to talk about one, which is the NCI-funded TCGA, cute name, the Cancer Genome Atlas, the 4 base pairs, nucleotides, of course, TCGA. And we're able to stratify patients into 3 groups. Okay, fine, 3 groups, a better outcome, a worse outcome, and a middle outcome. What I'm going to show you is, though, there's much less heterogeneity in this classification scheme, okay? As you'll see, because although we have a ton of genomic data, what we've learned is that the cluster 1 patient, I'll call them, low risk, they almost never recur. They still do, but almost never. The cluster 3 patients always recur 99% of the time within 24 months. So there you go. Close to nothing, close to everyone. That's really helpful because you're going to be, and then there's a middle group that is heterogeneous still. You got to think, all right, we have to think about this, present a tumor board, and think what your risk is. But you're much more comfortable now not treating that low-risk patient with anything, just watching them surveillance, and you're going to be much more comfortable aggressively going after that high-grade patient, okay, with therapy. So, case 5, 43-year-old, laparoscopic, 7.8 centimeter left, non-functional, stage 2, high grade, surgical path complete, capsular invasion, but no capsular breach. Capsule's intact, okay? What approach, if any, would you choose here? High grade is the buzzword here. So classically, it's been mitotane, the one drug approved for adrenal cancer. It's an adrenal agent. We use it, and it's been shown to be effective. We've used this for 30 years. It's the only approved drug in the world for adrenal cancer, okay? Difficult to dose, difficult to tolerate. Only 50% of patients achieve therapeutic levels over 12 weeks. Poor safety, tolerability, et cetera, et cetera. We use it, but a half-life of 159 days, right? It's lipophilic. Got to monitor blood levels, the whole bit, 2 to 5 years recommendation. Fine, it's used. But more nowadays, we're going towards for the high-risk patient, we're now starting to use chemotherapy, a cisplatin-based chemotherapy. Cisplatin and etoposide combination with mitotane, okay? Because we found in non-randomized studies that cisplatin-based therapy is much more effective than mitotane in all patients treated. But you don't want to treat that patient who's not going to recur, right? You want to treat the patient who's really high risk. So this is the Aduvio 2 trial, which is around a multi-institutional study where we're comparing mitotane only in the high-risk patients versus mitotane plus cisplatin-based chemotherapy on the assumption that the cisplatin is going to work better, okay? Okay. Case 6, 30-year-old female, ER, right side abdominal pain, no history of prior gallstones or menstrual irregularities, physical exam, a little bit tachycardic, hypertensive, gallbladder, appendix, and ovarian disease were ruled out, but a CT showed a 4.3 centimeter right adrenal mass. In the ER, she had some diarrhea, gastritis, and gastroenteritis was diagnosed. So she was just sent home. Endocrine consult in her community hospital suggested a hormone workup by her primary care. There was no evidence of hormone excess. She was referred to interventional radiology, and they biopsied it. They biopsied the lesion, and it showed SF1 positive tissue, okay? which just basically tells you it's adrenal cortical in nature because SF1 stains the adrenal cortex. That's all that tells you in hindsight. A laparoscopic resection is performed. Pathology shows a low-grade adrenal cancer. Should a biopsy have been performed? The answer is no. Basically, never biopsy a unilateral adrenal mass. That's what, ever. Certainly not a pheo. You don't need, and certainly not a functional adrenal cancer. But even a non-functional mass, you do not biopsy these. And try to convince your radiologic college, do not biopsy unilateral lesions. If you're nervous, what do? Take it out. Okay, so what are the indications for a biopsy of a solitary adrenal mass? To diagnose adrenal cancer? No. To diagnose a MET of existing non-adrenal cancer to the adrenal, or to rule out a pheo? Of course, it's B. The only reason is when someone has a pre-existing cancer or had one 6 months ago, and you're concerned, is this a new adrenal cancer or is it that disease? Now, quite frankly, breast cancer 2 years ago, or even 6 months ago, new adrenal mass, 50% of the chance it's going to be the breast cancer, but if that's all they have, nothing else on imaging, PET, etc., you don't need to biopsy it. You're still going to take it out. So solitary mass is only when they have multiple lesions and you don't know if it's the breast cancer that went to the lungs or a new adrenal cancer that went to the lungs or breast that went to the adrenal. Okay, 59-year-old, severe epigastric pain with sweating, 6 months of diaphoresis, new anxiety, hypertension, effectively treated though with monotherapy, but he's lost 30 kilograms. Melanoma excised 2 years ago. CAD in a brother, father died of coronary artery disease. Physical exam, markedly orthostatic, cachectic, bilateral masses are palpated. You feel bilateral masses on your exam, okay? CT shows bilateral adrenal masses. This is a trick case. Adrenal hormones are excluded. No hormone excess. Great. So should you do a biopsy now is the question. Now you do biopsy it? Bilateral mass? Trick question. No. You do not do an adrenal mass. You don't do a biopsy. Not yet. How about treat the patient? A bilateral disease, you have to think of both hormone excess and hormone deficiency. The patient's going to die in the ER. You have to treat this patient before you do anything. Okay, so treat the patient first. For what? For primary adrenal failure. With or without labs, you're going to treat this patient. No one should die in an ER with what looks like adrenal crisis without getting steroids. So you draw labs if you can. If you're thinking about it, you draw labs and treat the patient, wait for the labs to come back later. Okay. And the patient had primary adrenal failure. Okay. Now should a biopsy be performed after the pending adrenal crisis after you treat them? Now you do it. Now you refer them and biopsy the mass, because now it's a bilateral mass, you don't know where it is. Now you biopsy, non-functional bilateral mass. And so biopsy is rarely useful in unilateral masses, with the caveat I mentioned. It's usually helpful in bilateral masses, with a caveat. If you have bilateral masses with elevated cortisol, well, then it's either bilateral ACC, bilateral adenomas, or bilateral macronodular adrenal cortical hyperplasia, or PPNAD, primary pigmented adrenal cortical dysplasia. I mean, okay. Okay. 8. We're going to get done. 38-year-old female with a prior history of biliary leak and stent placement, 2 surgical repairs, status post chole, now status post open resection, 4.2 centimeter non-functional mass. Path report shows ACC with capsular invasion, no breach, negative, margins are negative, and 19 mitoses per 50, lymph nodes negative. C. Okay, let's say low-grade-ish. And then patient is followed, looks great. They're followed because they're in that category of low grade. We don't think they're going to recur at all, but I didn't say everyone does. I didn't say it was 100%. So you follow them. So she's followed, but then she's lost to follow-up 2 years later, comes in at 3 years with that solitary mass in the liver. Okay? It's not, an MRI is done, it's PET negative, and it's not foconodular hyperplasia or hemangioma in the liver. It's a solid mass. Let's assume it's ACC. What do? Well, this is when we take it out. This is when we don't treat with chemotherapy. This is a slow-growing ACC. Recurs 3 years later. This is when we do local therapies. You would take it out, okay? Or do chemoembolization with Y90, yttrium 90, or radioactive beads, perhaps. Won't go into detail there. Local therapies, as I mentioned. One more thing about local therapies. I said this earlier. We do not operate for hormonal control. Simply don't do that. We don't need to anymore, as I mentioned earlier. Okay? We also use local therapy for, like this patient, for, like I said, local oligometastatic disease recurring late, 9 to 12 months later. 30-year-old female, new hirsutism, acne, weight gain, amenorrhea, pretty classic. CT shows a non-lipid-rich 6-centimeter mass that I show you there. No hormone workup, but primary team says the chest CT is negative. Sent to general surgery, open resection. Path shows a fragmented mass, lymphovascular invasion, necrosis, margins negative, but extension into the fat, and it's high grade, 87 mitoses per 50. That's a lot. This is very high grade. This is where? It's over here. Right? And it's completely removed. High grade stage 3. Okay? 6 months later, Cushing's and androgen excess. And you see this. And this is what I see all the time in these high grades. You see labs that are consistent with cortisol and androgen, and you see that kind of CT scan. 3 to 6 months later. So this is classic high-grade ACC. The patient needs some therapy. This is the patient you're not going to give myetane to. You're going to give EDP, etoposide, doxorubicin, cisplatin, and myetane, and more frequently, usually second line, we're giving immunotherapies to these patients. Okay? Usually those second line. I'll talk about that in a minute. With glucocorticoid control, of course. So we resort to systemic therapies all the time in these patients, and when they're inoperable, myetane's classic one that everyone's used. It's not helpful in high-grade ACC. You need more than myetane. Okay, and I already talked about that. Its effectiveness is somewhere around 15% in all comers, usually low-grade. There's EDP in red over streptozocin and myetane. EDP plus myetane is about 23 to 30% effective. I'll give it 30 at best. But that's what we have. That's the best we've got. Okay? EDP. 25-year-old male, history of lymphoma as a child, family history of sarcoma in the uncle, father, lymphoma in the sister, diagnosed with 5.1, non-functional mass, lipid poor, resected, report says stage 2 low grade. Fantastic. So let's say you're done. That's not you're done. You're going to follow the patient. That's not the question. The question is, what genetic predisposition for adrenal neoplasia does this patient have? The answer is Li-Fraumeni. Li-Fraumeni is the most common mutation in ACC. Of course, the AIR mutation is adrenal failure. MEN2, of course, where you do see PHEOs, you don't see ACC. DAX1 mutations, congenital adrenal hypoplasia, and SHDB is a PHEO mutation. So it's Li-Fraumeni, which is the most common. And indeed, Li-Fraumeni is in about 11% of our adult patients have germline mutations in ACC, even without family history. Okay? In kids, it's about 80% of patients, the kids have Li-Fraumeni in some countries. Okay? The other one is Lynch syndrome, which is non-polypotic colon cancer. It occurs in about 3% of our patients with adrenal cancer. So every patient with ACC must be screened for these are germline mutations in Lynch and P53. Every patient. There's others that are really rare that we've found over the years that I'm not going to talk about. Okay. Turns out that most of the same genes here that are in the germline variant of adrenal cancer that are inherited are the same mutations you find in the sporadic adrenal cancer that's not germline. Okay. So that's the question. Can we exploit genomics to optimize treatment? And that's just the last number of slides here. We've been able to distill those clusters, those flavors, and the study for the NCI was like $20 million. The goal is you can't do that on a patient. How do you distill that down to clinical care? So what we've been able to do is distill the 3 flavors into biology first, and here's the biology. Okay? That takes months. The biology now, which only takes weeks, we learned that all 3 flavors are driven by the insulin growth factor pathway. The 2 more aggressive flavors are driven by another growth factor, the Wnt pathway, and the 3rd worst flavor is driven by cell cycle dysregulation. How does that help us? Well, we've been able to distill that into an overnight PCR assay that puts your patients in flavor 1, really well behaved, flavor 3, really bad, or this middle heterogeneous group. Why is that helpful? Because those are targetable biologies, right? So you can pre-select patients to be treated with these therapies. We're not as far as we are in thyroid with all the mutations and therapies, but we're getting closer in ACC, and that's how we'll end the talk. I'll show you. So that assay now, we're going to use it because it allows us to stratify these patients, and we'll focus particularly on that flavor 1, because flavor 1 is only driven by the IGF pathway. And there are drugs out there for the IGF pathway. So we turned this assay into a patent and got 2 patents for it, one for diagnostics stratification, and the other would be for treatment. And I'm going to show you what this drug does. That shows you a patient on the right with metastatic disease, low grade, but metastatic, treated with an IGF inhibitor with a complete resolution of lung mass after failure on EDP. This is about 20% of patients have this biology of cluster 1. We've done 3 trials, a phase 1, a phase 2, and a phase 3, and the drug works. But who's it working? These trials were in all comers. Just all patients who failed EDP were given this drug. So who did it work in? Well, there's the responders on this is a placebo-controlled trial. So these are under the x-axis are those who responded. What I want to show you here in the last couple slides are when we finally tested these patients with that new assay, all the patients who were responders were the IGF only, and the non-responders all had the other mutations, cluster 2 and 3. So that's really helpful because then you could pre-select patients for treatment with an inhibitor like in thyroid cancer, okay? So we founded a company, and we'll talk about that some other day. Cluster 2 is targetable. There are drugs out there being developed by companies for the Wnt pathway. Iterion's one of them, and we've proven it works in preclinical models. And so we hope to test that again. The last flavor is the most interesting. Back to my first statement about cortisol excess in ACC to close the talk. And we have 10 minutes for Q&A. The last flavor is the most difficult because it's got IGF mutations, it's got Wnt problems, and it's got massive cell cycle upregulation. Dangerous disease. What we learned about this flavor is not only is it the most aggressive, it makes the most cortisol. Okay? So it makes cortisol as well, and these are the patients who die. Highest mutational burden as well. Poorest survival. So you know that immunotherapy was approved for those patients with high mutations, who are PD-L1 positive, high mutational burden, MSI, microsatellite unstable, right? A lot of mutations. And almost all cancers follow this rule. Higher the mutation, higher the immune infiltration, the better they respond to immunotherapy. Well, what's weird about adrenal cancer is plenty of mutations, particularly in flavor 3, right? This is all cancers on the bottom. ACC is a cancer type with plenty of mutations, from low on this side to high on the right side. But it has no immune cells in it. Adrenal cancer is the most paucity immune cancer there is, other than uveal melanoma, because immune cells can't get into the eye. So why is that? So we were puzzled for a while until we started thinking like endocrinologists. First of all, it's the reverse. The higher the mutation, the less immune cells in adrenal cancer. It makes no sense until you start thinking like an endocrinologist. Because I just told you, it is the highest mutated cancers that have what? The most cortisol. And as you know, cortisol blocks T-cell infiltration. Nobel Prize 1950, what did it do? It blocked T-cells. So adrenal cancer is tricky. It's using intratumoral cortisol as its immune evasion mechanism. So that's a problem. Well, it's a problem unless you can treat the patient. This is why, although this trial is finished, that's why Corcept tried to block cortisol action in the tumors with a GR antagonist with immunotherapy, and the trial is done. I don't think it's out in public yet, but I don't think their approach worked for reasons I won't go into. It's really important in ACC is the bottom line, is to decrease intratumoral cortisol to optimize immunotherapy. If you've got a Cushing's ACC, you must get the cortisol down to use the immunotherapy. This is the time, particularly, I would use the block and replace strategy. Get their cortisol to 0, because why? You want to block the tumor from making cortisol, and then give them back just enough cortisol so they can stay alive. So immunotherapy works. Get rid of the intratumoral cortisol. Don't block glucocorticoid receptor action everywhere. No. Give them a steroid inhibitor, give them cortisol back. So my thought is that's the end. My hope is that, one, we went through some cases that went through the challenges we're having with diagnosis, prognosis, and management. And then I gave you a little whisper of what's evolving in terms of genomic analysis and upcoming new targeted therapies for ACC. So I hope that was helpful, and we have about 10 minutes for Q&A, I think, or 5 minutes, and I'm happy to take some questions. Remembering, of course, the 4 most common things we think about in adrenal nodules, and they're very common. and that they can be anything, but importantly, you're the gatekeeper. We as endocrinologists are the gatekeeper for these diseases to get the right therapies to the right patient at the right time. And I would argue that progress is iterative, okay? Discovery is iterative, and optimizing care is iterative. But if we keep our goals in the best science, ground our questions in the best science, and ground our goals always in the best patient care, if I can go back to that, we'll never go wrong, okay? So with that, I'll close, and I thank you for your attention.
Thank you for the wonderful presentation. May we please request you to take a seat on the dais, Dr. Gary? Yeah. So this is indeed a wonderful presentation discussing the need for early diagnosis, appropriate management. You also highlighted the practice gaps and the emerging therapies and the management of ACC. Thank you once again. You mentioned about it's actually a very rare disease and a difficult to treat disease for many endocrinologists in India. You mentioned about the collaboration with Indian experts. Can you please elaborate on this?
The question really is, one, how do we collaborate and who do we collaborate with? I've certainly worked with Nalini a bit over the years. It's difficult to collaborate with true patient care, but we've certainly shared expertise, which I think is that's number one. I think we all must share our expertise with each other and learn from our own clinical experience and share that. I think that's number one. I think in terms of ACC care in general, it has to be multidisciplinary. Ideally, you are seeing patients in the same room at the same time with a surgeon and oncologist like we are able to do. That's oftentimes impossible to do, so you must have open communication, and your colleagues must be willing to collaborate with you. Some endocrinologists are very comfortable with mitotane. Some oncologists demand that they follow and use mitotane. My argument's usually been that endocrinologists know a little bit more about mitotane and what it's doing to the normal adrenal. Mitotane does, of course, inhibit the normal adrenal, thyroid, and gonadal axis that needs endocrinologic care. So communication is most important, is all I'd say. Ideally, you at least have a tumor board like some of your groups have, where you meet together with the other specialists to discuss the cases. Ideally, it's on the same day you're seeing the patient. Those kind of cooperative arrangements are difficult, but they are the ideal goal to reach for.
Do you have any questions? Quick comments or questions?
You said that you use radiation therapy in some patients. To the best of our knowledge, in these cancers are relatively radio-resistant. Is that true?
We have not found that. We have not found that. We often are radiating solitary mets, particularly to the bone, and preventing their spread and preventing their growth. So we've had quite success with SBRT for these lesions. In terms of the adjuvant setting, the two trials we did most recently was still 8 years ago. The study would argue that not only when compared to those who didn't get radiation, that it prevents local recurrence and even prevented distant recurrence from whatever was left in the adrenal bed. So but there's only been about 5 studies, one from MD Anderson, one from Martin Fosstein in Germany, and 2 from University of Michigan.
Yeah, you keep it there.
So other than EDB plus mitotane and immunotherapy, do you use any other therapy like gemcitabine, capecitabine? And if that is being used, is it found to be effective?
It's a good question. So we do not use capecitabine like in some of the other endocrine cancers. We have used gemcitabine and Taxotere, docetaxel, before with some benefit, but it's diminishing returns. EDP 50%, 30%, immunotherapy 30%. The IGF inhibitors, if they ever get approved, 30%. Now, there are IGF inhibitors out there in the world, maybe not here. Teprotumumab for thyroid eye disease and lincitinib, which we had used in our studies, are being evaluated. Gemcitabine and Taxotere, it's still 10% or less of effectiveness, but it's third line. But we have not used, you said capecitabine and yeah.
So because immunotherapy is quite expensive, so we need something in between after EDP and mitotane.
Well, I'll tell you what we do after EDP and mitotane.
After EDP and mitotane, because most of the patients progress even after that.
Immunotherapy is usually our second line. The other drug, which we're adding to immunotherapy quite a bit these days, and even by itself, has shown some remarkable effects. I don't have numbers for you, is a multi-TKI. So cabozantinib is our favorite. Lenvatinib you can use as another multi-TKI. We've had much more experience with cabozantinib.
But with that, we need to stop mitotane.
Yes, great question. So cabozantinib is metabolized by mitotane. As Martin Foshnock has shown, even a mitotane that is 2 milligrams per liter is enough to activate CYP3A and just degrade capecitabine excessively. So we're looking for a mitotane less than 1. The problem is a half-life of 159 days. So we're getting a little more cautious with using mitotane if I'm concerned about recurrence after EDP.
Usually the patients are on mitotane and it will take lots of time for the effect to go off.
So more and more, this is more nuanced. We're using EDP alone without mitotane. So if we need to switch to immunotherapy, we can quickly. And if we need to add cabozantinib, we can do so quickly. We usually use cabo in combination with immunotherapy, not by itself. But you can consider cabo or lenvatinib by itself before immunotherapy. But usually it's immunotherapy first, then cabo we find as added benefit.
And in our X resection, and if the patient is having Ki-67 more than 50%, have you ever used prophylactic along with mitotane E plus P therapy?
EDP, did you say?
EDP.
Yes, that's what I was actually referring to. I know many slides. But indeed, what we are doing now for the high-grade patient with a Ki-67, if it's greater than 15, sure, we like mitotic counts better in Michigan, but mitotane count greater than 20 even. We're going to cisplatin and etoposide.
Yes.
I had a slide on that, but I was a little too fast. We're using that now only for the high-grade patient. That's the Aduvio 2 trial where we're comparing mitotane versus mitotane plus cisplatin and etoposide. But many of us are just going right to that without the trial because patients they hear the data and they hear us talk about it. We want to do a trial, but they're demanding be aggressive if you can. And so many of us are doing that.
Thank you.
Thank you very much. I think we had a wonderful session. Thank you, Dr. Gary Hammer. I hope he's available to take a few more questions if necessary off the dais. So we hand over to the organizers for the next session, and I thank Dr. Maithil as well. Thank you very much.
Thank you, sir. Next, we have orations. And may I call Secretary ESI, Dr. K.V.S. Harikumar, sir, to conduct the session.
Good morning, everybody, and welcome to ASICON 2025. We move to one of the most important part of the ASICON, the orations. For the first oration, which is named after Professor Subhash Mukherjee, has got a lot of connect to this place and a lot of research of this place. And he had a, I would say, unfortunate ending, despite his brilliance before the time. MBBS from Calcutta National Medical College and PhD from Science College, University of Calcutta in Reproductive Physiology, and second PhD from University of Edinburgh. And to give the Professor Subhash Mukherjee oration, may I call upon Dr. R.V. Jayakumar sir and Dr. G.R. Sridhar sir onto the stage, please. Please welcome both the past presidents of ESI. Please give them a round of applause. And Professor Subhash Mukherjee's oration of 2025 is awarded to Professor Rama Walia from PGIMR. She has not only papers to her credit, she has patents to her credit. Welcome, Professor ma'am, onto the stage, please. I request the chairpersons to please, ma'am, please. I request the chairpersons to please felicitate the orator and then she'll have the talk. I request the chairpersons to introduce the speaker and she'll start. Thank you.
A very good morning to one and all of you, and welcome to the first oration of SECON 2025. I'm very glad that we have got a very good speaker to start the oration, and it is Dr. Rama Walia. She has done her DM in endocrinology, and she is at present the additional professor in the Department of Endocrinology at PGA Chandigarh, and she has got academic and clinical achievements in many awards, and she did the 2019 PN-Shaw oration, and her main topic is in the neuroendocrinology imaging field. And she has got a lot of publication in international journal, and she's being internationally quoted as an authority in the field of this imaging technology, the nuclear medicine or isotope imaging of pituitary for making the diagnosis of pituitary disorders. And with these few words, I welcome and invite Dr. Rama Walia to give the oration, and I give the mic to Dr. Sridhar.
It's a twin opportunity. I heard of Dr. Mukherjee from an article in Current Science. And second is Dr. Walia is following a good tradition. Professor Jaikumar is also one of the earliest alumni of PGA Chandigarh. And it's a privilege to be able to listen to what Dr. Rama Walia has to say.
Thank you, sir. I feel privileged to receive Dr. Subhash Mukherjee oration, and I'm deeply grateful for Endocrine Society for giving me this oration. So today we'll discuss navigating hypogonadotropic hypogonadism in boys, a clinician's roadmap for effective management. So I'll start with a case, 14-year-old boy with chief complaints of short phallic length, delayed puberty, no family history of delayed puberty, no anosmia. On examination, height age 12 years, weight age 12 years, no midline defects, Tanner staging, axillary hair present, P2, testicular volume 2 ml each side, SPL 4.5 centimeter, and bone age of 11 years. So with this clinical picture, what comes to our mind is self-limited delayed puberty, but still we need to confirm many a times. This is a straightforward case, but still many a times there is issues and we need to work them up. So when do we call delayed puberty in boys? It's lack of pubertal development by an age that is 2.5 STs beyond the population mean, and for boys it is more than 14 years. The common causes of delayed puberty, the most common cause is self-limited delayed puberty, that is CDGP, hypergonadotropic hypogonadism, hypo-hypo, and functional hypo-hypo. So hyper-hypo is very easy to diagnose. LH-FSH is high and T is low, so we do not face any problem. If it is functional due to systemic disease, then systemic disease is usually evident prior to the patient comes to us with hypo-hypo. The problem comes to differentiate between self-limited delayed puberty and congenital hypo-hypo. So where both LH, FSH, T, and all the three are low in both the disorders. Why do we need to differentiate? Let us wait for some more time and let the patient develop and grow further. But it leads to psychological stress. And we also need appropriate treatment of the underlying cause like systemic disease or pituitary tumor with which the patient may come. And we also need to start treatment at appropriate age to mimic normal puberty to opt for optimal somatic maturation, that is height, bone mass, and secondary sexual characteristics. So to do that, we need to differentiate these two disorders at the earliest. Coming to diagnostic protocol, these are the typical clinical features which are textbook written, that how to differentiate SLDP from congenital hypo-hypo. So growth failure and delayed puberty is SLDP. No growth failure, only delayed puberty, it is hypo-hypo. But during puberty, again, there is lack of pubertal spurt, so that might be confusing between hypo-hypo and SLDP. Family history of late bloomers is definitely there in SLDP, but even in hypo-hypo, there can be familial clustering. Neonatal manifestations like micropenis, Cryptorchidism and midline defects are part and parcel of IHH. Anosmia, hyposmia, neuroskeletal abnormalities may be present in congenital hypo-hypo. PBAC is delayed in SLDP because its somatic maturation is altogether delayed while it is present in congenital hypo-hypo. Testicular volume of more than equal to 3 ml is actually suggestive of SLDP, and if it is not there in congenital IHH. However, in partial hypo-hypo, PV can be more than 3 ml. Bone age of more than 12 to 12.5 years is very unlikely in SLDP because by the time the bone age becomes more than 12 to 12.5 years, the child will enter into puberty if it's a simple case of SLDP. While bone age of more than 12 years is usually seen in IHH without progression of puberty. So this is clinical testicular volume of 3 ml. This is a study where we did the correlation of clinical testicular volume with ultrasound testicular volume. So if we use ellipsoid formula, then testicular volume of 1.1 ml and with Lambert's formula 1.5 ml serves as a USG diagnostic parameter for defining congenital hypo-hypo. Coming to endocrine evaluation, so bone age, basal hormones, which include LH, FSH, testosterone, estradiol, inhibin B, prolactin, and TFT, and dynamic test. If we talk about basal gonadotropins, these are very useful. People have done multiple studies on these. Because the rise is mainly nocturnal and it is pulsatile, so people went ahead and did LH pulses, and they found that it has a good sensitivity and specificity. However, this is cumbersome. They also looked at basal LH value, and LH more than 0.6 by IFMA, again suggested it is hypo-hypo. People also did study on basal FSH. If it is less than 1.2, it is SLDP. However, FSH was ignored and not routinely used to differentiate SLDP from hypo-hypo. Then this is the usual cutoff of LH less than 0.3, which is by ACLIA, which has a good sensitivity and specificity to say the patient is having hypo-hypo. So coming to after basal LH FSH, basal inhibin B, there are various cutoffs varying from 35 to 110. So if it is less than 35, it is likely to be hypo-hypo. If it is more than 110, it is likely to be SLDP. However, there is a broad gray zone. So this is the last is our study in which basal inhibin B of more than 80 had almost 80% sensitivity and 96% specificity to say that it is SLDP. We also did inhibin B post-testosterone priming. I'll come to this part that what is testosterone priming. And then a cutoff of more than 94 picogram per ml, I had 100% sensitivity and specificity to differentiate SLDP from hypo-hypo. So why do we require dynamic testing? So one reason is that all the secretions are pulsatile. So we may not pick up the pulse at appropriate time. Then hypothalamo-pituitary gonadal axis is first to activate nocturnally. With dynamic testing, we are evaluating the potential for maximal functioning of the gland, and stimulability is directly proportional to cumulative priming. Who is the appropriate candidate for dynamic testing? All subjects with basal levels in gray zone, and basal levels and clinical picture not correlating. The conventional dynamic tests include GnRH stimulation test. GnRH is currently not available. GnRH analog stimulation test, HCG stimulation test, and recent include post-testosterone priming, hormone levels, kisspeptin stimulation test, GnRH agonist stimulated inhibin B, and FSH stimulated inhibin B. So this is GnRH stimulated LH. Again, we can see the number of the subjects are limited, and the pros are that it is easily available, short duration, there is no hospitalization required, but different cutoffs by different studies despite the same protocol. And there is a great degree of overlap zone, and with a sensitivity and specificity of almost 75%. So in nutshell, we can say if basal is more than 0.3 LH and stimulated more than 14 by triptorelin, it is SLDP. If it is less than 3 and stimulated is less than 8, it is hypo-hypo, and in between is equivocal. Logically, in case of discrepancy between basal and stimulated values, then we have to interpret the test as per stimulated value. This is for leuprolide. Here the cutoff is more than 6 and less than 2.8 to differentiate SLDP from hypo-hypo, and in between is a gray zone. Coming to HCG stimulation test, this is further downgrade from GNRS stimulation test, and it actually tests the priming of testes to the ongoing LH. So it has a very good specificity. If it is stimulable, we are sure that it is SLDP. However, the negative predictive value is poor. It's lengthy and cumbersome, so hardly done. Coming to our case, the basal LH was 0.1 and triptorelin stimulated LH was 10 in gray zone. So what else can we do? Can we look at inhibin B values? Basal and stimulated inhibin B in pubertal disorder. This paper was published by, part of Shakun's thesis. So conventional thinking is that LH regulates onset of puberty. It's a gate for onset of puberty. LH rises first and FSH follows LH. And historical concept that prepubertal FSH is more than LH. But, and that is by default. It is not useful, it's just that it is under-controlled by the hypothalamus. But the current concept is that this FSH is not by default, it is by design. It is actually required for optimal testicular growth. So prepubertal FSH is more than LH, and FSH is required for Sertoli cell division, which occurs prior to rise in LH. Once LH rises, there is increase in intertesticular testosterone, which leads to differentiation of Sertoli cells, and these cannot further divide. Once intertesticular testosterone rises, there is decrease in AMH and further rise in inhibin B. So we just wanted to say, can we stimulate inhibin B with something? So we tried to get it done by giving exogenous FSH. So in this, we gave FSH from outside and looked at whether inhibin B responds to FSH from outside and whether the response comes earlier than GnRH stimulated LH. So we can see that there are in patients with spontaneous puberty, the level of basal inhibin B is higher, and FSH stimulating inhibin B is further higher. So this is stimulated inhibin B, FSH stimulated inhibin B in patients with spontaneous puberty, and this is in hypogonadotropic hypogonadism. So there is marked difference between these two without significant overlap zone. So the patient with spontaneous puberty showed a significant increment in inhibin B after FSH, and this was present prior to GnRH stimulated LH, which I call it as GnRH LH, and it outperformed all other tests like GnRH LH and basal hormone levels for differentiating CDGP from hypo-hypo. Non-stimulability of inhibin B in hypo-hypo is possibly due to lack of FSH priming in the prepubertal period, and also due to lack of mini-puberty. So this FSH stimulated inhibin B outperformed with a sensitivity and specificity and PPV and NPV of 100%. So is there a shortcut? Because this is again a prolonged test. We just wanted to see whether inhibin B is stimulable or not. So this was where we used GnRH to stimulate inhibin B. And again, this had a better sensitivity and specificity as compared to GnRH. GnRH had a sensitivity, GnRH LH had a sensitivity of 50% and specificity of 100%, while GnRH RB had a sensitivity of 90% with a specificity of 100%. So this is a shortcut from FSH-IB that we can also do GnRH stimulated inhibin B. So in the same patient where stimulated LH was 10, we went ahead and did GnRH-IB. It was again low. However, FSH stimulated inhibin B was 130 picogram per ml, so it was suggestive of self-limited delayed puberty. Is there a shortcut that we may not do all these stimulation tests and is an easier way out? This paper was published long back in 2017. Here what we did, the patients who came with for differential diagnosis of SLTP from hypo, we gave them testosterone 50 to 100 milligram IM monthly for 3 months and then withdrew it. And this withdrawal was similar to what happens in congenital adrenal hyperplasia once we treat them. So it kickstarts puberty in them, and there was no undue bone age advancement because of these 3 testosterone injections. So in this, what we found that if the patient is having delayed puberty and the results are not favoring either CDGP or hypo, we can give testosterone, redo the basal test, and if required, the stimulation test. Then almost all the patients can be either categorized into SLTP or hypo. So this way, we can come to a conclusion whether the patient is having SLTP or hypo. So if the patient is having hypo, then how to treat these patients? This was a case which I saw yesterday, 27-year-old boy with poor secondary sexual characteristics, LH, FSH, and testosterone were low. TB was 2 ml. He had classical synkinesia. So once we treat such patients, then we have either testosterone therapy or gonadotropin therapy. Testosterone therapy is required for secondary sexual characteristics, linear growth, somatic maturation, and psychosocial development, while gonadotropin therapy is required for fertility. If we compare these two, testosterone therapy can be easily titrated and be continued over 2 to 3 years and is economical, while gonadotropin therapy is a bit difficult to titrate. Testosterone therapy leads to fewer injections, while gonadotropins, it's multiple injections. T therapy, only secondary sexual characteristics are there, no spermatogenesis, while gonadotropin therapy is complete with SSCs and spontaneous spermatogenesis. Compliance, of course, is better with T therapy and poor with gonadotropin therapy. And in testosterone therapy, the T normalizes as per our schedule, the way we increase testosterone, the amount of testosterone being given from outside. While in gonadotropin therapy, it depends the response rate of testes to HCG. So T normalization takes longer time. Coming to when to initiate therapy, how to use and how to monitor. So it should not be later than 13 to 14 years if we are sure of the diagnosis. Which regime to use and how to use. The dictum is that whenever we are treating with exogenous hormone therapy, we should try to mimic normal physiology. So should it be HCG followed by FSH or FSH followed by HCG, or dual therapy to begin with, or triple therapy with HCG, FSH, and testosterone? Coming to all HCG therapy first, is it sufficient? It is only in partial hypo or post-pubertal hypo where testicular volume is already 4 to 6 ml. There we can go for HCG therapy alone, otherwise it should not be used. Coming to piggyback or sequential therapy, where either HCG is followed by FSH or FSH is followed by HCG. So as I've already discussed, that FSH in prepubertal time is not by default, it is by design. FSH is actually required during the prepubertal time. It is not that LH rises first, but it was being used earlier because it was thought of that LH rises first, and HCG alone is sufficient in some cases. HCG is available at 1/3 of the cost of FSH. However, it is totally non-physiological, and actually a premature HCG-driven increase in intertesticular T will lead to differentiation of Sertoli cells and will prevent their further increase in Sertoli cell mass with FSH. So coming to FSH followed by HCG, the rationale is it is truly physiological. And coming to evidences so far, if we see here, in the prepubertal period is not quiescent, there is increase in testicular volume, and that is because of the FSH which is there. And FSH actually rises prior to LH during puberty. And a rising intertesticular T is accompanied by a declining AMH and differentiation of Sertoli cell. AMH is a product of immature Sertoli cells. A rising inhibin B is a combination of, because of rising FSH and rising intertesticular testosterone along with declining AMH. So FSH rise is definitely prior. This was a study which actually said that we can use FSH first therapy. So if we use FSH first therapy in the upper graph, we can see that there is increase in inhibin B. There is doubling of testicular volume, and there was a trend towards higher maximal sperm count. And there was increase in Sertoli cell proliferation and spermatogonia migration to basal membrane. However, when we compared FSH first therapy for 3 months prior to initiating HCG and FSH combination therapy, we actually found that the time to spermatogenesis was 15 months in FSH first therapy as compared to when we started combination therapy to begin with. So actually the 3 months of FSH therapy was adding to the treatment duration. So we stopped using FSH first therapy and actually started combination therapy along with. So coming to HCG and FSH combination therapy, so it alleviates the concern of premature exposure of Sertoli cells to intertesticular testosterone, and it almost is invariably required in patients with congenital hypo, so why not to begin with? However, again, HCG takes time. The virilization is delayed, and HCG doses to be used are very high. So and for intertesticular T, we need a very low dose of LH or HCG to produce intertesticular T. So we thought of why not to give low dose HCG along with testosterone from outside because it doesn't cross blood-brain barrier, and FSH. So because it improves virilization with exogenous T, and in hypo, in any case, there is no endogenous LH that there will be any suppression of LH by exogenous T. That can only happen in partial hypo, where this therapy is not required. And it is very cost effective. So in this study, we started HCG with very low dose, 500 IU thrice per week, and gradually increased to maximum of 5,000 thrice per week in three divided doses, and monitoring AMH. Higher doses rarely required. FSH dose was 75 to 300 IU subcute thrice per week, and levels maintained between 4 to 8 IU per liter. Testosterone was 50 to 100 milligram every 2 weekly IM, and dose titrated to target nadir T more than 9 nanomoles per liter. Usually we say that prior testosterone therapy harms further spermatogenesis. So in this, we were giving actually testosterone therapy along with HCG and FSH. So is there any evidence to use that? So majority of the meta-analysis and systemic reviews refute the detrimental effect of prior testosterone therapy on future spermatogenesis. Actually, it is a function of time. So if we are giving testosterone therapy prior, then actually we are delaying the start of gonadotropin therapy. It is not that the prior testosterone therapy is harming, it is a delay in start of gonadotropin therapy. So we should start gonadotropin therapy at the earliest opportunity. So this is the effect of prior T therapy on fertility, and it is usually not a predictor. The predictor of response actually are the testicular volume and non-cryptorchid testis, which better predicts spermatogenesis rather than prior testosterone therapy. One study from KEM actually showed that prior T might be harmful, but then the HCG doses protocol use was different in both the arms, so possibly that played a role. So coming to how do we monitor, so there are two compartments in the testis. One is Sertoli cell compartment and one is Leydig cell compartment. So clinically, Sertoli cell compartment monitoring is with testicular volume. And although clinical has a poor correlation with ultrasound base, but then we cannot do ultrasound every time. So that is only done at baseline and 3 monthly. So clinical testicular volume assessment is a very good surrogate for Sertoli cell compartment. And for Leydig cell compartment, clinically we can look at the progression of acquisition of secondary sexual characteristics. Biochemically, for Sertoli cell compartment, is serum FSH levels, serum inhibin levels, and semen analysis. So serum FSH levels we need to maintain between 4 to 8 milli-IU per ml at 24 hours after subcute injection. Serum inhibin B is best correlate with sperm counts. However, there are assay issues, and less than 136 picogram per ml actually say that we are unlikely to retrieve sperms, and semen analysis is almost equivalent to liquid biopsy. Coming to Leydig compartment, so it's based by serum testosterone levels, and if we are starting therapy at less than 18 years and the height is incomplete, so we have to titrate it over 2 to 3 years, while if we are starting more than 18 when we are not bothered about height, we can titrate over 3 to 6 months. Serum AMH levels are actually a surrogate marker of development of Leydig cell compartment and production of intratesticular T. So decline in levels is earlier than rise in systemic testosterone, and this we can use to titrate HCG therapy. It is useful only in first 3 to 6 months when AMH is declining. Once it has come to less than 6.9, then we need to monitor it with serum testosterone per se. And of course, we can use ultrasound testes. So for monitoring, we do testicular volume at every visit clinically, FSH at 6 weeks, and whenever we titrate, serum inhibin B at 3 months after initiation and then 3 monthly. Semen analysis, first analysis whenever the patient is able to ejaculate, and subsequently 3 monthly. AMH 6 weekly, and this is we use for titration of HCG doses. And serum testosterone 6 weekly, and ultrasound testicular volume 3 monthly. What are the predictors of response? The most consistent predictors are baseline testicular volume, pubertal status, and absent cryptorchidism. Not a predictor include prior testosterone therapy, etiology, or genetics. And potential predictors are age, basal and peak inhibin B, AMH, duration of therapy. So from our study, age lesser than 24 years was a better predictor, and basal inhibin B more than 26. While on follow-up, longer duration of therapy, lower AMH, that is less than 6.9 nanogram per ml, higher percentage fall of AMH from baseline, higher testosterone, this is endogenous testosterone, of more than 6.96 nanomoles per liter, and inhibin B more than 92 picogram per ml predicted successful spermatogenesis. So in this study, we found that the minimum HCG dose required was 3500 IU. So we said that why to waste time for initially building up this therapy. So we went ahead and did another study, which is yet to be published. So here we used HCG doses starting with 2000 IU twice per week, FSH as per the previous study, and along with testosterone. Second group was HCG and FSH, and third group was the conventional HCG followed by FSH. So if we see in the first group where we used the triple therapy, there the dose of HCG required was 6,000, while in other two groups the HCG was required, the mean dose was around 10,000. And the response rate between the first two groups was comparable, while in which we used HCG first, the response happened at 15 months. But here still another important thing is that most of our patients are getting spermatogenesis between 12 to 15 months, which is much, much earlier than what the literature says of 2 to 3 years. So the response, and almost more than 90% actually respond within this time. And some of the patients who do not respond, they also respond by 24 months. So the most important is, along with spermatogenesis, in the patients who are on triple therapy, their body hair score is much better, and they are much more satisfied with the therapy, and we are able to retain them better. If they are on only HCG and FSH, they actually stop treatment because we stop their testosterone, they feel actually bad, and we are not able to continue therapy. So in 2017, I first collected the data. The response rate at our center was only 30% because most of the patients were lost to follow-up. They were not having adequate testosterone levels, so they didn't want to continue gonadotropin therapy. With this therapy, our retention rate is almost 100% because they feel good with the testosterone therapy. So this is the response within 1 year of testosterone therapy, while if we are not using triple therapy, only HCG, then the facial hair doesn't come within 1 year. So in view of the limited evidence of comparing regime and more severe the hypogonadism, more vigorous should be the approach. So if TV is less than 4 ml versus more than 4 ml. So less than 4 ml, it's severe hypogonadotropic hypogonadism. FSH and HCG therapy is the standard. Triple therapy is rewarding and combined is much, much better than sequential. If it is more than 4 ml, it's a milder spectrum. HCG monotherapy can be tried. However, FSH and HCG therapy is standard. So differential diagnosis of delayed puberty is simple. Gonadotropin therapy is effective in inducing spermatogenesis. Almost everyone responds. HCG, FSH, and testosterone combination therapy is required in most of the patients and is very rewarding. FSH priming prolongs the treatment duration without any clinical advantage, so we have stopped using it. Predictors of response include testicular volume, spontaneous pubertal development, absence of cryptorchidism, inhibin B, AMH, age, and duration of therapy. Thank you.
Thank you, Dr. Ramavalia, for the excellent presentation and excellent oration. And as you know, there is no questions for orations. So I hand over the mic to Dr. Sridhar for winding up.
We've seen a remarkable performance, remarkable for being majestic and at the same time modest. She's used a clinical hook to get the clinicians' attention. And she put together her publications, a series of impressive publications from JCM to buttress how the articles of JCM can be applied in clinical practice. And more than that, she completed her lecture half a minute before the allotted time. All in all, a remarkable performance to a remarkable audience. Congratulations and thank you.
Thank you, sir.
Thank you, sir. We move to the next oration, Professor P.N. Shah oration. To give away the Professor P.N. Shah oration, may I call upon Professor Shubhankar Chaudhary and Dr. M.V. Muralidharan sir onto the stage, please. Again, both are past presidents and needs no introduction for this audience. And Professor P.N. Shah was one of the founder members of the society. He's been leading researcher. And this is also the oldest oration of the Endocrine Society of India. And Professor P.N. Shah's oration for the year 2025 has been awarded to Professor Pinaki Datta from PJMR, Professor of Endocrinology. May I welcome Professor Pinaki onto the stage, please. I request the chairpersons to please introduce the speaker and then we'll move up the oration.
Good morning, gentlemen. I am indeed thankful to the West Bengal Society of Endocrinology and the Scientific Committee of Endocrine Society of India for giving me the opportunity to chair this session, the P.N. Shah oration. He was my examiner for DM in PGI in 1977. And I have contact with him for a number of years after this event. And the oration will be delivered by Dr. Pinaki Datta, presently in PGI Chandigarh. I see him probably every week during the morning meeting, Saturday seminar. And he will be telling you about precision endocrinology and the use of various methods or platforms that is used for the practice of precision endocrinology. Nowadays, treatment are precision-based. You give an intervention based on evidences, and he will be covering the various aspects of precision endocrinology, the genomics, metabolomics, proteomics, all these things he will be covering in his oration. Thank you very much. Dr. Pinaki Datta, please.
Yes, a very good morning to the august audience. So happy Teachers' Day to all of you, my senior faculty members. I am directly or indirectly taught by all of you. And whatever I am going to present is not only my work actually, it is work of almost hundreds of residents or clinical fellows and my PhD students who have worked with me. So welcome to the City of Joy of Dominic Lapierre, and he also wrote the famous story, or you can say the novel, The Freedom at Midnight, which is very close to the heart of Pandit Jawaharlal Nehru, our first Prime Minister. So I'm going to show you a picture, which is actually treasured memory of a, you can say, the years gone by. And it was in 1974, Asia Oceania Congress of Endocrinology, which happened at Chandigarh. And you can see in the center, it is my mentor, Professor Radharaman Jivandas. On the left side, it is Professor P.N. Shah, and the other one, right side, is Professor Rosalind Yalow. Before she got her Nobel Prize in Physics and Medicine in 1977, actually, you can say in one word, actually, Guni chine guniya, suna chine baniya. The goldsmith can only understand which is pure gold, actually, so they can understand who is the original person. And the lady who changed the whole history of the modern medicine, actually, they invited her before she got the Nobel Prize. They knew that she is the lady who has potential to rise, and with all odds, actually, she was in the University of Illinois. Amongst all 400 male members, she was the only female member. And so gender equality is very, very important for us. So coming to multiomics in precision medicine, multiomics means to gain comprehensive, holistic, and understanding of an individual's health and disease by integrating multiple layers of biological data, which includes radiomic, genomic, transcriptomic, proteomic, and phosphoproteomic, metabolomic, which combinedly constitute system biology. So my introduction to this field was by late Professor Kanchan Mukherjee, who is no more in this world. I'll show in the actually last slide what he did for me. So utility of radiomics. Most of the pituitary adenomas, you cannot tell whether it is a functioning adenoma unless it is a clinically active disease like Cushing syndrome, prolactinoma, or acromegaly. But rarely, by showing you a picture of a pituitary adenoma, if there is associated aneurysm, you can say this is more likely to be an acromegaly, only based on the imaging. Pituitary adenoma with T2 hyperintensive with features of acromegaly, it is more likely to be a sparsely granulated tumor. And if there are fibrotic changes in a patient who has received dopamine agonist therapy, it is more likely to be a prolactinoma. And if there are microcystic changes, it is likely to be a silent corticotropinoma, but this is not always true. I'll show the examples one by one. This is a gentleman who is having telltale evidence of coarsening of facial features with features of acromegaly. There is a large tumor, you can find out there are aneurysms, and this is a patient of acromegaly. Here is a patient with prolactinoma who was treated by me for almost 25 years with bromocriptine followed by cabergoline with multimodality treatment, including gamma knife radiosurgery and multiple surgeries. Finally landed up with pulmonary fibrosis and extensive pituitary fibrosis. So if you see on histopathology that patient is having extensive pituitary fibrosis, it is very likely that patient has received cabergoline or bromocriptine in the past. And on the imaging also you can tell it to some extent. If here is an example in which T2 weighted MRI showing microcystic changes in silent corticotropinoma on the left side, on the right side it is another corticotropinoma which is not showing that. So it is not 100% true actually.
So if somebody is having a disproportionate hormone deficiency and hypogonadism with multi-compartmental disease and picture like this, you suspect prolactinoma because this is a potentially treatable condition. Next come the role of nuclear imaging. So you can, in prolactinoma patient, you can predict that this patient is going to respond to your dopamine agonist therapy to some extent by doing a F-dopa PET scan, but this is not foolproof method. This is a patient in which you can see a normal patient which is showing there are increased uptake in the putamen and globus pallidus, or you can say the normal uptake. Patient with Parkinson's disease, another patient there is no uptake at all. This is a patient who not responded to dopamine agonist therapy. Another patient, he responded to dopamine agonist therapy with a little bit of uptake. But this is not always true and not available everywhere. Next comes the prediction of histopathology. This is a tall boy who at the age of 13 years, he presented with a pituitary tumor of 14 millimeter in largest dimension, and hardly he is 13 years old. You can find that the tumor is hyperintense on T2-weighted image, and as expected, he was showing that there was a sparsely granulated pituitary tumor. You can see here the electron microscopy as well as you can find out multiple fibrous bodies, multiple fibrous bodies in the high power field, but they are nuclear only on location. This is a densely granulated tumor. You can see that there is a bleed also inside the tumor, and T2-weighted image. Other areas actually there are hypointensities, and it is showing negative or perinuclear, multiple dot-like presentations. So you can find out the granularities here also. So this is a densely granulated tumor. So now coming to the genomic. Pituitary adenoma classification and familial and genetic causes include here only. They include multiple endocrine neoplasia and Carney complex, which are because of the germline mutation, and there are some somatic mutations which I have highlighted here. I will give one by one example. So genetic testing in all patients or familial cases with constellation of paraganglioma, pheochromocytoma, pituitary adenoma. The mutations in genes known to cause pheochromocytoma and paraganglioma can rarely be associated with pituitary adenoma. This is a multicentric study actually by us and Professor Mata Corbonitz, where we had found that the pheochromocytoma paraganglioma can rarely be associated with pituitary adenoma, whereas mutation in the gene predisposing to pituitary adenoma can be associated with pheochromocytoma and paraganglioma. So MEN1 is more often found in patients with pituitary adenoma if there is a paraganglioma or pheochromocytoma. On the other hand, if pheochromocytoma paraganglioma is there, then SDHB associated or some other causes, pituitary adenomas are less often found. And the most common pituitary adenomas which are found are prolactinoma followed by acromegaly and non-functioning pituitary adenoma. So this is a telltale evidence of a patient with Carney complex. You can find out there are skin fibromas, and the family members are also affected. Both the sister and the brother both are affected. Mother is actually having the mutation, but she has no manifested disease, which is extremely uncommon actually in this condition. But in science, everything happens because in this condition, the penetrance is almost 100%. And you can find out here, there is a normal testis here, and below that you can find out there are testicular microlithiasis. And the biopsy specimens revealed that the cutaneous myxomas and angiomas were there. So another patient who was referred from Sere-Kashmir Institute, Srinagar, you can find out there is a thoracotomy scar. In this patient, we had one leg arterial myxoma which presented with a stroke, and you can find out there are pigmented spotty spots in the conjunctiva, and this is very, very classical actually. And Professor Stratakis becomes very happy if you'll find out this sign in a patient with functioning pituitary adenoma, or there are features suggestive of Carney complex. This is almost diagnostic. This patient had a microadenoma, and you can find out there are multiple microaneurysms actually in this patient. This is because of the myxomatous degeneration of the cerebral vessel itself, of the basement membrane, or because of the multiple previous episodes of showers of embolism. So this is a new entity actually, acromegaly with CEC2 mutation, which presented with multiple endocrine neoplasia mimic. This lady was referred from Srinagar by Professor M.H. Bhatt. She had a classical acromegaly and parathyroid adenoma, a collagenoma. The parathyroid adenoma was rich in lipid. It was negative with 4D CT scan. It was negative with technetium sestamebe scan and choline PET, but only ultrasound revealed the tumor because it was very, very lipid rich. And when we reviewed the literature, there was a paper by Sunita D'Souza, actually from Australia. She had screened 131 patients of non-functioning pituitary adenomas and 3-4 prolactinoma patients and few acromegaly subjects in whom there was a somatic mutation of this check in 6 cases, and whether there was a cause and effect relationship was not known actually. So this patient actually, you can find out there is a cause and effect relationship, and you can say that this is a new entity which can tell you that this is an MEN1-like syndrome actually. This is in press actually. And this is a boy where you can find out this is the youngest boy who presented with AIP mutation, presented with apoplexy at the age of 4 years. And he was treated with multiple modalities, including VEGF antagonists, chemotherapies, and finally with pegvisomant, because it was not available in India. We have to procure it from Belgium with the help of Pfizer International. This is the same boy. So FIPA with AIP mutation positive, the patient may be fortunate enough to be cured with single modality sometimes. This is one of the patients which was treated only with radiotherapy because he refused surgery. His brother actually, he was operated at the age of 4 years in 1984 by Dr. Bhatia from All India Institute, and still under my follow-up. And you can see he's very tall, and this is familial acromegaly with AIP mutation. Another case you can find out, it is a familial. To our utter surprise, he presented in during pregnancy with apoplexy. There was a large adenoma, she was young, and there was a family history. The father is standing there. You can find out that he is also having acromegaly features. I was thinking almost 90% chance that this patient is having AIP mutation, but to our utter surprise, there was nothing actually. No mutation came out. So there is something more than that. Another patient with acromegaly because of somatic mutation, because of McCune-Albright. I will just pass it. There is a germline or somatic GPR101 mutation. This is the 3-year-old child who presented at the age of 2 years. By the time she went to the school, she was taller than her principal actually. When they came to our hospital, I had in the mind that something is there, and by the time actually the X-linked acrogigantism was not reported, I just kept a sample for future. And when the entity came into picture, we analyzed, and it was because of the X-linked acrogigantism. But another patient, familial acromegaly subjects, mother and sister, daughter, both of were seen. I was jumping actually 1912 that this probably, most probably something X-linked. By the time it was not described. To our surprise, both of them are having somatic GS-alpha mutation. So it was not X-linked. So all that glitters is not gold. This is another infantile Cushing due to Dicer mutation. The baby was diagnosed at the age of 9 months with infantile Cushing's. And the initial diagnosis by the histopathologist was it's a functioning teratoma, but something was there. I thought that I should keep both the samples of the tissue as well as that's how we should keep our samples for future. And when the knowledge came actually, it was found to be a case of Dicer mutation, and the father was the carrier without any manifested disease. It also published with Anthony Leo. And this is multiple endocrine neoplasia. You can have the full spectrum, brother and both the brothers. One is having acromegaly, the other one is having acromegaly, parathyroid adenoma, and intra-abdominal neuroendocrine tumor. And they had this younger one is having a non-functioning pituitary edema. So in same family, we can have genetic heterogeneity also. This is a prolactinoma with multiple endocrine neoplasia. You can find out the classical cholagenomas here, large tumor you can see. And another acromegaly patient with primary hyperparathyroidism, renal stone disease, and acromegaly, she presented at the age of 15 years to us, but there was no mutation found. So this was a sporadic acromegaly. Another Cushing's with multiple endocrine neoplasia phenotype. She was found to have mutation positive. This is a patient which was sent from my hometown. He was a patient of sickle cell anemia with acromegaly and parathyroid adenoma also. Again, I was very complacent. Most probably it is a case of multiple endocrine neoplasia, but it came to be a somatic GS-alpha mutation with mosaicism. So you can have a multiple tissues, the disease process in the endocrine organ. So all that glitters is not gold again. So the candidate gene approach helpful only in syndromic, familial, and rarely in young adenoma cases. The yield is only 5 to 20%. Therefore, people have tried whole exome sequencing and genome-wide association study. Coming to whole exome sequencing, before that I will say that if we'll do a digital droplet PCR study in some of the prolactinoma cases in which we did it with the help of Asutosh, we have a multi-centric study. It is about to be published. It's in the press. So we could not find it in the young patient or in the aggressive pituitary adenoma versus the elderly patient or non-aggressive patients, the mutational positivity of SF3B1, unlike the previously reported cases. So it is a quite large cohort actually. It is about to be published. So then we went ahead with the whole exome sequencing in patients with acromegaly. So we excluded all familial cases, so-called quote-unquote sporadic cases we included so that it will be helpful to find out some novel genes, but it was a defeat only. So none of them were a driver mutation, they were just some bystander mutations. Next, there was a publication by Anat Ben Shlomo, Professor Shlomo Melmed's colleague actually, and they published in Journal of Clinical Investigation that somatic copy number variation rather than the mutations are the hallmark of functioning pituitary adenoma, re-emphasizing our previous study. So WVS in Cushing syndrome, this was published by late Professor Kanchan Mukherjee, actually in the one of the poster in Pituitary Congress. So our data concurs with that reported by Merily Theodopoulou, which she published later actually. Because of the lack of functional studies, we could not publish it in a good journal. She asked our help actually, can you provide some samples? But during that time, Dr. Mukherjee, I can say, was on the top of his career and he was little megalomaniac. So he told, no, we'll not share with anybody. We'll do ourselves. But to my actually dismay, on 7th of June, the 7th of May, we got a mail from Merily Theodopoulou for collaboration. Of 7th of June, he expired in Bangalore in a conference. So we were quite sad actually. So next we went ahead with the proteomic analysis of human anterior pituitary glands. So we could find that 2,286 proteins were found from the pituitary gland along with the 7 classical hormones which are secreted. So there is something more than that. And from the posterior pituitary, 1,738 proteins were identified other than the 2 carrier proteins and oxytocin and vasopressin also. So whole exome sequencing studies of non-functioning pituitary adenoma, again same type of thing, the copy number variations are more important than the mutational analysis. Therefore, we went ahead with proteomic analysis in again patients with non-functioning pituitary edema. So then you know that phosphoproteomics are the commonest post-translational modification regulating various cellular processes along with acetylation, sumylation and the histone deacylation and the other processes. Activation of the status of various proteins and also to monitor kinase activity and the identification of aberrantly activated signaling pathway affected by the phosphorylation, it can be helpful. So Asutosh did this study and we found out that 2,508 phosphocandidates corresponding to 1,345 phosphoproteins were identified and mostly the EGFR, MEK, the START1 and 3, beta-catenin, BRAF and HSP, B1 were the significantly overphosphorylated in the recurrent pituitary adenoma subject as compared to the invasive one or non-recurrent. So identification of these phosphoproteins provided a roadmap for patient stratification, prognostication and recurrence and trials for targeted therapy in future. So this is phosphobeta-catenin at serine 552 correlated with recurrence and invasion. Even here you can find out the invasive and recurrent tumors are quite widely separated from the graph. This is the principal component analysis. And in the same pathway, you can find out there are multiple proteins which are linked to this phosphobeta-catenin S552. Then we validated this cohort in a larger cohort actually. After the mass spec, results were available with immunohistochemistry and Western blot that beta-catenin phosphoserine 552 potential prognostic marker for recurrence. You can find out recurrent and non-recurrent tumors. There is a wide difference in the immunohistochemistry. And you can see the Kaplan-Meier survivor curve for the recurrence also and the disease-free survival. It was completely different in people who were showing the expression of the different proteins. So here you can see on the Western blot analysis and the double immunofluorescence, that nuclear localization of phosphobeta-catenin, which indicates that it is going to act on the nucleus, it is more active and transported into the cytoplasm, from the cytoplasm to the nucleus. So then phospho-EGFR T639, it is a predictor of recurrence in non-functioning pituitary. Somebody may ask why you chosen these proteins. Because from the list of proteins which is most upregulated or most underexpressed, you have to choose them, and for them commercially available antibody has to be there, or you have to tailor-made or design the antibodies. So phosphoprotein sparsely granulated somatotropinoma, this is an ongoing study. So in this, we took the somatotropinoma patients and categorized them into the densely granulated and sparsely granulated tumor, and then did separately the mass spectroscopy in them and in triplicate to make it statistically significant. And you can see there are clearly literature on the granulation pattern and clinical aspect of somatotropinoma. Sparsely granulated somatotropinoma usually happens in younger patients. They are more aggressive. They are resistant to therapies. So therefore, we were interested to do this so that we can do something in future. So this slide summarizes the most relevant and recurrent literature supporting our recent literature supporting our investigation into the granulation pattern of somatotropinoma. And these studies collectively show that dense and sparsely granulated tumors differ not just on histopathological approach, but also in clinical behavior, prognosis, and treatment response. So therefore, knowing this is important. So in this, we can see that the expression pattern of the growth hormone and the IGF-1 is different in sparse and densely granulated tumor as compared to the intermediate type. And on radiology, we see the sparsely granulated tumor have large tumor diameter and volume compared to the densely granulated, which all of you know. Additionally, sparsely granulated tumor have more number of invasive patients. So then, after screening, we validated the cohort in 43 subjects, out of which, because of the various reasons, 12 were excluded, and total 31 were included. And IHC for pituitary hormones were including GH were done. And cytokeratin membrane antigen, which is a marker for fibrous body, was done in 31 subjects, and then they underwent mass spectroscopy in triplicate, as I had already told. So the first step is cytokeratin membrane antigen classification to say that it is a sparse or densely granulated. And in the top panel, you can see there's 1 to 4, the densely granulated tumor, whereas the insert shows the cytoplasmic positivity of CAM5 and 2, and the bottom panel shows the S5 to 58, the sparsely granulated tumor, where we can clearly see the fibrous bodies. And looking for towards the clinical parameters, we observed that IGF-1 and GH were definitely elevated. So the heat map shows that you can, based on the proteomics and phosphoproteomic analysis, there is a complete segregation of the sparse and densely granulated tumor. You can find out here in the brown and the brown one. So the principal component analysis plot revealed that clear separation between dense and sparsely granulated tumor, indicating their underlying data is distinct enough for supervised clustering of, differentiate them, and supporting the biological difference between these tumor subtypes. So then we did a validation in another 142 subjects using cytokeratin membrane antigen, classifying them whether it is densely granulated, sparsely granulated, or intermediate granularity, based on the immunohistochemistry and the Western blot. And there were 65 sparsely granulated tumors. Clinically, most of them required gamma knife radiosurgery or redo surgery, and they were resistant to the available therapies. And densely granulated, only one of them required gamma knife surgery. There may be some bias you can see because it is a single center study. And you can find out on the proteomic front, there is the overexpression of tumor necrosis factor 1P1 and underexpression coenzyme Q in the sparsely granulated tumor. Here you can find out the TNIP and the DAPI here on the other side in the blue color. And sparsely granulated, you can find out TNIP is strongly positive as opposed to densely granulated tumor. And on the other hand, the coenzyme Q is more expressed in the densely granulated tumor. So this validation of proteomics showed that overexpression of TNIP and underexpression of coenzyme Q in sparse and densely granulated tumor. Next is overexpression of LKB1 pathway protein in SSG and DCJ. This is the protein which chosen from the overexpression pattern. It was the most fold increased protein in amongst the actually analysis from the bioinformatics data. And you can see that the AMP kinase activity, they are all pathway protein of the downstream pathway protein of the LKB1. Here you can find out in this sparsely granulated tumor, it is more positive. Even the mTOR is more positive, intensely positive. And the bar diagram also depicts the same thing actually. So we again validated it with the immunofluorescence, which shows increased phosphorylation of LKB pathway proteins in sparsely granulated tumor as compared to the densely granulated tumor. So the results for the immunofluorescence staining clearly demonstrate that significant difference in the phosphoprotein level of key proteins involved in the LKB pathway between SSGA, SGSA and DGSA. The increase in the phosphorylation of AMP kinase and the mTOR pathway is also to be noted. So then the SGSA tumors show significant reduced cell viability upon inhibition of EVLK1, AMP kinase, mTOR in vitro using various inhibitors which are commercially available. So the SGSA tumors show significantly reduced cell viability upon inhibition of EVLK1, AMP kinase, mTOR, while DGSA tumors remain largely unaffected. From the bar diagram you can see, and most of them are significant statistically, and highlighting its metabolic vulnerability. And in contrast, the PRKACA inhibition does not impact the viability of either of the tumor. Next is GH secretion in the functional readouts of the somatotroph activity, measuring GH in the supernatant, which allows us to assess how active the tumor cells are functionally in the terms of hormone production, comparing GH level in treated versus untreated cells, which shows whether inhibitor suppress GH secretion or enhances GH secretion or no effect of supernatant, which contains the secretome. So this is one of the integromic analysis. Actually, after you integrate everything, the genomic, the metabolomic, the proteomics, phosphoproteomics, and transcriptomic, thus come the role of integrated roadmap. This is one of the pathway which was designed by Achilles Pandey from Johns Hopkins with the help of Mukherjee sir and me. The integrated map of cortisol CRH pathway. From here you can find out what are the other off-target effects of the hormone actually. Same thing we did for the AIP and prolactin also, which are published. And you can see that next work was done by Asutosh, that cell division cycle protein 42 is a therapeutic target in non-functioning pituitary adenoma. And here you can find out that there is overexpression of CDC42 in pituitary proteins. CDC42 can be used as a therapeutic target actually. With inhibitor and stimulator, we found out that they are definitely vulnerable to them. So coming to my acknowledgements, this is the first one is Professor Gopal Krishna Rastogi, who was the founder member of our department. Professor R.J. Das, who was my mentor. Dr. Muralidharan, Dr. Anil Bhansali, who were my teachers. Asutosh and Vaishali are my PhD students. They had done most of the laboratory work. Bishan sir and the pathologist Uma madam and Debojyoti Chatterjee, they had done all the histopathological examination in most of the patient. And Paramjit sir and Chirag are radiologists. And I'll tell regarding Mukherjee sir later actually. And these are my overseas collaborator, Professor Mata Gorbonits, Professor Vera Popovich, and this is Achilles Pandey from Mayo Clinic, who introduced me to the area of system biology. And when I was a young boy and working as a JR in the Department of Medicine, I had encountered Professor Narendra Kotwal, and he was a very, very fascinating person, and he inducted me to and made me interested to join endocrinology. So once upon a time, I went to his institute and was felicitated there. And this person never comes to the stage actually. He is almost secluded. Dr. Sujit Bhattacharya, he is my silent mentor actually. I am saluting him. He always used to call me Royal Bengal Tiger actually. And these are my two other collaborators. This is Miklos and this is Professor Ashley B. Grossman, who has supervised Asutosh during his study postdoc in his tenure at Queen Mary University. Thus, he learned most of the techniques from there and did my work easier. So, Professor Das, actually, the rarest of the rarest figure which I got with Rosalind Yellow, that was in 2021, February 23rd. I happened to went to his home in Bhubaneswar. he was writing his autobiography and he told that Pinaki, you have to edit this autobiography. So he gave me that picture that is still with me actually. I feel privileged to carry that picture of Professor P.N. Saha and Professor Mukherjee, Das and Rosalind Yallo. And last but not the least, my family members who always supported me, that whenever I start my fast innings, that is around 5 o'clock, after Dr. Bipin said his message with flower and a very good message in the morning. Then second innings in PGI, third innings again come back home, that don't say anything to me. You continue your studies and they don't interfere me. So thank you very much. And with thanks to Almighty, I complete my oration actually. Thank you very much to all of you.
Thank you very much. I'm sure we are all enthralled and enriched by the advances that are taking place in better evaluation of endocrine conditions. And now we have example in pituitary tumors. Hopefully, and I think there is some intriguing possibility that better understanding of the proteomics may also lead to newer treatments stemming from that. So with these, we would like to congratulate once again Dr. Pinaki Datta, and I, on behalf of Dr. Muradharan as well, would bring this session to a close.
Yes,
Thank you very much.
Sir, if you allow, I will just share a small anecdote regarding Kanchan Mukherjee. So, Subhankar sir came as an examiner in 2017 May to our institute. He told, I have heard a lot about Kanchan Mukherjee. Can you have a meeting with him? So we went to his Gamma Knife Center. Subhankar sir started chatting with Kanchan Mukherjee. Then he showed one of the scars in his arm. Actually, they are a cut down scar. He had almost 9 scars in his body because of various surgeries. He remembered Dr. Dhira Ganguly. Dhira Didi did this cut down when I was a small boy and was suffering from acute gastroenteritis, almost collapsed, about to die, but she resuscitated me along with Subhankar, and that's why I'm here today. Within 1 month he died actually. That is a very sad story. Thank you very much.
Thank you, Professor Shubhankar. Thank you, Professor Pinaki and Professor Muradharan. We come to a conclusion of the oration session. I hand over back to the organizers for further scientific sessions to be continued. Thank you.
Thank you, sir. So, from the session of oration, now we are moving to a session of endocrine update. And for this session, may I request Dr. Jagatjyoti Mukherjee and Dr. R. Santosh to please come to the dais and please chair the session. Over to you, sirs.
Hello. Good morning. I think after the oration, some of you want to go out, have a cup of tea, a break. So if you want, please move out quickly because we want to start the next session. And fascinating sessions, adrenals and pituitary. The first one, you have already heard Professor Hammer before. It's basically the adrenals, adrenal insufficiency. A very inverted commas easy topic, but I think most often missed by many of us. And you're going to speak on the management of adrenal insufficiency. Again, on the surface looks very simple, but I think the devil lies in the details, I think. So you're going to take us through that. Over to you, Professor Hammer.
Okay, thanks. Can you hear me now? Okay, great. Well, thanks for inviting me back up to the stage for a second talk. A little shorter talk. We're going to talk about a little update on adrenal insufficiency. We all know the importance of the adrenal glands and the stress response, so I don't need to go into that in too much detail, other than show you a couple of nice slides to let people wander in as they're getting their cup of coffee. Just need some volume on that. Oh well, we can move on. I may need help on, let's see, getting this back. Is it back now? There we go, okay. Okay, so we all know the importance of stress hormones, cortical and medullary, in the mammalian stress response. I won't go into that in too much detail. We want to make this a clinical update. I also don't need to go into the organization of the adrenal gland, so we'll just jump right through these in terms of our, as endocrinologists, our understanding of the glomerulosa, fasciculata, reticularis, and the medulla. So I won't belabor the point at all about the role of these hormones, because we already had an introductory talk this morning when I talked about adrenal masses. So we won't go into that at all. We'll skip the regular understanding of the renin-angiotensin axis and the pituitary adrenal axis. I will remind you, though, that there are a bunch of adrenal rock stars in history that helped pave the way for our current understanding of the adrenal cortex. The first textbook of human anatomy by Vesalius in 1563, 1543, you'll notice that this patient either had adrenal failure because there's no adrenals in the slide, or they didn't know what that little piece of flesh was above the kidney. It really wasn't until Eustachius, about 20 years later, put the adrenal in its rightful place as a crown above the kidney. Eustachius from Eustachian tube, back in 1564. It took another 300 years, of course, until Addison, in his famous monogram, first described the disease that now bears his name, Addison's disease, which of course used to be used only for the term autoimmune adrenalitis, but now that term has diffused a bit into the term for just adrenal insufficiency in general. But there are many rock stars in the adrenal world. There are a bunch of Nobel Prizes for diseases of the HPA axis. I will not go into detail on any of them, but just give them due deference. Okay, so adrenal failure really is inadequate adrenal hormones, right? It's important to know that this can be familial, like in the Kennedy family. Historically, there are many causes like TB, historically, thought to be the cause of death of Jane Austen, actually, the author. All walks of life, whether you're Osama bin Laden or famous singers like Helen Reddy with adrenal failure, genetic. But Addison first talked about autoimmune adrenalitis, and I show you the atrophy there in the upper green box. This is just to remind us that this is one cause of adrenal failure, where TB was historically 20% of adrenal failure. But it can be isolated or part of genetic syndromes like polygland or autoimmune type 1, type 2. But there are many other causes. It's just important to remember for the trainees, of course, that in primary adrenal failure, you have both glomerulosa defects, aldosterone is also defective, similar to like cortisol. Remember that in polyglandular type 1, there are usually have adrenal insufficiency before the age of 15, hypoparathyroid before the age of 10, and chronic mucocutaneous candidiasis before the age of 5. PGA type 1. You can also have other autoimmune syndromes like dental hypoplasia, keratopathies, and occasionally the diseases on the right. But there are many other causes. I will not go into these at all in detail, but you know the list. Everything from autoimmune diseases to infection to tumors to bleeding to surgery, genetic causes, etc., and medications that, of course, cause adrenal dysfunction. And we just talked about autoimmune adrenalitis, which is the most common in all age groups, but many others. We won't go into the biology of autoimmune adrenalitis. There's whole lectures on the causes of destruction of the adrenal that involves both T cells and B cells. We will not go into the biology today for this talk. I will just remind us that in the last 20 years, like in our prior fantastic last talk, we've learned many aspects of the genetics of adrenal failure, and there are many, many diseases. There's over 40 monogenic diseases now of adrenal failure that include both diseases of various aspects of the pituitary adrenal axis from the ACTH receptor down to diseases of adrenal formation or homeostasis, which we will not go into today. Question for you, though. Which twin here is sick? This is a New England Journal article about 20 years ago. It's, of course, the bronzed one, right? The bronzed one is the diseased one because of elevation of pituitary POMC, which makes ACTH which makes MSH in addition to ACTH, and results in the bronzed skin, of course, and pigmentation in primary adrenal failure. Because of the MSH produced by the pro-opium melanocortin gene, which makes ACTH as well in the pituitary, which is elevated in primary. Always a clue, but not a diagnostic sign of primary adrenal failure. But if we talk about adrenal defects, here you can have adrenal defects, pituitary defects, or of course hypothalamic defects. Causes of secondary adrenal failure are quite similar. They can be tumors, iatrogenic, autoimmune, genetic, infiltrative, infectious, and on, medications that affect the pituitary as well. The genetic mutations are interesting, and like the adrenal, there are many, like adrenal failure, autoimmune diseases as well. But of course, the most common is probably tumors and iatrogenic diseases of the pituitary, whether it's hemorrhage or a tumor in the pituitary. Crowding out the pituitary are the most common causes. Hypopit. And remember, when it's pituitary-based failure of the adrenal, the glomerulosa is fine, and you usually do not have any dysfunction with hypokalemia, hyponatremia, or hyperkalemia. Okay? There are various causes of monogenic pituitary secondary failure, okay? As I mentioned already. It's in the primary adrenal failure where, as I mentioned, you see both a high ACTH and low glucocorticoids, and also a high renin and a low mineralocorticoid state. Not too groundbreaking there, whereas in secondary, of course, you've got low ACTH and low glucocorticoids, hypoglycemia, hypotension. The most common cause of adrenal insufficiency, remember, as endocrinologists, we need to drill this into the heads of our primary care providers, is the too rapid cessation of exogenous glucocorticoids for the treatment of non-adrenal disease, or the inadequate replacement in adrenal insufficiency during acute illness. These are causes not just of adrenal dysfunction, but of adrenal crisis. And we need to constantly educate our colleagues about these two situations. And that's really one of our biggest jobs in the educational space, I would argue. So, what we're most concerned about in adrenal insufficiency, whether it's pituitary or adrenal, is usually cortisol deficiency, of course. And the screening test is to rule out disease, usually with an AM cortisol. The principle of the test is that cortisol is highest in the morning, allowing a maximal chance to rule out disease, because cortisol is normally highest. So a high AM cortisol rules out disease. Classic would be greater than 18 micrograms per deciliter. Only in extreme cases is a cortisol diagnostic at baseline without a stimulation test, and it would have to be less than 1.8 micrograms per deciliter to make the diagnosis. But most patients are neither extremely high nor extremely low and require dynamic testing. That's why we do it. Rarely do you see an AM cortisol greater than 18 or less than 1.8. So we dynamically test, like in all endocrine systems, we stimulate, right? We stimulate with ACTH or hypoglycemia to stimulate the axis and hope that it goes over that critical level of 18. Now, an ACTH level that's extremely high is consistent with a diagnosis of primary adrenal insufficiency, but is clearly not diagnostic. Okay? It's consistent with. Okay? For secondary, an insulin tolerance test is the gold standard to rule in disease, right? The principle of the test, of course, is that insulin, which drives hypoglycemia, is the #1 stimulus for CRH and hence ACTH, and a cortisol level that's subnormal is diagnostic of adrenal insufficiency, not secondary adrenal insufficiency, but an ACTH level after insulin tolerance test that's subnormal is diagnostic of secondary. Okay. And again, an ACTH level, as I said, that's extremely high is only consistent with the primary AI, not diagnostic. But I want to talk a bit about adrenal crisis, right? It's really defined clinically as cardiovascular collapse due to adrenal insufficiency. New pituitary hemorrhage or bilateral adrenal hemorrhage, new adrenal infection, Waterhouse-Friderichsen syndrome, rapid withdrawal of exogenous glucocorticoids, or new medications. Never forget the medications. Most of them increase metabolism of glucocorticoids, like phenytoin, phenobarbital, rifampin, or they decrease synthesis. Most of us know about these because we use these to treat cortisol excess. Metirapone, mitotane, ketoconazole. Adrenal crisis is always precipitated by stress to the body. Trauma, bad infection. Basically, when the body needs cortisol and aldosterone to fight and doesn't have it. But you always see a precipitating event. So you have to take home point. If you have cardiovascular collapse in the setting of catecholamine-resistant hypertension or hypotension with abdominal pain, you must think adrenal failure. Cardiologists are pretty good at this. No one dies in an ICU without getting glucocorticoids for the most part in many hospitals. But this is when you have to think about adrenal crisis, right? Why? Because if the diagnosis is missed, your patient's going to die.
In a crisis, our body calls on our very own emergency response center, the adrenal glands.
This is just to wake you up.
They produce hormones like adrenaline that sends the body into action mode. And this is how sometimes people can get superhuman strength.
They're confusing the picture, of course, with growth hormone, but nonetheless, it makes the point. So, clinical case number 1, 72-year-old white male, status post hip surgery on warfarin with new bilateral flank pain. What's the most likely diagnosis? Cortisol is less than 1. Yes, acute bilateral adrenal hemorrhage. This is classic for bilateral hemorrhage. What I want to make a point about this slide is, and this often happens in the setting of someone who has antiphospholipid syndrome, which is repeated arterial and venous thrombosis following hemorrhage. Okay? But I want to make notice about the imaging. Some endocrinologists look at their images, some don't. We should look at the images even though we rely on radiologists to help us. This is classic. And what I want you to notice is the soft tissue attenuation in both adrenal glands, the margins are ill-defined, and there's periadrenal infiltration or fat stranding. Like in that black space where it should be fat, you see these cotton wisps. That's classic fat stranding from adrenal hemorrhage. And this can happen for a variety of reasons. Classic Waterhouse-Friderichsen syndrome, which isn't just meningococcus, it can be Pseudomonas, other gram-negative bacteria, a hemorrhagic diathesis, coagulopathy, hemorrhage of underlying adrenal tumors, have to be bilateral, of course, in that setting. Of course, idiopathic, which means we have no idea what the cause is. Or labor stress. During very difficult labor, you can see hemorrhage of both adrenals. Uncommon, but it's seen. Okay. 3 different stages of failure. 1, subacute failure. If you can see it, it's kind of hard to see, with or without glasses. It's called train tracking. So look at the limbs of the adrenal. You see the gray limbs, and in the middle of each limb, it's black. That's classic early hemorrhage where the middle of each limb gets fat and looks like it has fat in it. That's called train tracking. Subacute hemorrhage. Okay? Acute hemorrhage is what I showed you. High attenuation, periadrenal fat stranding, hemorrhage extension. Chronic adrenal failure can either resolve completely, or you can end up with what's called a pseudocyst, which you can see, I think, in one of these slides here. The very last slide shows the pseudocyst. The one on the left shows resolution. When you see that pseudocyst in a patient, you're thinking that's a prior hemorrhage. Case 2, 59-year-old, epigastric pain with sweating. Hey, I already showed this case, so you should remember it, but I'll go over it fast if you weren't here with the first case. A lot of weight loss, diaphoresis, anxiety, no fever, had a melanoma 2 years ago, family history of heart disease, cachectic, hypotensive, orthostatic, palpable masses on both sides. You can feel them. And a CT scan is done in the ER and shows that. So, no washouts, they're big. What is this? What are you worried about? It's bilateral adrenal disease in a setting of hypotension. So what are the next steps is what we talked about earlier today. Do you biopsy this, do a bilateral adrenalectomy, a hormone workup, or send a patient home? The answer is you almost do none of this first, but this needs a hormonal evaluation, of course, because any adrenal mass, unilateral or bilateral, needs a hormone workup. We're not going to go into that. But the differential diagnosis of bilateral adrenal masses is many, from metastatic disease to primary adrenal neoplasms, which we're not going to go into bilateral adrenal masses too much, but bilateral pheo, macronodular hyperplasia, macronodular PPNAD, primary pigmented adrenocortical nodular dysplasia, CAH, et cetera, infiltrating causes, infections, et cetera. This patient had a hormonal workup, which showed the following. Now, of course, in a patient like this, by the way, we didn't present this case exactly the same last time, but in a patient like this, if they're in the ER, with what looks like an adrenal crisis, you're going to treat the adrenal crisis first. That's number one, right? This patient was treated for that, but had labs drawn prior where the norepinephrine was mildly elevated with plasma and in urine, okay? So the team that saw him were thinking about pheochromocytoma in this setting. One thing to remember, stress does something very important to the adrenal medulla. It activates the adrenal medulla, and this is most likely this reactive activation of your catecholamines, which is why we don't rule out a pheo in the ER. But they thought about a pheo, got an MIBG scan, which was negative. And then they got a PET scan, which showed that both adrenals lit up on a PET, however. So that makes you concerned about malignancy on both sides, right? Of course. FDG was PET positive. So now what do? Do you biopsy now? No. I talked about the hormonal evaluation, which you still have to do in a patient like this. But I told you, and I say, why? Wasn't it already done? Well, it was for hormone excess. But what didn't they do in this patient? I already told you. In the patient, look, they're having adrenal crisis. This patient may have bilateral adrenal failure from whatever that is. So after treating the patient, they had hormones. They did have hormones drawn. And what I want you to notice here is that while the metanephrines were mildly increased, I didn't highlight this before. You saw it though. The cortisol, AM cortisol was 8, but the ACTH was 257. What did I tell you about that? It's consistent with primary failure, not diagnostic. So from the beginning, they should have been thinking about that in this patient, right? Adrenal failure. So bilateral disease, you have to think about excess and failure whenever you have a patient like this with bilateral disease. So in this case, you got to treat the patient, as I mentioned already. So let's assume the patient was treated. Draw a lab test if feasible, which showed the patient was adrenally insufficient, had primary failure. And then, of course, after you treat the patient with hydrocortisone, then, of course, you can biopsy the patient because you're going to have to find out what this is. So when they did that in this patient, and this morning I reminded us that in unilateral disease, of a unilateral nodule of the adrenal, biopsy is rarely helpful. We don't do it, except when the patient has another cancer and you need to distinguish the new cancer from the adrenal mass. In bilateral disease, it's almost always helpful. So in this case, you biopsy the patient, and as I said, it can be many things. And in this case, it showed these pleomorphic nucleated large cells. CD20 was high. What is this? This is primary adrenal lymphoma, a very rare disease where you don't have lymphoma on the outside in your body, only in the adrenal. You're not going to be able to pick this up without a biopsy. Okay? But we've seen this. It's rare. I mean, usually lymphoma involves the lymph nodes. The adrenals are involved in about 4% of patients with lymphoma, but solitary adrenal involvement causing adrenal insufficiency is less than 1%. So I didn't expect us to get this case. That's why you have to biopsy cases like this. It's large B-cell lymphoma. Patients present with adrenal insufficiency. Some people wonder if it's due to prior autoimmune adrenal failure, because that's immune-mediated, and maybe that ends up with a lymphoma. Hypothesis only. Hematopoietic rest in a myelolipoma. Maybe. 3, 46-year-old Filipino male, 3 months of weakness, 15-pound weight loss, worsening fatigue, salt craving, vomiting, libido, erectile dysfunction. We're endocrinologists. Something's going on here with what? Adrenal or pituitary, you're thinking? You're thinking pituitary because he's got some weakness and fatigue and he's got hypogonadism. You're wondering about that. He immigrated 6 years ago. He's a nurse at a nursing facility. He hasn't left the country since. He's hypotensive. He's orthostatic, muscle wasting, hyperpigmented, hyponatremia, hyperkalemic. His ACTH was, I said you're thinking pituitary, that was a trick. His ACTH is 500. His ACTH stim test is flat. So he's got primary adrenal failure, right? And there's his adrenal glands there. They look kind of weird, kind of just gnarly looking. So what's the next step in this guy? Well, let's treat the patient again. Treat the patient first. You're thinking adrenal crisis, treat the patient, draw labs if you can, and after that you can do a biopsy, of course. They did that and they saw this, casein necrosis. What is this? This is TB. You see a lot more TB here than I do in my country, but we always have to think of TB always in cases particularly like this. And then you see this on the biopsy, gives you the diagnosis. Remember, TB still happens. 10 million new cases a year in the world, with still 2 million deaths a year. And I'm sure you see that here. And there's Still 30 high multi-drug resistant countries, including here, I believe, multi-drug resistant TB. So, 6% of patients who have active TB have adrenal involvement. The rule of thumb is if less than 2 years of active TB, you're going to see bilateral enlargement. If it's longer than that, you may see that calcified or atrophic adrenal. In an adrenal biopsy, you don't need to do it if you have active TB and bilateral enlargement. I mean, with the bilateral enlargement, you will still do the workup for the primary adrenal bilateral disease. But if it's primary bilateral disease, you've ruled out hyperfunction, hypofunction, and they have TB, it's TB. You don't need to biopsy it. Okay? Remember, rifampin increases metabolism, et cetera, et cetera. 4, 26-year-old African female delivers a healthy 8-pound baby girl after 32 hours of difficult labor. You know where this is going. Vaginal delivery, postpartum hemorrhage, presents to the ER, markedly lethargic after giving birth. She felt fine at home on postpartum day 1 and 2, but slowly developed fatigue, vomiting, confusion. Primary care thought, oh, you're just tired. You haven't had children before, have you? But on questioning, worst headache of her life in the recovery room, and she couldn't breastfeed and lacked milk production for a week. So what is this? She's hypotensive, orthostatic, breasts are not engorged, CRIT's 39, lights are at normal. Again, random cortisol is not helpful. ACTH stimulation test is normal. She responds. So does she have adrenal insufficiency still? Yes. That's the problem with an ACTH stimulation test in secondary adrenal insufficiency that's recent. The adrenal hasn't atrophied yet. And a lawsuit will happen here. She responded because the adrenal hasn't atrophied yet. You give ACTH, she responds. If you gave her hypoglycemia, the cortisol wouldn't respond because she has no ACTH. But it takes at least a week or 2 for the adrenal for the fasciculata to atrophy. So you have to be careful of an ACTH stim test in acute secondary adrenal insufficiency. That's why. Okay. Her adrenals are kind of thin, even though it's hard to diagnose adrenal insufficiency on a CT scan. Those are thin limbs, but I don't use that diagnosis. So what next with her? Random ACTH, by the way, was 10, which is low. What is this diagnosis? It's not primary, right, it's secondary. So what next? You do an insulin tolerance test is what she needs, and on insulin tolerance test, she doesn't respond. So this is secondary adrenal insufficiency as predicted. The presumptive diagnosis, of course, is that. She's had quite a big hemorrhage in her pituitary. So what is this? This is Sheehan syndrome, of course. This is which precipitated her adrenal crisis. Postpartum pituitary hemorrhage, which results, of course, from reduced blood supply. Pituitary starts to hypertrophy first, then it bleeds, and then necrosis, right? That's mom, and that's why she can't breastfeed. That's why she's hypogonadal, et cetera, et cetera. Mom feels tired, weak, feels aging, not just having the kid. And of course, the baby, no prolactin, no lactation, baby's crying. Okay, classic. Common triggers of adrenal crisis. Pregnancy is rare, but happens. It's usually going to see, I mean, vomiting and diagnosis aren't the cause here, but they can help still precipitate adrenal crisis if it's bad enough. You know, because it's an illness, and they have adrenal insufficiency. They're not being treated with stress dose steroids. They have a GI bug. They have the flu, dehydrated, et cetera, et cetera. Bereavement or stress is rare to cause adrenal crisis. You can see it, and someone is incredibly, profoundly emotional, but that's rare. Okay, let's finish up here with another service announcement.
Yeah, but Adrenaland is for kids 10 and over, and I'm finally 10 or over, which means I'm finally big enough to ride the spleen puncher.
All right. So to finish up in the last 5 minutes, let's talk about our advancements in adrenal and treatment of this disorder. You know, we've used cortisol for years, since 1954, when Upjohn in Kalamazoo, Michigan, near where I live, first, you know, made cortisol for treatment. And we've made great progress, all of us have as endocrinologists. We should give ourselves a round of applause for drug delivery developments, patient education, crisis preparedness. But guess what? Patients still die, even in our hands as endocrinologists. I had a 30-year-old lawyer who died because she loved being tan. tan from her adrenal insufficiency. She died because she wouldn't listen. We're pretty good with sick day rules, 2 to 3 times normal replacement dose during illness. While you have the illness, then taper down. Guiding principle, the guiding principle for someone who's on long-term prednisone therapy, for example, is the higher the dose and longer you treat, the greater chance of long-term suppression and atrophy. The risk of suppression is relatively low when it's, of course, a low dose, short duration of bursts, high dose and prolonged therapy. Greater than 1 to 4 weeks is higher risk. Time course, as I said, larger the dose, for periods of time, months to years, it may take 9 months to 2 years to recover. I had a patient on high-dose prednisone for 8 years. She was able to get off her prednisone when she didn't need it anymore. It took 2 years, though, to get her off. The need for taper. This is critical to tell our non-endocrine colleagues. The taper from high-dose steroids for a non-endocrine condition to physiologic replacement is the decision of the treating doctor for whatever you're treating them for their lupus, for their ulcerative colitis. That's a non-endocrine decision, right? The taper from physiologic to off, that's where we can help them sometimes. And for the taper. That's determined by adrenal suppression. So the future is here in the last 3 minutes. There are new drugs out there, slow-release cortisol. I'm not sure if it's available here, but if you look at the BID dosing, which is what a lot of us do with hydrocortisone, it looks like that. 3 days of dose looks like that. That's the normal circadian rhythm. So how do we get better at that? Well, there's now, as you know, slow-release cortisol, plenodrin, for example, which looks pretty good in terms of its ability to recapitulate normal rhythms. And we're starting to use this. It's expensive, but it'll come down in price soon for our daily dosing. This study I want to highlight in the next 1 minute before I close, in that this great study out of Birmingham tried to understand a little bit about how we should treat people in the hospital with adrenal insufficiency to prevent crisis in the hospital. And they looked at patients, with various kinds of stress and what were their cortisol levels during combat stress, surgical stress, trauma, sepsis, and those are the levels there. I'm not going to say much more. Those levels of cortisol you see during those kinds of stress. And they want to recapitulate that therapeutically during hospital admission, which is a crisis event, not a crisis event, a critical event that you need high-dose steroids for. So they looked at normal oral, 4 times a day oral, 4 times a day IM, 4 times a day IV therapy in pulses. And you'll notice that those pulses span the ranges in yellow, but the peaks and troughs were too low, right? They were really low and didn't really give you the level of cortisol you see during major stresses in life. So they opted to give continuous IV cortisol in the hospital, and now when they give IV cortisol, it's perfectly in the sweet Goldilocks spot for what your stress levels should be. Cortisol should be during acute stress. So the new recommended guidelines really are, during a hospitalization of our patients, you give them IV 100 milligrams IV, continuous 200 milligrams IV for 24 hours, then Q6 50 milligrams IV, fluid resuscitation, and only taper them on an outpatient from the 50 to levels, taper them down to their normal replacement doses. Great guidelines. We use it now routinely for hospitalized patients with AI. But where are we going? People still die of adrenal crisis, maybe 40,000 cases per year in the US and UK. So what do we do? Well, we know a lot about the genetics, as I mentioned now, of primary adrenal failure. And I would argue that the future, in the next 50 seconds, the primary diseases of the adrenal cortex, particularly these monogenic diseases, are primed for cell and gene-based therapy. And that's where we're going for these patients with primary adrenal failure. So it's time to change the paradigm from Vesalius to Eustachius and build new adrenal glands. And the future is bright because we can almost do it now. We know that dexamethasone causes atrophy of the adrenal. That just shows you the red cortex atrophying and recovering. The adrenal repopulates itself every 60 days, like the gut in human beings, every 60 days. We've studied this for years. We know about the progenitor cells in the adrenal. They're green. They sit in the glomerulosa, and they give rise to the whole cortex every 60 days. So in the last 8 seconds, I'll just show you that we now can isolate these cells. We can take these progenitors out and watch them differentiate in culture to glomerulosa cells, to fasciculata cells. This is where the field is going. We can even study them. We can study them in single-cell dishes, watch them differentiate. Colleagues at University of Pennsylvania can make mini adrenal glands in a dish with induced pluripotent cells. So this is where we're going. We can even inject them back into the adrenal and watch them live. You can put them in little plastic bubbles and watch them live in mice and animals. So we're getting there. We're not there yet, but there's even companies now trying to exploit this technology, these biologies we've discovered. So it's exciting times, and in the next 5 to 10 years, we'll be there. So I'm going to close with that and just say thank you very much for your attention. Always ground your questions in the best science. Always, one more, last video, it's 2 seconds long.
Being diagnosed with low adrenaline levels was devastating. No one ever warned me about adrenalitis, so I never saw it coming. There's times when you need adrenaline, and I didn't have it. That's when a friend who had beaten adrenalitis recommended the all-new 245 horsepower V6 Toyota Tacoma with the TRD package. Knocked it right out. That truck saved my life.
The all-new Tacoma. Now that's moving you forward.
So let's look forward to progress. Thank you very much.
Professor Hammer, you can come and join us here for the question and answer session later on after the second talk. Over to you.
So before I introduce the next speaker, I would request the people who are there at the end of the hall, please don't have your small conversations here. Please go outside. It's quite disturbing for us over here. The people who are there in the end of the hall, please move outside to have your small conversations. Don't have them here. Please close the door on your way out, please. Okay, so we go to the next topic, where we'll be talking about the newer diagnostic and therapeutic options in AVP deficiency. And for that, we would like to welcome Professor Miriam Kreiskrein from Basel. So Basel, as we know, is a city which is very beautiful. It's known for its health. It's known for its education, a very exciteful football team as well. And yeah, so right now we are here to listen about AVP, and that's what we're going to do.
Thank you very much. Does that work? It's a great honor for me to be here. Thank you for the invitation. I must say I'm very impressed by your society, not only scientifically, but also by your dancing qualities, which I have seen yesterday evening at the Colors of India. So it's my pleasure to talk here about new diagnostic and therapeutic options in AVP deficiency, which was formerly known to be central diabetes insipidus. And just before I go into the topic of the differential diagnosis, I would like to give you some perspective why we decided to rename diabetes insipidus. So this is a historical perspective, and the name diabetes actually means to pass through, and this was created already by the ancient Greeks, and only much later, in 1674, a Sir Thomas Willis discovered that there are two different forms. One had sweet and one had urine without taste. And again, 100 years or more later, Johann Peter Frank discovered the two different forms. It is diabetes mellitus and diabetes insipidus. And only in the 19th to 20th century, there was actually the discovery of these two different hormones involved in these diseases, namely insulin and vasopressin. But despite this clearly distinct pathophysiology of these two different diseases, there was confusion between diabetes mellitus and insipidus. And the most famous and also most tragic confusion was this case of Kane, which was reported in BBC News. This was a 22-year-old patient from the UK with diabetes insipidus who died after a routine hip operation, as he did not receive any desmopressin and also no fluids, despite being nil by mouth, and instead he got several glucose measurements. But it's not only this tragic case, but we also did a survey in more than 1,000 patients with diabetes insipidus, and very briefly, what we found is that in fact 80% of patients reported that their health professionals had confused their condition with the diabetes mellitus on at least one occasion, which led, for example, to a diabetes diet or to regular glucose measurements. And not very surprisingly, 85% following this survey wanted to have a name change, especially without the word diabetes in the name. One suggested name of the patients, for example, what fish out of water disease, of course not a very professional name, but I think it mirrors how these patients feel in real life. So in the following, we built up an international working group consisting of many societies, endocrine societies worldwide. And as you can imagine, we had several discussions about what this new name could be. And then we published this consensus in the different endocrine journals, again worldwide, with the suggestion that central diabetes insipidus should become now vasopressin deficiency, and nephrogenic diabetes insipidus should become vasopressin resistance. And this new name directly mirrors the pathophysiology of the disease and also indirectly how you should treat the disease. So with that brief excursion, I come back to the differential diagnosis of a patient with polyuria and polydipsia syndrome. So as soon as you have excluded osmotic diuresis because of the other diabetes, we have to differentiate basically these three entities. On the left side, central diabetes insipidus, now vasopressin deficiency, where you have a lack of vasopressin production or secretion from the hypothalamus or posterior pituitary, which leads to polyuria and consecutively to polydipsia. On the other hand, here in the middle, you have vasopressin resistance, where you have a renal insensitivity towards the action of vasopressin, also leading to polyuria and polydipsia. And lastly, you have also primary polydipsia, where there is an excessive thirst leading to polydipsia, and this consecutively triggers polyuria. So symptoms in all these three entities are very similar. It's polyuria and polydipsia. Concerning the etiologies, this is a table. I will not go into detail, but in general, in AVP deficiency, it can be trauma, like surgery or injury. It can be neoplasia, like craniopharyngioma, vascular, or also granulomatous diseases or hypophysitis. And the most common reason for AVP resistance is treatment with lithium, and can also, of course, for AVP deficiency and AVP resistance, it can have genetic causes. So in going back to this panel with the three entities, as mentioned, symptoms, polyuria, polydipsia, are very similar. And therefore, the differentiation is difficult, but on the other hand, it's also very important because the treatment is also different in these three diseases. And if you have the wrong treatment, it can have dangerous complications. For example, if you treat a patient with primary polydipsia because of a wrong diagnosis with exogenous desmopressin, it can lead to dangerous water intoxication. So I would like to show you three patient cases. First patient is a 77-year-old male patient with the onset of polyuria and polydipsia around 4 liters per day following a viral infection. Nicturia once to twice per night, no large volumes. Past medical history had lithium for more than 30 years for bipolar disorder, but he stopped it 1 year ago. HbA1c is 5.9%, calcium, potassium is normal, as are also the anterior pituitary axis. Patient number 2 is a 29-year-old male patient, has a 6-year history of polyuria and polydipsia, around 12 liters per day, with around 16 episodes of voiding during the day, also during the night. Family history is negative, HbA1c is normal, calcium, potassium, anterior pituitary axis are normal, pituitary MRI is normal, and the water deprivation test is non-diagnostic as it shows a maximum urine osmolality after thirsting of 540 millimole per kilogram. Sodium is normal with 142 millimole per liter. And the third patient is a 50-year-old female patient, has a 6 months history of polyuria and polydipsia of 5 to 6 liters per day, nicturia at night around 1 liter or more, increased tiredness, HbA1c is normal, but anterior pituitary is deficient with secondary hypogonadism and hypothyroidism. Baseline sodium is 146 millimole per liter, and the bright spot is lacking in the MRI. So what do these 3 patients have, and how should we do the differential diagnosis? Now, normally, if we have a patient where we suspect hypotonic polyuria, we have to confirm this, and if it's confirmed and if it's hypotonic, for many decades, the next step was to do a stimulation test, and this was the water deprivation test. And my first question is, how can we avoid a water deprivation test? How can we try to diagnose these patients already with baseline values? And this is a study which we recently published, and where we looked at a development cohort consisting of patients with vasopressin deficiency and primary polydipsia, and then we validated it in a validation cohort. And what we basically looked at is baseline sodium, baseline osmolality, and baseline cupeptin, and also baseline signs and symptoms. So a very simple first message. If sodium levels were above 145 millimole per liter at baseline in the development cohort, this ruled in AVP deficiency in this cohort. And again, that was confirmed in the validation cohort. On the other hand, if sodium was below the reference range, was below 135 millimole per liter, that ruled out and ruled in primary polydipsia, again confirmed in the validation cohort. We also looked at cupeptin, and very briefly, because I think it's quite well known by now, but cupeptin belongs to the same precursor hormone than vasopressin, which is pro-vasopressin. And this is then spliced into vasopressin, neurophysin 2, and cupeptin. And cupeptin, in contrast to vasopressin, can quite easily be measured with a commercially available assay, which is a sandwich immunoassay, and it's quite stable and reliable to measure. And you see on the right panel that the correlation between vasopressin and cupeptin is very strong, which means that if we measure cupeptin, we know indirectly about the concentration of vasopressin in the circulation. So we also looked at cupeptin in this development cohort, and if cupeptin was above 5.6 picomole per liter, again, this ruled out AVP deficiency and pointed to primary polydipsia, confirmed again in the validation cohort. There is not only baseline lab exams, there is also signs and symptoms of a patient. And we built a score with baseline lab results, but also with nicturia more than 3 times per night, nighttime drinking exceeding 1 liter, a sudden onset of polyuria and polydipsia, and the presence of anterior pituitary dysfunction or surgery. And without going into detail for this score, but applying for a high sensitivity and high specificity cutoff, enabled to diagnose around 70% of patients with all these baseline labs and signs and symptoms only, which means that only 30% of patients have to really undergo further testing by a stimulation test. A brief word to AVP resistance, because also here a measurement of cupeptin can be very helpful. And this was shown in this study, where you clearly see that in all patients with AVP resistance, cupeptin is already increased at baseline. So all cupeptin levels were above 21.4 picomole per liter and can be identified with a baseline measurement of cupeptin. And this was confirmed in a study by another group more recently, where also these 5 patients in this study with AVP resistance had increased and clearly increased cupeptin levels. So therefore, we proposed the following algorithm. We proposed that you do a baseline exam without thirsting, measuring sodium, cupeptin, and asking the clinical questions. If cupeptin is very high, it points to AVP resistance. If sodium is below 135 and or cupeptin is above 5.6 and you have clear clinical symptoms, it points to primary polydipsia. On the other hand, if sodium is above 145 and you have clear clinical signs and symptoms, this points to AVP deficiency. So patient number 1, which I've shown you, of course he had lithium, so it's suggestive for AVP resistance. You measure copeptin, and in this patient it was 64.8 picomole per liter, which confirms the diagnosis. So you don't need any further testing, and this patient has AVP resistance. Patient number 3 had a sodium of 146 millimole per liter and clear clinical symptoms with nycturia exceeding 1 liter and anterior pituitary deficiency. So this patient has AVP deficiency. You don't need to do any further testing. On the other hand, what do you do if copeptin is below 5.6 and you have unclear clinical scores? So this applies to patient number 2. Baseline sodium is 142, copeptin 2.3. You have nycturia, high amounts of voiding, but no anterior pituitary deficiency. So what do you do in this patient? So this patient is one who needs a stimulation test. And the question is now, what stimulation test should you do? Now, as already mentioned, for many decades, the gold standard for a stimulation test was the water deprivation test. And the concept in this test is that you indirectly measure vasopressin, indirectly because the direct measurement is not very reliable, and you measure that by looking at the urine concentration upon thirsting, which according to most protocols is a 17 hours of thirsting period. I will not go into detail for the interpretation of this test, which goes back to a study of Miller and et al. 1970, but it's important to say that the test can be very cumbersome for patients because they have to thirst for at least 17 hours, and despite this, it has only a limited diagnostic accuracy of around 70%. So what alternatives do we have? And in a first study, we aimed to prospectively validate copeptin for the differential diagnosis of these patients. The aim of the study was to do a head-to-head comparison of the diagnostic accuracy of copeptin after osmotic stimulation with a simple 3% saline infusion and with the classical water deprivation test. We included 156 patients with AVP deficiency or primary polydipsia in 11 study centers in Switzerland, Germany, and Brazil. And you see here the test protocol, which was an initial bolus of hypertonic saline within 15 minutes and then an infusion per body weight until sodium levels reach the level of 150 millimole per liter. And afterwards, the patient should drink and receive glucose 5% until sodium is normalized. And the water deprivation test was done according to the normal protocol. So this is the results of this study, and you see on the left side is the hypertonic saline test, where in patients with primary polydipsia there is a significant increase in copeptin upon hypertonic saline, which is not seen in most patients with AVP deficiency. And you see on the right side the water deprivation test, where this is much more overlapping. And this points to the main problem of the water deprivation test. Despite the 17 hours of thirsting, the osmotic stimulation is not high enough to really stimulate vasopressin or copeptin levels. So accordingly, the diagnostic accuracy of the hypertonic saline plus copeptin test was 96.5% and was superior to the water deprivation test. However, as mentioned, you have to increase sodium levels to 150, which means you have to monitor your sodium levels every half an hour at least, which is not possible in all hospitals. And also, because of this increase in sodium, there is some side effects like malaise, headache, and also, of course, thirst. So we therefore looked at a non-osmotic stimulus, which is arginine. And arginine, you know it from stimulation of the anterior pituitary, especially growth hormone, but the effect on the posterior pituitary so far was not known. And as seen in this graph on the right, upon arginine, there is also a significant increase in copeptin in primary polydipsia, in blue here, not as strong as with hypertonic saline, but still significant, which is not seen within AVP deficiency. So with a cutoff of copeptin of 3.8 picomole per liter, this arginine test also had a 92% and 93% sensitivity and specificity. And the test was much better tolerated with only a very little side effects. So in the next step, we did a prospective head-to-head comparison to know which of these tests should now be the new gold standard for this differential diagnosis. And our hypothesis was, comparing arginine and hypertonic saline, that arginine would be non-inferior to hypertonic saline, but would be better tolerated. So this is the main results. Hypertonic saline, as you see in this table, was confirmed to have a very high diagnostic accuracy of 95% with in yellow AVP deficiency against primary polydipsia, clear differentiation between the two groups. However, and against our hypothesis, arginine was inferior to the hypertonic saline test with a diagnostic accuracy of only around 74%. So therefore, the conclusion of this paper was that AVP deficiency was more accurately diagnosed with hypertonic saline-stimulated copeptin than with arginine-stimulated copeptin. So is arginine testing out for this indication? I don't think so, because if you look into more detail, then if upon arginine copeptin was above 5.2 picomole per liter, this identified patients with primary polydipsia with more than 90% specificity, and conversely, if a copeptin remained below 3 picomole per liter, this identified patients with AVP deficiency with more than 90% specificity. And overall, with these two cutoffs, you could identify around 50% of patients. So coming back to this algorithm, in these unclear situations where you have to do a stimulation test, if there is the possibility to regularly control sodium levels and there is no contraindications for the hypertonic saline test, this is the test with the best diagnostic accuracy with a cutoff of 4.9. Below this points to vasopressin deficiency, above to primary polydipsia. If you do not have the possibility to control sodium levels and/or there are contraindications for hypertonic saline, the arginine test can be done with these two cutoffs of 3 and 5.2 to identify around, as mentioned, 50% of patients. And of course, if you do not have copeptin, you can still do the good old water deprivation test. So this is patient number 2. This patient underwent a hypertonic saline test, and upon this test, copeptin increased to 29.2 picomole per liter, which identified this patient as primary polydipsia. Now let's have a short look into the future. Because arginine is inferior, hypertonic saline has its side effects, and you have to monitor sodium levels. So we also looked at urea, which is the advantage that you can take this orally. So it's an oral stimulation test. And urea is also quite weak, but it's an osmotic stimulus. And what we did is our patients drank 30 grams of urea together with orange juice. And as you see on the left panel, upon urea, copeptin also increased in primary polydipsia, and it remained low in AVP deficiency. This panel and the figure looks quite similar to arginine. But this was a small study, and of course these cutoffs and the sensitivity and specificity have to be confirmed in a larger study. And I think the most promising new test could be mannitol. And this is not unpublished results, but what we did here, because mannitol is also a strong osmotic stimulus, but it does not increase sodium levels. So you do not have to control and to monitor sodium levels. So what we did is that we gave 1.5 gram per kilogram body weight of 20% mannitol, infused over 30 minutes, and then we measured copeptin after 30 minutes. So plasma osmolality with that increased to around 300 to 310 millismol per kilogram. So what you see here is that upon mannitol, again, in patients with primary polydipsia, there is a significant increase, and it was much more pronounced than after arginine or after urea, a bit weaker than with hypertonic saline, but it increased in primary polydipsia and it remained low in patients with AVP deficiency. And the advantage is this was already seen after 30 minutes. Hypertonic saline needs around 2 to 3 hours. And also on the right panel, you see that with a cutoff of around 5.7 picomole per liter, there is a clear differentiation between primary polydipsia and AVP deficiency with a 100% sensitivity and specificity. Of course, again, this is a pilot study with only few patients, and it has to be confirmed again in a larger, even multi-center study. Now, what about treatment of these patients? And treatment of AVP deficiency is quite straightforward. We treat them with exogenous desmopressin, which is available as tablet, nasal spray, or as a melt tablet. You see here a table with the approximate starting doses and also with the approximate equivalence doses. So if you want to switch from one application to the other. Usually we start at night time, at bedtime, so the patient does not have symptoms at night, and then if needed, you add a morning dose. The most important side effect of exogenous desmopressin is the risk of hyponatremia, which has been reported to be around 27% for mild hyponatremia and 15% for more profound hyponatremia. So therefore, it is very important to instruct the patients about a desmopressin escape method, which means that the patient should delay the next dose of desmopressin, either with every dose, once daily, once per week, or several times per week. That depends a bit on the frequency of hyponatremia, until aquaresis occurs and the patient feels thirsty again. And with that desmopressin escape method, and that's what we have shown in this survey, you can significantly decrease the incidence and the frequency of hyponatremia in a patient. As you see in this graph, those patients who told us that they regularly performed desmopressin escape, they had a lower frequency of hyponatremia than those patients who were aware of the method but did not apply it, or those patients who have never heard of desmopressin escape. So my message here is you should inform first, if you start treatment with desmopressin, you should inform the patients about symptoms of hyponatremia, and you should instruct them how to perform the desmopressin escape method. So, and this is my last slide. I'm too fast, I see. So the patients with vasopressin deficiency are treated with desmopressin, as mentioned, quite straightforward, and usually the symptoms like polyuria, polydipsia are rapidly resolved. However, what is known, and this is known from several studies, that these patients, despite treatment with desmopressin, have several neuropsychological symptoms. And the question is therefore, could that be due to an additional oxytocin deficiency? And this will be discussed in my talk this afternoon. I invite you to be there. So therefore, in summary now, for the new diagnostic and therapeutic options in vasopressin deficiency, for the diagnosis, you should try to diagnose with baseline exams only, based on history, on sodium and copeptin levels. If sodium is below 135, it indicates primary polydipsia. Above 145, AVP deficiency or AVP resistance. If copeptin is above 21 picomole per liter, it points to AVP resistance. Above 5.6 picomole per liter to primary polydipsia, and below 5.6 picomole per liter, you need to do a stimulation test. The hypertonic saline test with copeptin measurement is the best available diagnostic test. Arginine has a lower accuracy but can still be done with the adapted cutoffs. The water deprivation test can still be done, and alternatives maybe in the future is urea or a mannitol. For treatment, the treatment is desmopressin you should be aware of the risk for hyponatremia and inform patients about symptoms of hyponatremia and a desmopressin escape, and perhaps a new treatment in the future for these patients could also be oxytocin. And with that, I thank my research group and I thank you for your attention.
Miriam, please come and join us. I think we have time till 12:30 for question answer session. So we had very nice discussions on two glands, adrenal and the posterior pituitary. So if you have any questions, adrenal insufficiency or on AVP deficiency, or if you want, you can ask resistance as well, I presume. If there are no questions, I'll start with Miriam first. Copeptin is the buzzword, right? So can you tell us a little bit about copeptin assays? What are the nonces? What are the chances of false positivity, false negativity? I mean, it looks very nice, 21 and 5.6, but I think in real life, it's not so easy. So can you just share your thoughts on that?
Yeah, that's a very, very important and good question. So first of all, I would like to mention there is different assays as well. And all these studies I have shown you were done with the Brahms Cryptor assay. So if you use an ELISA assay, which is more broadly available, you have to be very careful, and you cannot use the same cutoffs than I have shown you, because usually this assay with ELISA shows higher values. But I know from the company that this Cryptor copeptin assay is available in India, so it should be possible to measure. And then concerning real life, yes, there is first renal insufficiency, which leads to falsely high copeptin levels because it's renally eliminated. So in a mild renal insufficiency shouldn't be a problem, but if it's a more strong, a more heavy renal insufficiency, you have to be careful. And also copeptin, like vasopressin, is a stress hormone. So if you are stressed, the levels are increased. So if you have a patient with a very high copeptin, still it should not be AVP deficiency. But a patient with primary polydipsia can easily have a copeptin of 30, which does not point to AVP resistance. So this is the most important thing. You have to look in a pre-analytical setting at a non-stressed patient. Or if the patient comes in stressed, lay down and wait for 30 minutes, and then you do the test results.
I think we have time only for one last question. So, Dr. Sujay Mujumdar, please.
Yeah, excellent presentation. My question is, how do you manage the AVP resistance?
Yeah, also very important. It's much more difficult than AVP deficiency. So usually the first treatment is that you give a low sodium and low protein diet to reduce osmotic diuresis. Then you can try in lithium AVP resistance, you can try with amyloid, which enters like the same cells than lithium, and then the treatment usually is good. Importantly, you have to monitor lithium levels in these patients because they can increase if you start the treatment with amyloid. And then also thiazide use, diuretics can be done.
So essentially with the standard diuretics, that's what you do, like thiazides and amyloid, as you were saying. That's what you do, isn't it?
Yeah. Exactly.
Thank you.
So I have a question about adrenal insufficiency. So what is the protocol that you would like to use while treating pregnant women, especially the fludrocortisone dose as well as the hydrocortisone dose during the various trimesters of pregnancy? And what is the role of a short synactin test, that is 1 microgram AV?
Those are tough questions.
ACTH test.
So in pregnancy, you oftentimes need more cortisol. We don't have one protocol, but we watch it very carefully, and they oftentimes need increased dosing of Cortef. Florinef, I don't change much during pregnancy. I don't see a lot of pregnant women these days. The 1 microgram test, it can be used and give you a little more sensitivity. I don't have a lot to say. We don't use it very often. We use the 250. There may be others who, we can talk later, who use the 1 microgram more than I do. But that's about all. On those issues, I'm not really an expert in terms of the high-risk pregnancies, other than we watch them very carefully and they need a little more Cortef, depending on the individual patient.
Thank you to both of you, and I think it was a great session. I think they all deserve another round of applause, please.
Thank you, sir and ma'am. We would now move on to our next session, which is Conundrums in Cushing's Syndrome. And for this session, I would like to call upon Dr. Ankit Srivastav, sir, and Dr. Sujoy Majumdar, sir, to chair this session. Over to the chairs.
Good afternoon, everybody. From the domain of the Cushing's and the AVP, we will now move on to a little more details about the Cushing's. So we've got the first speaker, Dr. Ramaya Rajan, who is an associate professor in the Department of Endocrinology, Diabetes and Metabolism at CMC Vellore. A very well-known and then speaker, so I would really invite her to talk about the molecular genetics about the diagnosis of Cushing's syndrome.
Thank you, sir, for that kind introduction. At the outset, I would like to thank the ESICON team for giving me this opportunity. In fact, I'm privileged to be sharing my session with my teacher and mentor, Professor Asha, and I'm extremely thankful to the organizing team for this. So I'll be talking on molecular imaging in Cushing's syndrome, the present and the future. This will be the outline of my talk. I'll start with the current diagnostic algorithm, which is being used for diagnosis of, especially I'll be concentrating on ACTH-dependent Cushing's syndrome here. For ACTH-dependent Cushing's syndrome, then we'll move on to the need for the molecular testing, molecular imaging, and then we will delve into the various molecular imaging options which are available to us. And finally, I'll end with, when we have an ideal molecular imaging, how is the diagnostic algorithm going to be modified? So as we all know, 90% of the corticosteroid tumors are in the pituitary, and these are microadenomas. With the current advances in the imaging technique, the sensitivity of detecting a tumor has increased to about 70%. However, a major proportion do not have a visible tumor, and even with a visible tumor, most often we end up having a subset where the tumor size is more than 6 millimeter. So as we all know, whenever the tumor size is less than 6 millimeter, currently bilateral inferior petrosal sinus sampling remains the gold standard for tumor localization. And this has a sensitivity of more than 90% in correctly localizing the tumor. However, it has its own challenges. So now let's look at this case capsule. This is a 16-year-old boy who presented with weight gain, proximal myopathy, height faltering, and newly diagnosed hypertension. On examination, his height was at 3rd centile, he was obese, and he had discriminatory features of Cushing's syndrome. On evaluation, it was confirmed that he had ACTH-dependent Cushing's syndrome, and the high-dose dexamethasone suppression test with 8 mg dexamethasone showed more than 50% suppression. However, when we look at the imaging, it's striking that there are 2 lesions in the MRI measuring about 3 to 4 millimeter, one on the right side of the cella and one on the left side of the cella. Now the question comes, what do we do next? This is the diagnostic algorithm which we use in our center for a ACTH-dependent Cushing's syndrome. So remember, in Cushing's syndrome, the clinical findings and the clinical presentation has to be taken into consideration to determine the pre-test probability before we interpret any diagnostic testing. So when there is an ACTH-dependent Cushing's syndrome, we do look at high-dose dexamethasone and MRI pituitary. We don't have CRH and injection desmopressin available. And when the high-dose dexamethasone suppression test shows more than 50% suppression, and the MRI shows a lesion which is more than 6 millimeter, with clinical findings and presentation very much typical of Cushing's disease, we go ahead with transnasal surgery, that's a pituitary surgery. However, when we have a mixed clinical presentation here, where the clinical findings and the presentation may be in favor of ectopic Cushing's, we do a functional imaging more often or a CT thorax abdomen to rule out an ectopic etiology mainly here, and when it is negative, we go ahead with pituitary surgery. However, if the functional imaging is positive, then we go ahead with IPSS. Similarly, when there is a discordance between high-dose dexamethasone suppression test and the MRI pituitary, again IPSS becomes the next step in our center. And also when we have a picture where it is more in favor of ectopic Cushing's with unsuppressed high-dose dexamethasone, MRI pituitary being normal or having an equivocal finding, gallium DOTA will be the next step where we will look at the ectopic tumors, and if found positive, we'll go ahead with surgery. If negative, again IPSS becomes the next line. So in the case which we saw, that there is a discordance between the high-dose dexamethasone and MRI pituitary, and hence here IPSS becomes the next step. So what are the challenges with IPSS? It's invasive. There is a differential anatomy of petrosal sinus in up to 20% of the patient, 20% of the subjects, which makes its interpretation complicated. It requires a high level of technical skill for successful cannulation, hence this becomes a major important limiting factor, limiting its availability in centers. However, even if we are localizing, as we saw that the sensitivity is more than 90% for localizing the source of ACTH, even if we localize, the lateralization, the sensitivity for lateralizing a tumor within the cella ranges in studies from as low as 50% to about 70%. And this could definitely hamper the success rate of the surgery despite localizing the source of ACTH to the pituitary correctly. So this is a systematic review of 12 studies where they looked at surgical strategies. How did surgical strategies determine the outcomes of pituitary surgery in cases with MRI negative pituitary imaging? So basically, more than 80% of these patients, it included more than 400 subjects, and more than 80% of these patients had IPSS, and the source of ACTH was localized to the pituitary. However, despite that, what is very evident from the slides is that the success rate of surgery were somewhere hovering around 60 to 70%. And that's why we need a molecular imaging. So now we know that even with all the possible modalities, corticotropinomas are not well delineated in the cella in about 30 to 40% of the cases, and this is definitely going to affect the intraoperative navigation for selective tumor excision, and also it could affect the remission rate following surgery. Molecular imaging work on the principle that these tumors, especially corticotropinomas and the ectopic ACTH secreting neuroendocrine tumors, express variety of target receptors, and these target receptors are being exploited or targeting in developing the molecular imaging. So what is ideal molecular imaging? An ideal molecular imaging is something which shows a focal and specific uptake, very specific for corticotrope tumors or ectopic ACTH secreting neuroendocrine tumors. Thereby, this should help in accurate tumor localization during surgery, prior to surgery. Also very important is that it should help in localizing recurrent corticotrope tumors where the challenge is much more because the prior surgery would have altered the entire anatomy of the cella. So what are the various molecular imaging options available for Cushing's syndrome? I have highlighted them in different colors because the first two techniques, they work on the same principle that they are taken up into the cell through L-amino acid transporter. Next comes the two molecules which are very specific for corticotrope tumors, and the last three have been studied not only in corticotrope tumors but also in adrenal Cushing's and ACTH secreting ectopic tumors, ectopic neuroendocrine tumors. So coming to the first molecule, in fact, when we look at the literature regarding this, the widely studied one is C11 methionine. It's not only studied in Cushing's, but it's also studied in somatotropic tumors. Methionine is an amino acid which is involved in protein synthesis, and it is taken into the cell by an active transport through L-amino acid transporter. So when I say active transport, naturally it is taken up avidly into the cell which has high metabolism, and higher the metabolic rate in a tumor, higher will be the uptake. So it is taken up by both pituitary, normally by the pituitary itself, because the tumor has a higher metabolism when compared to the normal pituitary. The tumor will light up much more than the surrounding normal pituitary. So when we look at the various studies which have looked at the diagnostic accuracy, when I'm looking at a molecular imaging, I will be keenly interested in how do they perform when the MRI is showing a tumor which is less than 6 millimeter, or when the MRI is negative. So we have studies ranging from 2015 to a latest study which has come in 2025. In fact, the latest study attracted me more, which included 22 patients with recurrent or persistent Cushing disease following a surgery. And they found that the diagnostic accuracy of this imaging in detecting a tumor which is less than 6 millimeter is close to 70%, and when it comes to MRI negative, this is about 55%. What are the challenges with C11 methionine? As we all know, most of the pituitary tumors, they are relatively benign tumors, and as so is the corticotropic tumors. They are very slow growing, and hence definitely the metabolic activity within the tumor is not that as a malignancy. So hence this creates a lower tumor to background ratio, thereby decreasing the pickup rate, and also it requires a cyclotron for generation. Coming to the next molecule, which is F-fluoroethyl L-tyrosine PET, again taken up by L-amino acid transporter and it enters the cell, and it acts on the same principle as C11 methionine acts. However, when we look at the studies in it, we have only a single study. It is widely studied in brain tumors, but in corticotropes, there is only a single study, very handful of cases, 9 cases, which is telling that it is 100%. And maybe before going ahead with this, we need much more data on this. And it has the same drawbacks as that of the C11 methionine. So now coming to the next two molecules are very specific for corticotropes, maybe very unique because they are from India. So this is talking about this gallium DOTA CRH. We all know that though the corticotrope tumors are autonomous, they do retain the responsiveness to CRH. They express CRH1 receptors. That is evident by the fact that we use CRH stimulation test where following CRH injection, there is elevation in the ACTH level, which means that the tumors are still responsive to CRH. So because these tumors express CRH1, tagging the CRH with a gallium will help in focally delineating these tumors within the cella. So we have a single study from PGH Chandigarh by Dr. Ramawalia, where they have looked at 27 patients with Cushing's syndrome, which included also 10 patients who had tumor size less than 6 millimeter, and they demonstrated 100% diagnostic efficacy. So this is one case from the PG. I have taken her permission to show this. So this is a 46-year-old lady with ACTH-dependent Cushing syndrome who have a normal cella. In the imaging, the cella is normal. There is no focal uptake or focal lesions there. However, when they use the DOTA CRH PET, there is a focal uptake on the right side of the cella. In fact, by IPSS, this was localized to the pituitary and the lateralization was to the left. But during surgery, they found that the tumor was found on the right side, and after excision, the patient attained remission. Now coming to the second molecule, which is again specific to corticotropinomas, the gallium-68 modified desmopet. So the corticotumors highly express vasopressin 1b or 2 receptors in comparison to the surrounding tissues. They are not much expressed in the surrounding normal pituitary, and modifying a desmopressin and tagging it to gallium will again help in focally delineating these tumors within the pituitary. So This is again a study from PJ Chandigarh by Dr. Walia, where there were 30 patients they have studied 30 patients with ACTH-dependent Cushing syndrome, and they found demonstrated 100% diagnostic accuracy in predicting in localizing the tumor. This is a picture of a 48-year-old lady with ACTH-dependent Cushing syndrome showing no definite lesion in the cella. However, what we can see is that you should look at the white arrow pointing towards the tumor in the cella. One of the limitation which I found with this molecule is that there is, because of the pooling of blood in the cavernous sinus, because of the blood, it will light up in the cella as well. So we should be very careful in picking up. And also one of the challenges with this molecular imaging is co-registering. It is because corticotropes are microadenomas. We are looking for tumors which are less than 5 millimeters here, and hence, instead of being co-registered with CT, usually that is how it happens, PETs are fused with CT, it needs to be co-registered with an MRI to pick up such smaller tumors. So when we look at the advantages, pros and cons of gallium CRH and modified Desmo, they are very specific for corticotrope pitnets. However, CRH is now not available not only in India as well as globally. And when it comes to modified Desmo PET, it's not available in any other center except for one center in India, and the availability becomes a major limiting factor here. Now moving on to gallium DOTA PET, which we are all very familiar about, their utility is very, very much higher in picking up ACTH-dependent, ectopic ACTH secreting tumor, a neuroendocrine tumor. So we all know that well-differentiated neuroendocrine tumors usually they express somatostatin receptors, and hence radio labeling as somatostatin analog will help us in picking up these tumors. So when we look at the literature, the sensitivity of these scan in picking up ectopic ACTH secreting tumor ranges somewhere from 70 to 80%. However, most often what literature writes and what I have listened to in talks is that it has 100% sensitivity in picking up covert and overt ectopic neuroendocrine tumors, which is not really true in real life experience. In fact, over the last 2 years, we have encountered 3 cases of ectopic ACTH secreting tumors which were DOTA non-avid. So this is one case of a 26-year-old lady with ACTH-dependent Cushing syndrome who has very typical features of ectopic Cushing's. The IPSS localized it to ectopic source. However, because the source was not localized, initially she underwent bilateral adrenalectomy. She presented to us 4 years after bilateral adrenalectomy, where the DOTA picked up the lesion to the thymic carcinoid and the tumor was removed. So this is one of the interesting cases, a 55-year-old lady with ACTH-dependent Cushing syndrome. She was also worked up outside and she presented to us. On evaluation, she had equivocal findings, some findings in favor of Cushing's disease, some in favor of ectopic Cushing's. So her short duration of symptoms was really striking, which was favoring ectopic Cushing's. However, she had mild hypokalemia, not a very profound, mild hypokalemia of 3.4 milliequivalents, and her ACTH levels were 95. In fact, in most of her ectopic, what we have found is that in our series of 21 patients, the median ACTH level was 200. So we were not really thinking of ectopic here. So however, her DOTA was outside, it was negative. So we proceeded with IPSS, where we localized the source to be ectopic. And when we went ahead and looked back at her images, we picked up this big lesion. In fact, it was a learning for us. We picked up the lesion in the lung, and this was operated, and she attained remission. So this is a second lady, another lady with DOTA non-avid ectopic tumor, 40-year-old lady, very typical features of ectopic Cushing's, not unsuppressed HTTSD, profound hypokalemia, very high ACTH levels of 215 picogram per ml. Again, DOTA was non-avid. However, when we carefully looked at the images, there was a 1.5 centimeter lesion sitting in the lung, after a removal of which rendered her in remission. Now coming to FDG PET, which is a very widely used functional imaging, not for corticotrope tumors, but in general when it comes to tumors. So this works on the principle that increased glucose uptake in non-functioning and hormone-secreting pituitary adenomas, and there will be minimal uptake in the normal pituitary. However, the cellular uptake can be found. It's very difficult to delineate the tumor from the cellular, the normal pituitary, when it comes to FDG PET. That is very evident from the study. Being widely used functional imaging, we have multiple studies which have been done with FDG PET. In fact, there has been a study in which they have done CRH stimulated FDG, the third study in the table. However, when we look at the diagnostic capacity, it is dismal. Diagnostic accuracy is not great, that we can tell that this is not useful clinically for diagnosing, for localizing corticotropinomas. So now coming to gallium pentacifur, this is something which came as a surprise to me also. Like now it is well known that this molecule is useful in localizing primary hyperaldosteronism. It binds to the chemokine receptor, which are overexpressed in functioning tumors, be it adrenal, where the hormone secretes more cortisol, or aldosterone, or be it be pituitary. So there were two studies, interesting study from China. Both the studies were from China, but from two different centers. Initial one was a pilot which had just a handful of cases of 7 Cushing's disease, where they found the diagnostic accuracy of about 66%. However, they have recently published one on 43 cases with Cushing's disease, in which 11 were MRI negative, and it gives a diagnostic accuracy of 81%. This is something because gallium pentacifur is available with us actually. At least there are some centers which have gallium pentacifur. This is something which can be explored in the diagnosis of Cushing's. So now, again, reiterating the question again, what is an ideal molecular imaging? There should be a focal and specific uptake in corticotropic pituitary tumors. It should help in accurate tumor localization prior to surgery, and also it should help in localizing recurrent corticotropic tumors where the anatomy is altered by the previous surgery. And also it's very important because we are dealing with microadenomas. It has to be co-registered with MRI. It is a cumbersome task, but however, these tumors are rare tumors, not very common ones, so it is possible. So, and availability. So when we put all these together, so what are the ideal molecular techniques, imagings we have? The gallium CRH, gallium modified desmo, and also probably gallium pentacifur, which needs to be studied. However, what stands out here is that the availability of the initial two ones, because it's available only in a single center in India, but still we are lucky enough to have a single center, and also these have limited data, and hence there is much more data has to evolve. I'm sure that is going to come in the long run. So now this is the old diagnostic algorithm which I showed. And how is an ideal molecular imaging going to change the diagnostic algorithm? Definitely, whenever there is a diagnostic dilemma initially, the ideal molecular imaging can be considered. And if you are not getting an answer with the imaging, then IPSS can be restricted to that small population who we have equivocal results even with a molecular imaging. So to conclude, I'll summarize saying that molecular imaging is an emerging tool for non-invasive, precise localization of ACTH-dependent Cushing's syndrome. C11-methionine is something which has been widely studied for a long duration, and it has shown a diagnostic accuracy of about 55 to 70%, especially in MRI-negative equivocal imaging and in recurrent tumors. Gallium CRH PET, modified desmo PET, and also gallium pentacifur show promise in identifying microcorticotropinomas. However, the limited availability and the limited data remains the major challenge for its wider clinical use. Thank you.
Thank you. Would you like to take a seat here, please?
Good afternoon. I would like to invite the next speaker, another professor from CMC Vellore. So Dr. Asha has worked extensively on the pituitary gland, and we are going to hear from her on a disease that is always difficult for the patient, a Cushing's disease which has recurred after an operation.
Thank you. Good afternoon. At the outset, I would like to thank the organizers for giving me this opportunity to talk about an important topic which we deal with almost on a regular basis. That's about Cushing's disease after failed transsphenoidal surgery. How do we approach these patients? So as we are all aware, the incidence of Cushing's is about 6 to 8 per million per year. It is associated with significant morbidity and mortality to the patients who are affected. And among all the causes of Cushing's, it is Cushing's disease due to a pituitary adenoma, which is the most common etiology. The main goals of treatment would be to eliminate the cortisol excess, control the tumor, and to maintain normal pituitary function. And transsphenoidal surgery is the first choice of treatment for these patients. Neurosurgical techniques have evolved over the years, and this has led to better outcomes for patients with Cushing's disease following transsphenoidal surgery. Following a successful surgery, these patients develop a transient phase of glucocorticoid deficiency, which needs glucocorticoid replacement. The consensus guidelines recommend that patients with Cushing's disease undergo surgery in specialized pituitary tumor centers of excellence, where at least 20 surgeries for Cushing's are done every year by an experienced neurosurgeon, and they should be followed up in a multidisciplinary team with an endocrinologist at the fulcrum. So I'll just start with a case. This was a 28-year-old lady who came to us initially in 2018 with progressive symptoms suggestive of Cushing's syndrome over a period of 5 years. Examination and biochemical evaluation confirmed ACTH-dependent Cushing's disease, and on MRI, there was a tumor adjacent to the internal carotid artery, which was completely encasing the left internal carotid artery. So she underwent transnasal transsphenoidal excision of the pituitary tumor, and as expected, in view of encasement of the internal carotid on the left side, she did not attain remission following surgery. So she was started on ketoconazole and was followed up. After 6 months of follow-up, she continued to be hypercortisolemic with elevated serum and urinary cortisol levels. So we shall discuss about management of such a patient. And so the first point to note is that remission following surgery, the definition is a cortisol decline to less than 2 to 5 microgram per deciliter within the first week following surgery. And we should also keep it in mind that patients whose cortisol levels were controlled with medical therapy before surgery, those with cyclical Cushing's and those with mild hypercortisolism may go back to a eucortisolemic state without developing postoperative hypocortisolemia. A small proportion of patients, about 6 to 20%, may develop a delayed remission within 6 months following surgery. And the factors predicting remission are surgery by an experienced surgeon, a tumor detectable on MRI, which is a microadenoma, and non-invasive. Complications following transsphenoidal surgery include new onset hypopituitarism, permanent AVP deficiency, CSF leak, and rarely venous thromboembolism. Again, complications are lesser with an experienced neurosurgeon, and the perioperative mortality is less than 1%. So this was a study done at our center where the impact of the surgeon's experience on surgical outcomes and postoperative complications were studied. A single surgeon operated 203 patients with acromegaly over a period of 11 years. These were divided into his first 100 surgeries and the subsequent 101 surgeries. And what was noted was the surgical remission improved by 20% in acromegaly patients operated by the single surgeon after his 100 surgeries. And again, the factors affecting surgical remission were mainly the surgeon's experience, cavernous sinus invasion, and preoperative growth hormone levels. Rates of CSF leak and hypopituitarism were also significantly lesser in the second half. Coming to the Indian studies that have reported remission in Cushing's syndrome, the large case series have been from AIMS, CMC Vellore, KEM, and a recent publication from Jaipur. So the remission rates reported in all these studies ranges from 66 to 80%, and in the largest study from KEM, with a long follow-up of at least of a median follow-up of 6 years, the relapse rate was about 41%. Looking at a meta-analysis reporting the data on outcome of remission of Cushing's disease following transsphenoidal surgery, reporting 5,600 patients, the remission rates following initial surgery were about 80%, which drops to about 58% with repeat surgeries. Surgical mortality, CSF leak, and AVP deficiency were also more common among patients having repeat surgery as compared to those having their first surgery. Again, primary transsphenoidal surgery was associated with less recurrence, about 18% compared to 28% recurrence following revision transsphenoidal surgeries, and recurrence was again more common among macroadenomas and those who had a higher postoperative cortisol levels. Looking at the consensus guidelines 2021, what do we do when we have a patient who does not attain remission following surgery? So the guidelines recommend 3 approaches, either a repeat transsphenoidal surgery, if a lesion is visible on an MRI, medical treatment, or radiotherapy. And subsequently, if a patient does not respond to this, then bilateral adrenalectomy would have to be resorted to. So in this situation, treatment would have to be individualized based on the patient characteristics and the requirement. A second transsphenoidal surgery, as discussed, has more complication rates, lesser rates of remission. Radiation therapy is also effective in controlling hypercortisolism, but there is a lag period. Medications are useful, but tolerance, availability, and cost have to be discussed. And bilateral adrenalectomy is the last resort when it is not controlled by the other measures, or in women desiring pregnancy where radiation therapy carries a risk of delayed hypogonadism and some of the medications are unsafe during pregnancy. Looking at the outcomes of repeat transsphenoidal surgery, the remission rates reported range between 42 to 83%, and recurrence rates are higher for macroadenomas at about 45%. And higher remission rates were achieved where surgeries were done by an experienced surgeon. How do we improve the outcomes? First of all, better imaging modalities. This has been discussed in detail just now, and functional imaging may help us as well. Radiotherapy is the second line option or the third line option in some situations after repeat transsphenoidal surgery or failed medical therapy. Advances in the radiotherapy techniques over the last decade again have improved the outcomes with lesser adverse effects. The indications are intolerance to medical treatment, a progressively growing tumor, Nelson syndrome, or upfront RT in certain situations. The effect of radiation therapy in normalizing hypercortisolism to achieve biochemical control has been found to be about 50 to 70% for stereotactic radiosurgery and a higher remission rate of 70 to 85% with fractionated RT. But fractionated RT carries a higher risk of delayed hypopituitarism. There is a lag period of about 3 to 4 years before the effects are seen. Radiological tumor control is seen in more than 90%, with a small risk of optic neuropathy, cranial neuropathies, and second brain tumors following radiotherapy. Recurrence has been reported in about 21% of these patients. Studies have also shown that use of medical therapy around the time of radiotherapy has been associated with increased relapse rates. This is a study from KEM which showed that cabergoline use around the time of RT was associated with relapse rates, increased relapse rates, and similarly use of ketoconazole around the time of RT has been shown to be associated with decreased remission or increased relapse, especially in childhood Cushing's. So the current understanding is that we should withhold anti-secretory medications for at least 4 to 12 weeks before giving RT, and especially so if the patient's clinical condition is stable and this does not cause harmful clinical deterioration. So this was a meta-analysis comparing repeat surgery versus radiotherapy in patients having persistent Cushing's, and both were found to be similarly efficacious, though the impact of radiotherapy in controlling hypercortisolism progressively improved with time. There were some relapses noted following repeat transsphenoidal surgery. With regard to medical treatment, again, the goals of treatment here are to restore eucortisolemia, improve the comorbidities and quality of life, and controlling the adenoma growth. And the potential indications, again, are failed transsphenoidal surgery, high-risk surgical candidates, or even bridge therapy until the radiation therapy takes effect. And of course, to control the acute complications of severe hypercortisolemia in patients who are yet to be treated. So the medical therapy would target 3 areas. Either it could target the pituitary tumor itself. So in this category, we have the somatostatin analogs acting on the SSTR5, that is pasireotide. We cannot use somatostatin 2 receptor analogs because they are downregulated in the presence of hypercortisolism. We also have cabergoline that acts on the D2 receptors, and temozolomide, which prevents tumor growth by causing DNA damage. We also have multiple drugs that act on different pathways, blocking adrenal cortisol synthesis, and we also have the glucocorticoid receptor antagonists, mifepristone and relacorilant. So among the pituitary-directed therapies, the one with the highest efficacy is pasireotide, which is given, the short-acting form is given as subcutaneous twice daily, or the long-acting preparation given as once monthly IM injections. The control of hypercortisolism is achieved in about 68% of patients on long-term follow-up, and the tumor volume reduction has been noted in about 41%. A major adverse effect of pasireotide is hyperglycemia, which is difficult to control, in addition to GI side effects and prolongation of QT interval. It is the preferred medication in the presence of a large residual tumor, especially if the patient does not have hyperglycemia. In Cushing's disease, cabergoline has been used with an efficacy ranging from 23 to 40%, but the problem is about 1/3 of the patients escape from the treatment effect and revert back to a hypercortisolemic state. Adverse effects are nausea, dizziness, orthostatic hypotension. The various adrenal-directed therapies block adrenal cortisol synthetic enzymes along the pathway from cholesterol to cortisol synthesis. These include ketoconazole, which acts on side chain cleavage enzyme, 17-alpha hydroxylase, as well as 11-beta hydroxylase. We also have metirapone, mitotane, etomidate, oscillodrostat, all of which act on the 11-hydroxylase. And again, mitotane acting on multiple enzymes along the pathway. So the largest French study which assessed the efficacy of ketoconazole looked at its efficacy in 200 patients with Cushing's syndrome, and the median dose used was 600 to 800 milligram per day, which showed an efficacy of 50% in lowering cortisol levels, but about 15% had treatment escape in the course of the study. The major adverse effect is hepatotoxicity, male hypogonadism, and development of adrenal insufficiency. Because the drug acts very fast, we would see adrenal insufficiency as early as 4 days to 2 weeks following initiation of therapy. Levoketoconazole is a stereoisomer of ketoconazole, which even potently inhibits the enzymes in the cortisol synthesis pathway, which we discussed. Efficacy again is about 50% and acts in about 3 to 4 weeks. The most potent drug in this category of adrenal cortisol synthesis inhibitors is oscillodrostat. The LINK-3 and LINK-4 trials, along with their follow-up extension studies, have shown 80% efficacy in terms of lowering cortisol with this drug. The main limiting adverse effects are quick development of adrenal insufficiency and glucocorticoid withdrawal syndrome. Prolonged QTC is something which we have to monitor in these patients. Mitotane is a long-acting drug, an adrenolytic, which is mostly used in adrenal cancer, which was discussed today morning. It has a slow onset of action and a narrow therapeutic window. It affects the hepatic cytochrome enzymes, increases various binding proteins, as well as HMG-CoA reductase activity. The adverse effects, again, are a limiting factor in the use of this drug, mainly GI and neurotoxicity, along with male hypogonadism, hepatotoxicity, increased cholesterol, etc. Monitoring cortisol levels is also a challenge in these patients because of increased CBG, cortisol levels will be high, urinary cortisol excretion is increased, and hence salivary cortisol alone is useful for monitoring these patients. Metyrapone is another drug in this class which acts very quickly and efficacy rate of about 47% in lowering cortisol. Again, the adverse effects are hypokalemia, hypertension, and edema. In this class, we have a very quick acting drug that is etomidate, which is an IV anesthetic drug, which is used as an IV infusion, mostly in an ICU setting, to quickly lower cortisol and correct the metabolic abnormalities before sending a patient with severe Cushing's for surgery. The adverse effects are mostly sedation, adrenal insufficiency, and reduced respiratory drive because this is an anesthetic agent. Mifepristone is a glucocorticoid receptor antagonist which has been used in various studies and shown efficacy of about 60 to 80% in terms of controlling the symptoms of hypercortisolemia. It being a receptor antagonist, we cannot use cortisol or ACTH levels to assess response to therapy. It is based on clinical and metabolic effects only. Again, the adverse effects are hypertension and hypokalemia. And it is a long-acting drug and it takes at least 2 weeks to get eliminated from the circulation. Treatment of hypocortisolemia following mifepristone again is challenging and has to be treated with dexamethasone because it's a receptor blocker. Various combination treatments are also being studied, drugs acting at various pathways, mainly the pituitary and the adrenal, when used together, improve the efficacy of cortisol lowering to about 60 to 80%. There are also studies which have looked at sequential therapy starting with pasireotide, subsequently adding cabergoline and ketoconazole, which have been shown to improve the efficacy of medical treatment to control hypercortisolism. We also need to keep in mind that a small proportion of corticotroph tumors can behave very aggressively, especially the Krug cell tumors and also the silent corticotroph tumors which are non-secretory. And in this situation, temozolomide could be used as a medical therapy to control the tumor growth, and response rate is about 65% in these patients. The predictors of response are functioning tumors, concomitant radiotherapy used with temozolomide, and those having low or intermediate expression of MGMT. In small studies, various other therapies have also been looked at, especially the immune checkpoint inhibitors and the VEGF inhibitors for aggressive corticotroph tumors with limited efficacy. Several novel agents are also on the pipeline, mainly ACTH antagonist, geftinib, relacorilant, which is a selective glucocorticoid receptor antagonist, and 11-beta HSD1 inhibitor as well. In monitoring patients on medical treatment, we would assess their clinical response periodically along with monitoring their biochemical response with serum, urinary or salivary cortisol levels. And also we monitor for the drug adverse effects of the drugs, as we have just alluded to. And also when using adrenal directed therapies, we have to keep in mind that the ACTH secreting tumor may grow in a small proportion of patients, about 30%, and so we need to monitor the ACTH levels every 6 months and do an MRI at least once a year in these patients. Now, which regimen do we use? In patients with less severe Cushing's, we would do a titration regimen, that is, start with a small dose and increase the dose by periodic monitoring of cortisol levels. But if you have a patient with severe Cushing's, then a block and replacement therapy would be appropriate, especially with a fast-acting agent which would quickly control the cortisol levels. In fact, it is advised to even add a second agent within the first week of starting the first therapy to quickly control the cortisol levels. Availability and cost are other limiting factors with regard to medical therapy. Currently, levoketoconazole, osilotrostat, and pasireotide are not available in India, but they can be imported, again with higher cost. Mitotane and metyrapone are again very, very expensive and difficult for most patients to afford. Bilateral adrenalectomy would be considered a last option when cortisol levels are not controlled by all the other therapies. It can also be done as an elective procedure in women planning pregnancy or those after failed therapies. Emergency bilateral adrenalectomy is recommended in patients who have life-threatening complications like recurrent bacteremia, sepsis, thromboembolic complications, severe myopathy, and psychosis. The preparation for a bilateral adrenalectomy should be done with medical therapy to control the cortisol levels and the metabolic derangements. The efficacy is 100% in terms of lowering cortisol, but surgical morbidity is 15% and mortality of 3%. There is a long-term risk of adrenal crisis in about 4 to 9 per 100 patient years, and also a 30% risk of corticotroph tumor progression because of the absence of negative feedback on the pituitary tumor. So coming back to the case which I discussed, 6 months following surgery, she still remained hypercortisolemic, and on an MRI there was a doubtful residue below the left cavernous sinus. We were not sure about proceeding for surgery, also because the residual tumor was below the internal carotid artery and was not amenable for surgery. She was 30 years at that time, and she was planning pregnancy. Hence, we decided to advise bilateral adrenalectomy for her to preserve her pituitary function. She had regular menstrual cycles, and it was planned that she would undergo radiotherapy after she has a baby. But after adrenalectomy, this patient was lost to follow-up. She comes back after 5 years with progressive severe hyperpigmentation and weight loss. Her ACTH was 2,400 picogram per ml. She had continued the glucocorticoid and mineralocorticoid replacement. There was a residual lesion below the left internal carotid which was increasing in size, and so she was diagnosed to have Nelson syndrome, underwent hypofractionated stereotactic radiotherapy, and is currently continuing glucocorticoid and mineralocorticoid replacement. Just to show you a case of aggressive Cushing's disease whom we are struggling to manage over the years. This patient also came to us in 2018 with progressive Cushingoid features, clinically, biochemically confirmed to have ACTH-dependent Cushing's disease due to a small pituitary tumor on the left side, just adjacent to the left internal carotid artery. He quickly attained remission following his first transsphenoidal surgery within 48 hours, and the biopsy also showed a corticotroph tumor with a MIB1 index of 4%. Subsequently, he has had multiple recurrences over this period of 7 years, requiring 3 transsphenoidal surgeries, 2 times stereotactic radiosurgery, along with temozolomide, proton therapy in the last year, and this is the most recent MRI just done last week, where he has developed hemiparesis due to tumor extension into the brainstem. Just this April he had surgery, and again the tumor has grown back hugely, and he just underwent transcranial surgery yesterday. So to summarize, the management of persistent Cushing's is challenging. The management approach would have to be individualized based on the patient factors, severity of hypercortisolism, aggressiveness of the tumor, tolerance to medications and the limiting adverse effects, and availability of expertise as to where the patient is getting treated. A multidisciplinary team approach is always the key to management, and among patients who fail surgery, medical treatment would be the first, and if there is a delineable lesion seen on the repeat MRI, then a repeat transsphenoidal surgery could be considered as the first treatment option. The other options being radiotherapy and bilateral adrenalectomy if none of the other treatments work. Thank you.
So you can kindly join us for the discussion. It's good that we have finished ahead of time. So if there are any queries or anybody wants to ask any question.
Please identify yourself.
Yeah, myself, Dr. Khandelwal. I'm practicing at Akola, practicing endocrinologist there. My question to Dr. Asha, I have a patient who underwent this bilateral adrenalectomy and now has a ACTH levels which are very high and a Nelson syndrome. but she refuses to undergo a MRI and a radiation therapy. So what's your experience? Her question to me is, what will happen if I suppose don't take any of these treatments, because my life already I've spent around 25 years with this Nelson syndrome. So any experience?
So in such a situation, if she is not willing for an MRI, at least a CT scan can be done to see how big the tumor is and what is its proximity to the optic apparatus. So in this situation, if she is not worried about the hyperpigmentation, our concern is about the vision, which should not be impaired. So that could be one thing that can be done. And if she can afford and diabetes is not a problem, pasireotide is an option, but again, it has to be imported. The other option is to use cabergoline. We have been using cabergoline long term in some of these patients. Even up to 10 years we have used, and the tumor has been under control.
Thank you.
Yes, sir.
Yeah. Good morning, ma'am. Happy Teachers' Day. Regarding the cases, 3 cases where it is ectopic KCTH and still DOTA negative, have you looked at the immunohistochemistry? How about the CRH and the ACTH in those tumors?
So all the 3 tumors were positive for ACTH staining. However, we don't have CRH staining available to look at in immunohistochemistry. And the striking thing is all of them, post-surgery, the ACTH levels came down, went into remission. So we don't have TRH level available to study the immunohistochemistry in the tumor.
So what is the experience with cabergoline and mifepristone in patients with Cushing's disease where ketoconazole is contraindicated?
Cabergoline, as you're aware, we have used in several patients. It does keep a tumor under control and also achieve eucortisolism in about 30-40% of patients, especially if they have mild Cushing's, that is if the hypercortisolemia is not very severe. Mifepristone we have used only in a few patients with severe Cushing's as one of the arm of multimodality treatment, medical treatment to control cortisol excess, the symptoms of cortisol excess.
Dr. Asha, may I ask you a question? What is your experience of using in this sort of a refractory Cushing's where basically they failed a surgery, you've tried a secondary TSS, and you're just resorting to, say, radio and chemo? Have you used them in combination? Like giving a pituitary irradiation plus these other agents. Have you used any experience with that?
Yes. See, when we give pituitary radiotherapy, it takes about 3 to 4 years for it to take effect. So we avoid any anti-secretory medication if the patient is stable for 3 months before and 6 months after the radiation, and subsequently we start them on medical therapy to control the cortisol.
Only if they failed in the pituitary radiation therapy?
No, radiation therapy effect will appear only after 3 to 4 years.
After 6 months, when you find they have not responded, only then you go for it.
Yes.
The other thing is that in one of your slides, you showed that basically you gave a combination of, I think, mifepristone and prednisolone. No, why not hydrocortisone? I'm sorry, not mifepristone. I think it was fludrocortisone and prednisolone. But why not simple hydrocortisone?
This patient had bilateral adrenalectomy, so she needs glucocorticoid as well as mineralocorticoid.
Yeah.
To have a good mineralocorticoid effect, you need to use a higher dose of hydrocortisone, which can again cause Cushingoid features.
Okay.
So for that reason,
Point
we
taken.
used.
Point taken. Yeah. So if there is no further question, I think we'll call this session to a close. Please give a big hand to both the speakers for an excellent deliberation. And I think I'll end the session and with my co-chairperson, I'll pass it on to them.
I think we should call the next chairpersons, please.
Thank you.
Thank you, sirs and madams, for the excellent session. So now moving on to the next session, it is pinpointing the source. And for this session, may I call upon the stage the chairpersons, Dr. Amitabh Hatwal and Dr. Vikrant Gatnatti, to kindly chair this session. Over to you, sir.
Hello. Yeah, very good afternoon to you all. We have a pre-lunch session, two interesting sessions, one on pituitary and one on adrenals. So I'd like to invite our first speaker, Dr. M.K. Garg, sir. Dr. M.K. Garg, sir, is ex-professor of Medicine and Endocrinology at FMC Pune. He is ex-professor and HOD of AIMS Jodhpur. He's been the past president of Uttar Pradesh Diabetes Association. He has multiple awards to his name, and it would be very nice to listen to him on this very rare interventional procedure which is done in endocrinology. Over to you, sir.
Thank you very much, sir. Really, lunch, pre-lunch, lunch and post-lunch sessions are very, very difficult. After lunch, if I am sleepy, I can understand all the audience will be less responsive, so my lecture made easy. So, basically, topic was given to me is bilateral inferior pituitary sampling. What are the challenges? And according to case-based situations. So, why we started? So first I will tell you about the case and then I will discuss the BIPs. So 19-year-old girl presented with features of the Cushing's, weight gain, hypertrichosis, menstrual irregularity and hypertension. She had the history of easy breathability, broad violaceous sky over the abdomen, thighs and the vaginal candidiasis. Examination with the classical features of the Cushing's like thinning of the scalp hair, mooning faces, facial plethora, hypertrichosis over the face, increased supraclavicular and dorsocervical fat pad, violaceous abdominal strata, thinning of the skin and the proximal muscle weakness. On investigation, she revealed the impaired glucose tolerance, DEXA revealed the low bone mineral density, basal cortisol was high, and overnight dexamethasone suppression was, again, cortisol was high. Low dose dexamethasone suppression test did not suppress the cortisol, and basal ACTH level was high. The high dose dexamethasone suppression decreased the cortisol value by 73%. So with this, imaging was normal, pituitary was normal. Because of the biochemical test, patient was diagnosed as a Cushing's disease and referred to neurosurgeons. And neurosurgeon refused the surgery because of the previously failed surgery. Because pituitary may sometimes may show incidentalloma. So you have the Cushing's, favoring the Cushing's disease, you go for surgery and the tumor is not removed and it's a failed surgery. So neurosurgeon was hesitant कि सर pituitary में तो कुछ भी नहीं दिखाई दे रहा है, पहले भी fail हो चुका हूँ, तो why do undergo the surgery? So now it is a young girl, what should I do? So what is next? To prove it is the bilateral inferior pituitary sinus sampling. And from the India, the data is very, very sparse. Because firstly, it is a very, very invasive procedure and require the expertise and associated risk factor. And cost is very high because of the ACTH test, procedure and international radiology at that time was little in infancy in India. And finally, there is non-availability of the CRH and desmopressin as described in the literature was not available in India to do the stimulation. So now, what to do? So now come to the basic thing, then I will come back to my case That Cushing syndrome was first described by the Harvey Cushing in 1912, and it is defined as the persistent and continuous hypercortisolemia, which may be endogenous or which may be exogenous. And clinical manifestations, as you know, classical, I have already described. Now, problem one comes to the case how to screen the patient. So for screening, we all do the overnight dexamethasone suppression test with 1 milligram of the dexamethasone at night. If morning cortisol, I have written the 3 values. When I was doing the MD, my Harrison says 5. When I was doing the DM, literature says 3. And post-DM value has come down to 1.8. So if it is more than 1.8, it suggests that patient might have the Cushing syndrome. Why the value is decreasing? The screening test, it must not miss any case. So we want to make it more sensitive. And the cortisol assay has also improved. That's why it is very, very important that we should not miss any case of the Cushing syndrome. That's why the value has been lowered, so that at lower value we must suspect and evaluate the patients. However, it may be positive in 10 to 15% of the cases, false positive. Why? Suppose you have given the patient, he has not taken the tablet. Tablet was spurious. He has taken the tablet, it has not got absorbed. Even if it has got absorbed, there is accelerated clearance. There may be the high cortisol binding protein levels, glucocorticoid resistance, as well as pseudo-Cushing's state, where it may be the falsely positive. Then we come to the late night salivary cortisol level, which is also a screening test or confirmatory test, where you do the 11 p.m. salivary cortisol. If value is less than 0.15 microgram per deciliter, it is unlikely. 1.5 to 3 is repeat test, and 0.3 and above, Cushing syndrome become likely, and its sensitivity specificity is pretty good. However, it can have the false positivity in hypertension, psychiatric illness, and advanced age. So every test of the Cushing's have because it is a rare disease, so they have the false positive or negative values. 24-hour unique cortisol, though cumbersome, if it is more than 100 microgram per 24 hours, it suggests Cushing syndrome, and sensitivity is pretty good, 95 to 100%. Specificity is little low, accuracy is 97%, but it's cumbersome. And if the collection is faulty, your reports are not to be believed. And it is also increased in the Cushing syndrome, pseudo-Cushing state, as well as the major depressive illnesses. Little 1 test, or you can low dose dexamethasone suppression test. If cortisol is after 2 days more than 1.8, it suggests the Cushing syndrome. Sensitivity specificity is pretty good, but it may have the false positive as previously noted, and false negative in case of the hypothyroidism and chronic renal failure. Problem 2. Now with this test, we have diagnosed the Cushing syndrome. Now we have to find the source, where from it is coming. It is ACTH dependent or it is ACTH independent. For that, you do the midnight cortisol and ACTH level. If the cortisol is high and ACTH is high, it is ACTH dependent. If ACTH is low, cortisol is high, ACTH independent, means the source is adrenal. So I leave the adrenal here because my topic is BIPS. So I will go toward the ACTH dependent. ACTH dependent is caused by either micro or macroadenoma in 90 to 95% of cases in the pituitary. But problem lies those 5 to 10% cases, which source may be ectopic. So if you diagnose wrongly, in ectopic you operate the pituitary, failed surgery, and still patient is symptomatic. So ectopic ACTH mostly comes from the carcinoid, may come from the medullary thyroid carcinoma, islet cell tumor, pheochromocytoma, so on and so forth. And it is very, very rare to have the ectopic CRH secreting tumors. So ectopic Cushing syndrome, though, may be suggested by the clinical features. What are those? Symptoms of less than 6 months duration, because it's a malignancy. They secrete a lot of ACTH. This is a rapidly progressive things. They have the rapid clinical course. They may have the weight loss. They have the hyperpigmentation because a lot of ACTH, recent onset hypertension, and impaired glucose tolerance, hypokalemia, and metabolic alkalosis. If these features are there, it may suggest that probably you are dealing with the ectopic ACTH source. So how to differentiate dependent and independent or source? So you have the Lidl 2 test, that is high dose dexamethasone suppression. So if there is a 50% suppression of the cortisol after giving the high dose of the dexamethasone, is 2 milligram, it suggests the pituitary source. Sensitivity is only 70%, but specificity is very, very good. Limitation is tumor sometimes secrete the pulsatility, fluctuations. So it may not, even the ectopic, you may know the basal is high, pulse has gone down, it gets suppressed. You think it is a pituitary, but it is not the pituitary. Carcinoid, they sometimes get suppressed, as well as some macroadenomas, which have the autonomous secretions, without any glucocorticoid receptors, they will not get suppressed. So it both way. Again, I told you, in Cushing syndrome, all tests have the positive and negative, and for the treatment, because it's surgical, it is very, very important to pinpoint the diagnosis. CRH test, because the pituitary adenoma have the CRH receptors. So if you give the CRH, there is increase in the ACTH by 50% and cortisol by 30%, suggests Cushing disease. If ACTH increases 100% and cortisol rises by 50%, it eliminates possibility of the ectopic ACTH. Imaging, 50% are positive for the microadenoma, but it may be false positive because of the incidentalomas. CT MRI to be done in case of the ectopic ACTH to rule out chest, thymus and pancreas. And somatostatin receptor scintigraphy has been done, and Dr. Rama has done the wonderful job by the gadolinium scintigraphy to locate the pituitary adenoma. So now what? As I told you, I have thought of going toward the BIPS. So it was first reported from the Walter Reed Hospital, USA in 1977. And after that, it was done unilateral. Then it came to the bilateral, reported in 1983, because they wanted to have the lateralizations. And I will tell you the other reason later on. And the CRH was used in BIPS in 1986. Sorry, technical fault. Over. So what is the rationale of the BIPS? First, I tell you, suppose I do the BIPS on you. Everybody is sitting here. Result will be positive. You are not a Cushing syndrome. So the normal corticotroph, once you do that, definitely, pituitary secreting ACTH, ACTH will be high, periphery will be low. So also the pseudo-Cushing syndrome, pituitary is normal. So you do the test, gradient will be there. So what is the rationale? Rationale is there in the Cushing syndrome, your cortisol is very high. And they will suppress the normal corticotrophs. So now the ACTH is only coming either by the ectopic source or by the adenoma. So now the source we are identifying. So once the normal corticotroph is suppressed and still gradient is showing, that means it is coming from the pituitary. And if there is no gradient, because tumor is there, they are secreting in the peripheral blood. So gradient will not be there. So if there is no gradient, it suggests source is probably ectopic. If gradient is there, it suggests that probably you are dealing with a serious secreting tumor. But again, caveat, as told that patient with Cushing syndrome, previous speaker has told, bilateral abdomen done, still patient is having the Cushing syndrome. And you think that I will do the BIPS. No, because once you have done the bilateral abdomen, cortisol is gone. The corticotroph which was suppressed, normal, they get activated. And you do the BIPS, gradient will be there. One more caveat. If you have the CRH secreting tumor, again CRH is going, acting on the pituitary. And ACT is coming from the pituitary. So you do the CRH secreting tumor, gradient will be there. So caveat is there that in case of the rare CRH secreting tumor, BIPS result may be falsely positive in spite of tumor being the ectopic. So these are the few caveats of the BIPS. Why bilateral? पहले ने unilateral किया था, आपने unilateral क्यों नहीं किया? Why you want bilateral? Because in 60% of the cases, the pituitary drains symmetrically on the both cavernous sinus. But rest of the cases, it may preferentially drain into the one side. So if it is draining on the one side, and if you are doing on other side, your results will not give the two results. It may be falsely negative. That's why bilateral is important. And bilateral also give you the gradient which help you in the lateralization, but again caveats are there. If there is a centrally located tumor, it may deviate on the both sides. Lateralization may be not there. If it is preferentially draining on the one side, tumor may suggest on that side, but tumor may be on the other side. I will come back to it later on. So, why CRH is given? Because the tumor secretes the ACTH intermittently. As I previously also told, fluctuation may be there. So by giving the CRH, you improve the sensitivity of the test which we wanted. That's why basal is important as well as the stimulation is important, because sometimes tumor secretion may be at nadir and you are doing the test may be negative. But by giving the CRH, you stimulate, hence it becomes the more sensitive. So what are the indications of the BIPS? As I told you, first line you read, it is the ACTH dependent hypercortisolemia should be confirmed. First you must be sure that it is a ACTH dependent Cushing syndrome. Then you do the Liddle 2 test. If it is positive and MRI is positive, you go for the surgery. But if the Liddle test is positive and MRI is negative, you code the BIPS as it was in my case. Needle test is again negative, but MRI is positive. Here, the consensus statement says that if your microadenoma is more than 6 millimeter, it suggests it has to be a pituitary microadenoma, and you can go for the surgery. If it is less than 6 millimeter, you go to the BIPS. If patient is clinically Cushing syndrome, Liddle negative, MRI negative, and adrenal is ruled out, you again go for the BIPS. Before going to the BIPS completely, you think about the anatomy. The pituitary have the small hypophyseal vein which from the plexus over the pituitary, which drains on the cavernous sinus on the both the side. And cavernous sinus drains into the inferior pituitary sinus, which drains into the internal jugular vein. So this is the red catheter. I will come back to this on the procedure. But anatomy is very, very important. Why? Because there is an anatomical variation in the drainage. Sometimes the one-sided inferior pituitary sinus may be hypoplastic. And suppose you are doing the unilaterally, your result will be negative. While on the other side, if it is hypoplastic and it is draining, it will show the wrong lateralization. So anatomical variation is very, very important. Second is plexiform inferior pituitary sinus, where it is not a vein, it is a plexiform. So it is draining differently. And that is the reason that anatomical variation should be delineated before you taking the sample. Procedure, because it is a teamwork, you require the interventional radiologists, anesthetists, endocrinologists, nurses, lab technicians, because at a time you are drawing the blood from the 4 places, 2 peripheral and 2 inferior pituitary. So 4 persons are drawing the blood. So it requires a lot of manpower. So informed consent, you go from the femoral vein, go to the inferior vena cava, right atrium, superior vena cava, internal jugular vein, and inferior pituitary sinus on the right side, because it is easy to cannulate. You put the dye, it goes to the cavernous sinus and the other side. It will delineate on the left side. So from left internal jugular vein, you can cannulate. And it will also delineate the anatomy. Blood has to be drawn very, very slowly. Because I have done the procedure, I know. हम जैसे होता ना पेरिफेरल वेन से लेकर खाट से ब्लड निकाल दिया, ब्लड नहीं आता, because it is a low pressure. It got collapsed. You have to wait very, very patiently to get into 1 to 1.5 ml of the blood. So it requires a very, very patience. It should be collected at 1 minute, 3 minutes, 5 minutes, and 10 minutes post-stimulation in the cold test tube. Always remember, ACTH is a very, very fragile peptide. So in the blood serum, there are peptidases are there, which degrade the ACTH. And in the cold atmosphere, they do not act. So always test tube has to be kept in the ice cubes. And blood drawn and put on the ice cubes, it has to be cold centrifuged. Complications during the procedure may occur as groin hematoma, you all know, contrast-induced nephropathy because using a lot of contrast, pulmonary thromboembolism. Suppose it is a, I told you, inferior pituitary sinus, which also drains the pons, pontomedullary junction and medulla. And these veins are very fragile. If you do the trauma, patient develops subarachnoid hemorrhage. Suppose procedure is long and your catheter is blocking those venous drainage, patient will develop the venous hemorrhage and there may lead to brain stem infarct, transient sixth-nerve palsy, obstructive hydrocephalus, and catheter-related complications. So when we did, this is the, you can see we have done the both side, they are easily drainage. Now I come back. So in India, when I planned this first time, CRH was not there, desmopressin was there. Now what to do? While reading the physiology, we have read in MBBS, also MD, DM, that vasopressin is a weak secretagogue of the ACTH. It acts synergistically with the CRH by the V3 receptor which is found on the corticotrophs. So we planned first time using the vasopressin in world to do the bilateral inferior pituitary sinus amnix. We injected only 1 unit diluted in the 10 ml of the saline over the 5 minutes the peripheral vein, and we took sampling differently, -5, 1, 5 and 10 minutes. As I told you, to circumvent the spurious result, and we were doing the first time, my lab technician was ready with the kit, ACTH assay to be done immediately. So we ran from the radiology after doing the test, came to the lab and immediately put the assay to get the right results. So as I told you, we have done the ACTH assay by the immunoradiometric assay by the Beckman Coulter, and intra-assay and intra-assay coefficient was less than 10%. To decide the source of the ACTH, if central to peripheral ratio at the basal level is 2, post-stimulation is more than 3, it suggests the pituitary source. Sensitivity is 97% because of the one thing, CRH producing tumors, and sensitivity is 100%. Lateralization can be done if the gradient is more than 1.5, but caveat is the drainage and the centrally placed tumor. So our results, if you can look at these results in the last line, -5, 1 minute, 5 minutes after vasopressin, and this, everything, it suggests that it is more than 2:1. So pituitary source was there. And so now I went to the neurosurgeon again. Look, we have done the BIPS first time. These are the results. Now he had no choice. We have proved it is coming from the pituitary. He went inside, and I can tell you, he did the selective adenocontromy without affecting the pituitary function. The tumor was removed. 6 post-op day, cortisol was less, and after 1 year, I could not recognize when she came to my OPD. All things were normal, and BMD has improved, menstrual cycle was normal, she has lost weight, and immunostaining of the tumor suggested the ACTH secreting pituitary tumor. In continuum, later on we did the 5 different cases, which was, you can see that was the MRI, CT abdomen, and one case was definitely bilateral PPNAD. Otherwise, all the case was diagnosed by the IPSS by vasopressin. So we had the continuum of the tumors, and we hope that this will flourish in India by using these methods. Thank you very much. It is my aims where I After retiring for the army, I worked, and these are the rainy days. In Rajasthan, Jodhpur, you don't see such type of the picture reflection in the AIMS. And thank you very much for the patient listening.
Thank you, Dr. Garg, for an excellent presentation. I think you were the first investigator to use vasopressin in India.
India, outside also nobody used.
All right, outside also. But now they have started using lysine vasopressin. There have recently been 2 reports. They have used lysine instead of arginine vasopressin.
Yeah.
They have shown good results. One from Chandigarh and one from Rajasthan, I think.
Yeah.
So any questions regarding pituitary
Sir,
tumor?
We have done, sir, MRI, pituitary, we have done this procedure, CT chest, CT abdomen. Still we don't able to localize the lesion. Sir, what to do?
I told you BIPS.
BIPS we have done, sir, it came negative.
BIPS has come negative.
We were not able to localize it.
Okay.
We are done in Surat. Interventional radiologists are there, sir.
Okay, now question is, MRI is normal, your tests are normal, and your BIPS is normal. That means most likely source may be the periphery occult tumor. There are the many cases of the Cushing syndrome where the tumor is so occult or small you may not be able to localize. So you give the treatment with the medical therapy, follow up the patients, or you go for the scintigraphy. Sometimes scintigraphy may pick up the small lesions in thymus, pancreas, or bronchioles. So these are the another things which you can go at the PET CT, which may pick up the small lesions somewhere in thymus, pancreas, or bronchial carcinoma. Then you have to follow it up. Because at that time, if the patient is totally uncontrolled, you do the medical therapy and go for the bilateral adenotomy if you want to do the things. Otherwise, you follow it up on the medical therapy. Someday, somewhere, it will show off. That's the answer.
Sir, how to confirm the catheter tips are actually in the right position bilaterally?
Look at the interventional radiologists, as I told you, they keep on injecting the small dye. And they pass through the internal jugular. It goes to the cavernous sinus on the left side, comes through the petrosal sinus. They track the catheter through that and reach the other side.
Is there any objective way of confirming it?
Yeah, there is not an objective way because they know the anatomy. They know it is in inferior petrosal sinus. So suppose if you say surgeon, sir, I have operated for the appendixectomy, and you ask the surgeon, how do you know it is appendix? So surgeon knows where it is. So radiologists know where the inferior petrosal sinus is.
So I think in response to that question, I would add that people are now doing serum prolactin in addition to...
Sir, वो मैं कहना चाहता था, but serum prolactin के लिए भी it will not tell it is in inferior petrosal sinus. It will only tell the gradient and the ratio. You can correct the ACTG ratio with the prolactin. But I've seen results are not very, very encouraging with that. That's why I omitted prolactin correction part. Otherwise, prolactin ratio of 1.8 from central to the periphery, they suggest that your procedure was right. That's all. It will never tell you that catheter was in the inferior petrosal sinus. That is the thing.
Good afternoon, sir.
Yes, please.
Good afternoon, sir. Sir, I'm Dr. Pooja from Department of Endocrinology, GMC and Super Speciality Nagpur. We have an endogenous hypercortisolemia case. MRI is actually partial empty cella with a very small rim visible. The ectopic we have done only CT, abdomen and thorax. It's negative. So should we go ahead with BIPS for this patient? There's a partial empty.
Look, empty cella does not exclude the microadenoma. It may be in the ectopic location, as you have seen in the previous case. So, what my advice would be, send to the PGI Chandigarh to speak with the Dr. Ramais here. Second is the gadolinium nuclear imaging. They sometimes may pinpoint the Cushing's disease, where the adenoma may be the ectopic site of the pituitary. Okay. So that can be the possibility, or there is an ectopic source. Right? So you can do the BIPS. You know that, yes, if it is BIPS, it is pituitary. then definitely you can go for the gadolinium scanning. But if it is negative, then you are again not sure, because that tumor may be draining somewhere else rather than cavernous sinus. So if it is positive, helpful; negative, again you are unsure.
Yes. Thank you, sir.
Sir, I really appreciate the case you presented. Sir, one question I wanted to ask, the role of DEX-CRH, how would you place in the investigating of your case? Dexamethasone suppression with CRH stimulation. Sir.
Look, you know, test मैं नाम literature में पढ़ के बहुत गिना सकता हूँ, but what is the standardized is CRH test. You can do the dexamethasone suppression and again do the CRH test, right? So normal case में it will not stimulate, but in case of the Cushing disease, it is going to stimulate. So all concept remain the suppression and stimulation.
Sir, any particular additional significance in your case, or it won't help us anyway?
I've seen the literature. Yeah. It is not going to, somebody might say 95% sensitivity, somebody say 98%. So it is hardly a matter of 1 or 2%. But in a given case, you are not able to decide.
Yeah. Thank you, sir.
Any more questions? We still have some time. Dr. Garg has finished well in time.
Thank you, sir. Thank you very much.
Thank you, sir. Excellent presentation. And I would now invite the next speaker. Dr. Kishore Kumar Behra. Dr. Kishore is an experienced endocrinologist with a number of national and international publications. He has been winner of prestigious A.V. Gandhi Award and has also won awards for best papers and posters. And he is a member of various organizations. So we'll be looking forward to your approach to
Thank you, sir, for this kind introduction. And at the outset, I will be very grateful to SECON 2025 team, and particularly Professor Sujit Ghosh to inviting me and to give a lecture in this prestigious gathering. So I'll be talking about the advances in the molecular imaging of the diagnosis of primary aldosteronism. As you know, this is a condition where probably to distinguish between the unilateral aldosterone producing adenoma or bilateral aldosterone producing hyperplasia leading to bilateral aldosterone production will be important because the treatment option is differ in between two. So I'll be covering the introduction, limitation of ABS and CT, why you want to do the imaging to better localization, and the latest development of the functional molecular imaging in the diagnosis of primary aldosteronism, and a few case scenario which has been done in our institution, AIMS Bhubaneswar. So I'll throw light that how this Pentaxi4, the only test usually we do in our institution, how it is helpful to localizing and to cater the treatment, and at the end the conclusion. As you know, this primary aldosteronism is a pathologic form of aldosterone characterized by renin and angiotensin 2 independent aldosterone production that is relatively non-suppressible. And it is a manifestation across a broad continuum. Thus, the PA is best considered a syndrome rather than a binary disease. And as you know, this is a syndrome which is contribute to cardiovascular and kidney morbidity and mortality. And in the recent, probably more than 15 to 20 years, and it has been shown most of the authors in this field, and particularly the Vaidya et al., they've shown that the pathogenesis of PA have shown that it's largely driven by the pathogenic somatic mutation. They may progress to across the lifespan and occasionally merge to neoplasia to create the most severe form of neoplastic primary aldosteronism. And if you'll see this primary aldosteronism in all hypertension constitutes about 15%. If you have a resistant hypertension, probably the prevalence is quite high. And even it is more higher if you have got the liberalized criteria to define the overt PA, because if you'll see the criteria is defined from the different guideline too, so it's very difficult to predict what is the exact prevalence, but what we see probably it is more. And why we want to investigate, you can see there is this long-term health impact of the cardiovascular disease risk, kidney disease, and metabolic disease risk, which leads to increased morbidity and mortality. That's why you have to investigate properly, localize properly, and to cater the best treatment available. So these are the high-risk population where you want to look for the primary aldosteronism screening and to get the diagnosis. The patient with severe or resistant hypercalcemia associated with hypokalemia, or hypertension with adrenal mass, or hypertension with sleep apnea, atrial fibrillation, or a strong personal history of family history. So if you see, probably this is the one disease probably having in a high-risk population also, the screening we are not doing at our best. I think you can see the screening is below 2%, and in the most industrialized country like USA or Canada or Japan. And also, this implies that much fewer than 1% of the high-risk patients are ever diagnosed with primary aldosteronism. So this is the pragmatic diagnostic approach for all clinicians. Probably we have a high-risk population with severe hypertension associated with hypokalemia, adrenal mass. So you have in a setting of suppressed renin, you have an aldosterone 15 nanogram per dl about primary aldosteronism, no need for the confirmatory test. You can straight away localize and go for adrenectomy. If 5 to 15, so probably primary aldosterone only otherwise proven. And if aldosterone is less than 5, probably the primary aldosterone is unlikely. You have to look for low renin, low aldosterone, like Cushing's or Liddle syndrome. You have to look at, and you will investigate in the proper line. So the subtyping of primary aldosterone is very important, because if it's a unilateral, then you can go for the surgery. If the bilateral, probably the mineralocortical receptor agonist may be the choice. And you can see in the research constraint setting, probably in the most of the institution in India, probably the first images of choice to localizing any adrenal mass in the CT scan, and probably in primary aldosterone, sometimes difficult to identify if the lesion is less than 1 centimeter. And also the current guidelines says probably in all cases of primary hyperaldosteronism, probably you have to go for ABS, but there is a technical demanding and invasive procedure. So you need a better localizing modality. And why a need for that? You can see this is a study which has been shown. The challenges with the CT scan, Young and colleague et al. Found that relying solely of CT scan imaging would have led to 21%, 7% of patients being incorrectly excluded from the adrenectomy, and around 25% undergoing unnecessary surgery. And the Kemper et al. Also shown that this 37.8% discrepancy between the ABS and the CT result, which could have resulted in inappropriate treatment decision. So due to the challenges in the performing of ABS, and some patients may undergo adrenectomy based on the CT finding when ABS is either unavailable or unsuccessful. And ABS got its own limitation of challenging even the best center in Mayo Clinic with a dedicated radiologist. Probably the successful cannulization in a tune of around 90 to 92%. It's never 100%. And there is a ACTS stimulation may reduce the lateralization index, resulting in some patient with unilateral PA falsely classified having bilateral PA. And also the result of ABS may be confounded by cortisol co-secreting APA, which is not uncommon. We will be discussing one of our patients. And also it's a very high cost. You will see it's a relatively high cost than the nuclear imaging and CT scan. So in summarizing, the limitation of ABS, non-invasive alternative, we have to choose higher success rate with the nuclear imaging, about 100% technical success rate compared to ABS failure rate of 5 to 30%. Functional localization directly images functioning of adrenal cortical tissue using radio-labeled analogs, and providing lateralization index based on the quantitative uptake measurements. And it can also identify less than 1 centimeter functioning adenoma missed by CT. And it's got a very good accuracy when comparing with the ABS, and clinical advantage and the cost effectiveness leads to look for better molecular imaging. So I will be discussing mostly of the second generation about the gallium pentoxy-4, and we will touch upon few lines about the C11 intermediate PET, and I will not discuss in this talk about the cholesterol analog for the diagnosis of the primary aldosterone producing adenoma. So these are the pentoxy-4, and the second, the mito or ito, basically it depends upon the enzyme which is be there, 11 hydroxylase B2 or B1. So according to that you can find out the tumor localization. So coming to the pentoxy-4 selecting imaging. So this is a chemoreceptor type 4 which is expressed on the surface of the cell membrane belonging to the chemokines receptor family, which expressed by many cells during the development of adulthood, but it is quite upregulated in aldosterone producing tissue, but it's almost negligible in the non-functional adenoma. And if we'll tag with the gallium pentoxy-4 is a specific ligand for this chemokines receptor 4, and it has been shown that the hypomethylation of CPCR related gene leads to upregulation of messenger RNA of the GPCR and increase the transcription, which leads to overproduction of excessive aldosterone in PA. So the gallium pentoxy-4 is a radio label tracer showing high specificity and affinity for this receptor, and it will tag with PET imaging may be useful tool for non-invasive characterization of primary aldosterone in adrenal lesion, and it was much better, superior than the 11 carbon metomidate. So it has been shown that it has got a very good accuracy in the recent study published in JAMA. So aldosterone cortisone ratio in adrenal vein was positively correlated with the SUV max of the adrenal gland at 10 minutes during the PET CT, and the diagnosis accuracy of PET scan and ABS in the tune of 90%. So it is very good, accurate, but this, so it's a very good test. And another study, it has been shown that to investigate the diagnostic efficacy and prognostic value of gallium 68 pentoxy PET CT in comparison with the adrenal vein sampling, and it is shown that there is a consistency of 77% between ABS and the gallium pentoxy-4, and you can see that both gallium pentoxy-4 and ABS examination consistently, accurately identified 13 cases of unilateral primary adenoma and 7 cases of BPA. And when the specific uptake value ratio has been taken, like lesion and SUV to the normal liver SUV mean, that is LLR, and the lesional SUV to the contralateral adrenal tissue SUV, that is LCR, and the maximum standardized uptake, that is SUV of the adrenal lesion, it is found that if you, for diagnosis of UPA, the LLR has a higher area under the curve than the PET, than the other uptake value of PET CT and ABS lateralization. So if you take a cutoff point of SUV of 5.7, was calculated by ROC analyzing, yielding a sensitivity and specificity in the tune of 80% and specificity of 100% respectively. So coming to the case scenario, which we have seen the 8 cases in our institution, and this is the algorithm we have used to diagnose. I think in this gathering, you know all this. So the case 1 is the 37-year-old lady who has come with a, she came with a hypertension, and we on examination found a thyroid mass, and which after FNSU it's found to be papillary carcinoma of thyroid, and she developed a recent onset hypertension. You can see the potassium is quite low, and we did a, because he's looking little Cushingoid, so we did the 8-time cortisol followed by the workup to rule out Cushing's disease, and we found that the ACTS is low, and it's ought to be a ACTH independent Cushing's syndrome. And this is a typo error. This aldosterone concentration we get 6 nanogram per deciliter, and we did a metanephrine, or non-metanephrine is negative. To say that because of the monetary constraint, probably, and we have sent the renin, but somehow it is missed, the sample in the lab, so that we cannot do the renin in second time. So we have discussed with our nuclear medicine guy that whether we can see whether the pentaxipher can localize that, whether this both in co-secreting cortisol and aldosterone, and to collaborate after operation how the patient is behaving. And so this is the images you can show. In the left side is the CT scan showing the mass, and in the right side you can see the gallium pentaxipher is showing the SUV. In our institution we took actually 30 minutes after giving this stressor, and it is quite high, and it's localizing the left adrenal mass, and we did the left adrenectomy. After that she became normotensive, and the potassium has improved. The second case is the Lassa Hembrom, and this is a 46-year-old male, hypertensive for 11 years, requiring multiple antihypertensive, and she had a CVA, IC bleed at 40 years of age, and we can see this, the plasma aldosterone concentration, PRA, AR, all are raised, and this patient also shows a positive pentaxipher scan, and he is due for this surgery. And this is the Dibendu Samanta, 34 years old gentleman, hypertension for 1 year, controlled with the single antihypertensive agent, and no evidence of target organ damage or no family history of hypertension. And you can see this, there is an increase in ARR and also PEX and direct renin concentration. And his serum calcium was not low, it is the lower limit of normal. And you can see there is bilateral normal looking adrenal and NCCT, and also in pentaxipher we could not find out any lesion. So summarizing, we have 8 cases. You can see out of 8 cases, the Dibendu Samanta actually we have put in medical treatment, because both the CT and the nuclear imaging is negative, and the patient 7 actually we'll discuss, it was positive in CT adrenals, but it's negative in the nuclear imaging pentaxipher. And actually she went outside, this is the only patient, she went outside and had a surgery, and it's found to be myelopoma, but we asked the tissue to review in our pathology, but she didn't give to us, so this is a little doubtful what she is having. So these are the 5 cases I've just put it. And this is the Sanjay Kumar Mahapatra, who I will be, this is, so the comparison of the pentaxipher of the 68 gallium pentaxipher versus CT abdomen. We have had 8% underweight CT, adrenal imaging and PET CT. CT abdomen, definite lesion, and pentaxipher mild uptake at the lower part of the right adrenal gland, and that the patient she underwent surgery and found to be adrenal myelopoma. And out of other 7, both scans are negative in 1, and lateralization of both CT and PET CT is 6, and so accuracy is about 87%. We did the adrenalectomy in 5, medical management in 1, and schedule for surgery is 1. So 3 months after surgery, 4 patients normotensive and normokalemia, not required any antihypertensive, 1 patient requiring single antihypertensive and normal potassium. And this is the patient which I was talking about. This is Sanjay Kumar Mahapatra, and we can see this is this scan. That's the right side localization of the tumor, and the left side actually they didn't show in the pentaxipher. So what we did after we did the surgery, it is found to have a diagnosis of MANP. So this is the term which actually this is multiple aldosterone producing nodules. So coming to the other investigation modality, usually we don't do because of the non-availability of the cyclotrons and the short half-life, like mitomidate. It is a imidazole methyl ester derivatives of etomidate, both of which are potent inhibitors of 11-beta hydroxylase and aldosterone synthesis. It has got a more inhibitor effect to the 11-beta hydroxylase, so that's why you have to give the dexamethasone so to have a good resolution of that. And the other one is C11 mitomidate combines with radioactive carbon 11 with decays to stable 11 boron, resulting in positron emission, which visualize the endocrine activity of the adrenal cortex and provides the possibility of functional imaging. And uptake of radio MTO has been shown to be highly specific for adrenal cortical tumor. As I already said, the dexamethasone pretreatment may improve the ability of sensitivity and specificity. And this is the match study which has been shown that the accuracy of MTO in predicting biochemical and clinical success after adrenal resection is 72% and 65% respectively. So it is non-inferior to the ABS, and this picture depicts probably the biochemical response and clinical successful in both MTO and ABS is not different, it's similar. So this is non-inferior. So the other modalities, because these are unstable, if you tag with the 18-fluoro-labeled radioactive stressor, probably they have a higher positron production and low positron energy. So you have a better visibility of the lesion. So in turn reduce the image noise and improves the contrast resolution. It also maximizes the possibility of detecting subtle lesion of less than 1 centimeter in diameter. And the other in the pipeline are 18F CDP2230 and 18-fluoro FMTO and ALDOBU. All are in the investigation. Only few case studies has been done. So it may take some time to come, and probably it can open a new mode of investigation to detecting the primary aldosteronism. So also in fluoro-labeled imaging also has got a better detecting the image and also better image quality. So in comparative performance of the all three ABS, 11 mitomidate and gallium pentaxephate, you can find out probably the gallium pentaxephate has got a better in comparison to all these, and it is now actually readily available. And the ABS probably, if have to have a very good dedicated radiologist to cannulate it, and so probably this the new imaging can open the new area for the diagnosis and the proper treatment. And you no need to withdraw any drugs, and it's a quite good imaging for the subsequent analysis. So this is the primary aldosterone which has been subtyping a treatment proposed in the future algorithm which has been published in JCM. You can do the hybrid hormone and steroid panel algorithms, the metabolomics, and probably it will take some time to be implemented in country like us. And if it is negative, you can go with the functional imaging. If still you are not able to do, then you can have the ABS. And if ABS is positive, localizing to tumor, you can have a unilateral adrectomy. If it is not there, in doubtful cases, probably you will go for a medical treatment with readily available good treatment to counteract the hypertension and to push the potassium up. So in conclusion, recent advances in PA subtyping has significant clinical ramification. The availability of non-invasive nuclear imaging technique may help identify more surgical candidates who might otherwise be managed medically due to the ABS limitation. And as a nuclear imaging technique becomes more widely available and standardized, they promise to reduce the diagnostic bottleneck currently limiting optimal PA primary aldosteronism care worldwide. So thank you for the patient hearing. and I'll be happy to take any questions.
Yeah, very elaborate and precise talk, Dr. Kishore. Thank you for highlighting. If there are any questions from the audience in regards to aldosteronism or AVS or functional imaging?
May I ask the question?
Sure, sir.
The recent US endo guidelines have now made mandatory screening for all hypertensive patients for PA.
Sir, mandatory?
Screening. All hypertensives have to be screened for PA now.
Yes, sir.
But why they have not included the functional imaging in their recommendation?
Sir, the functional imaging now, I mean, the MITO is the largest series which, 100 patient has been analyzed. The pentaxipir, you can see this is around 40 to 50% the largest series. And this is a new tracer and probably it's not available in everywhere probably. Once it will be available probably, what they shown in the JCM, the last slide I have shown, probably that will take to probably, if you, the last lecture which has been given by the Boyd et al. Probably the cutoff point for the aldosterone like B15, 10, 20, actually it's a very difficult. Which one to take, which one not to take. Even in aldosterone, if having 6 and the renin is very suppressed, the ratio is quite high. So the lecture is given by Gary Hammers. So probably once it is readily available, probably after doing the screening test, we can go for a nuclear imaging, and I hope probably it may come in the future in the guideline.
Yes, you could lateralize without doing AVS in any of the patient.
Sir?
You did not do AVS in any patient.
No, sir. In our institution, because it's a 10 years old at AIMS Bhubaneswar, so actually our radiologist is ready to do. The question is the amount of cost like aldosterone, cortisol, and the catheter will be more costly than doing the pentaxipir. It is take around 6,000 to 10,000, and because it is central institution, so we can write off, or if a BPL patient comes, then we can make it free. That may be the one of the, because the test, like one patient I saw that aldosterone and renin we sent to the lab and they missed the renin. So we could not repeat it again. So, and these tests are very costly. 2 tests cost about renin, aldosterone around 10,000. So that may be the important things, and once it will be sought out, probably it's a good idea.
Sir, one question. So I will first describe one of the case scenario that is currently admitted in our institute, Nil Ratan Sarkar Medical College Hospital. The elderly female presented with diabetes and long-standing hypertension and also CKD. Currently being managed with multiple subcut insulin injection and also OADs. He has some features of Cushing's, like mooning of face and central obesity, but other than this, there is no other Cushing discriminant features. We investigated, and one finding was hirsutism, and we investigated for Cushing syndrome, and that was found to be SCTH independent Cushing. SCTH is less than 5, and ONDST, LEDST all are positive, late night serum cortisol also positive. The imaging is showing, though the radiologist mentioned that there is bilateral SOL, adenoma, but we thought there is bilateral nodularities, multiple nodules, bilateral nodular hyperplasia. So the patient is having CKD as well. So how to investigate further? Should we go for PRC? And how to manage this patient?
I think the blood, PA and renin, you can do it. But what I show in my case number 4, actually, if you have a bilateral nodularity which has been picked up by the CT scan, but when we did the pentaxipir, it is the right side which picked up, and the left side didn't pick up with a SUV of 4.5 in our center. And when I inquire about, actually in the literature, you say you give a, prepare this pentaxipir and inject 25 minutes, and then after 10 minutes, the best period you can take. So what the study has been shown, and the literature also, and we have a very 8 or 10 patient, 8 on the board, and we have done, and 2 are on the queue, so we will be doing. So if you have a bilateral, probably the pentoxy-4 can able to distinguish which is secreting or which is not secreting. And if you do in the fluoro pentoxy-4 also, which is not available, probably it can delineate it more better. So I hope I answer your question.
Dr. Gar, please. Right behind you.
Sir, again also, yes sir, but, and also,
Sir, another question, sir. In an otherwise undoubted, I mean the clinically primary hyperaldosteronism, and some of our colleagues investigated for hyperaldosteronism and found to be hyperaldosteronism but having CKD. So is there any cutoff for biochemical PA and PRC for the CKD patients? The GFR is less than 45.
I think I'm not aware that it is, we are checking the blood. Actually, there is no need. But if we are doing the confirmatory test, we have not done any confirmatory test because the it's a very all the patients are hypertensive. All the patients are having hypokalemia. So we didn't go for any confirmatory test. But if you want to do the confirmatory test, and it's been shown that you are want to do the urine analysis, probably that makes a difference. You cannot do it.
So no more questions?
Yeah. We had 2 excellent speakers, Garg sir and Dr. Kishore. Thank you very much for enlightening us on these 2 topics. Thank you.
Thank you, sir. Thank you, sir.
Thank you, our esteemed speakers and the panelists for the excellent session. Next, we have a panel discussion on public health issues for endocrinologists, which will start from 3 p.m. sharp. So now we pause for a short break, and I will request everyone to reassemble here from 2:55 onwards. Thank you. Good afternoon, everyone. I once again welcome everyone back after this short break. Now we move on to our next session. That is, we have a panel discussion on important public health issues for the endocrinologist. For this, I would like to call up on stage our esteemed panelists, Dr. Shobna Gupta, Deputy Commissioner of RBSK, Government of India, Dr. Vivek Virendra Singh, Chief Health, UNICEF, Dr. Tushar Tale, Assistant Director General, Non-Communicable Disease, and Dr. Shapon Soren, Director of Health Sciences, Government of West Bengal. And now, I would like to request Professor Dr. Sujoy Ghosh, sir, to moderate this session. Sir, over to you, sir.
Do we have hand mics there?
Do we have
hand mic?
Good afternoon, ladies and gentlemen. At the very outset, I would like to thank at least the residual crowd that has stayed in this hall after lunch. You know, this actually highlights the fact that as clinicians, we do not appreciate enough the importance of public health, whether in endocrinology or any other subject. You know, we are all busy practicing endocrinologists, diabetologists, trying to take care of our patients at individual level, but we often fail to look at the bigger picture of public health. And if I had an opportunity to rewind my life and restart my career, I would probably have chosen public health and not endocrinology. The reason is, as an individual, I make very little impact in people's lives. But if we really want to make an impact on people's lives in terms of health, public health is probably the most important subject. And what we need to understand is, maybe in our undergraduate days, community medicine was just one of those other subjects that you were taught. It's probably the most important subject. And we are really, really fortunate to have a really power-packed panelists here. You have people from RBSK, you have people from the National NCD, we have our own Director of Health Services, and we have Dr. Vivek, who heads UNICEF. So in this session, please feel free to interact. Please feel free to ask questions related to issues of public health related to endocrinology. We all fret and say, you know, the government should be doing this for type 1 diabetes. What are we doing? We all talk about there should be a universal policy of screening for neonatal hypothyroidism, congenital hypothyroidism. But what can we do in terms of interacting with them and the government to try and make a change to policies? And of course, the bread and butter that we endocrinologists earn is from metabolic diseases. In spite of all the discussion that we have of adrenal disorders, thyroid diseases, it's ultimately diabetes, and now it's obesity, PCOD. So all of these metabolic disorders. And what are we doing to trying to prevent things from happening rather than, you know, just treating the extreme end of the disease? It's like trying to, you know, put a cover on your roof which is leaking instead of trying to make sure that you don't have any leaks in the roof. And maybe I should start off initially with ma'am, Dr. Shobna, and just to initially for the doctors to understand what does RBSK do in terms of what concerns endocrinologists and metabolic physicians. Ma'am.
Thank you, Dr. Sujoy, for having us here in the panel. And as Dr. Sujoy has already highlighted, it's an endocrinologist all sitting here, and we know how, you know, while doing medicine, and I'm a pediatrician by training, so this was one subject, you know, where everyone shivers. Oh my God, we have to, you know, go and read this chapter is remaining. So hats off to you all, and thank you for having me here. Being the in charge of the RBSK, just to, you know, tell what is actually RBSK is doing. It's a Rashtriya Bal Swasthya Karyakram, which is a Government of India initiative to comprehensively examine, screen the children from 0 to 18 years and then provide them early intervention services through the public health facility as well as the district early intervention centers which are present at the district level. And in West Bengal also you have a few of the good DEIC. In fact, the earlier ones which have been established, like in the SSKM is one of the early one which has been established and it's working wonderfully. So that was the main motto, to provide the quality life from survival to thrival. And it was a very focused approach was taken that all the children in the school and the Anganwadis will be screened under the categories of 32 health conditions, namely 4 Ds which we call, out of which 1 D is the defects, diseases, deficiencies and the developmental delay. So basically if I talk about and they were taken on the basis of the prevalence, how the early intervention can bring about the difference in the quality of their life and how that can be connected to providing services through the provision of having the memorandum of understanding even with the private partners, because we have, as you know, the intervention services for the cardiology, for the some of the defects which we are not having because of the burden at the public health facility. So that provision is being given and the money is being provided through the National Health Mission. So the main this was mainly about the program, how do we do it, and the financial support is given through the Government of India to all these states and the National Health Mission. And the states propose in their program implementation plan these money for these defects and the, for all this procedure. And this screening is done by the mobile health team. So it's basically a concept where we have, there's a team of health personnel which have 2 medical officers and a paramedics or a pharmacist. So there's a team which goes to the school and Anganwadi. In the school it goes annually and in the mobile, and to the Anganwadis it goes biannually. And they do the screening through the structured format. Structured protocol is there for the screening. And ultimately, then these are referral services and the treatment is being provided. So this is basic about the program which I have, just to highlight, and how it's been a decade-long program being implemented in 2014, and now we are almost 10 years into the program. And the reach has, almost we have a 70-75% reach in all public health facility. And as we are coming forward in the diseases also, at that time the congenital hypothyroidism is one of the condition which is an optional, has been kept depending on the capacity of these states. And there are other defects. I think we would be moving on further, then I'll be elaborating. Thank you.
Right, thank you, ma'am. So under the RBSK, all of you would probably know that screening for congenital hypothyroidism is an optional test. We'll talk about what the future plan of the government is to try and, if possible, make it a universal screening test like you would expect it in all developing countries and developed countries. So one of the things that we have to understand is the main role that RBSK has been playing very importantly is screening for disease early in children. So other things that you can think of in endocrinology where you think that there is a need for this screening would actually fall under the purview of RBSK. And how we as endocrinologists can think of and tell the government is that disease X, Y, and Z is important, is something that would actually fall under the purview of RBSK. We'll come back to that. Now, moving on to Dr. Tushar. Dr. Tushar probably already is in charge and leading, the adult NCD program. So one of the things that you know probably is the adult NCD program starts from age 30. So Dr. Tushar, first of all, if you could tell us about the brief outline of the endocrine bits and the metabolic bits of the NCD program, because particularly people not working in the government sector would probably not know, and even the ones working in the government sector would be working in tertiary care hospitals. So NHM does not go to tertiary care hospitals, it's below. So what is the network and the structure like, and how can we guys, endocrinologists, try and help you in that process?
Thank you, sir. So NPNCD program initiated in 2013, and primary focus is the early diagnosis and the initiation of the treatment. So under National Program for Non-Communicable Disease, our focus is the screening of 30-year plus population for 5 common diseases: diabetes, hypertension, and 3 cancers, that is oral cancer, cervical cancer, and the breast cancer. So these 3 cancers are being screened, these 5 diseases are being screened at the community level. At the community, we have, you must be knowing that ASHA and A&M structure is there, and through their community-based assessment checklist, individuals are risk stratified, and accordingly they have been referred to a higher center for evaluation. But at the same time, for diabetes, it has been through random blood sugars, hypertension, through sphygmomanometer, and for oral cancer, it is a visual oral examination. For breast cancer, it is clinical breast examination and self-breast examination. And for cervical cancer, we are using VIA method for the screening. This screen patient, if there is something wrong, something abnormal has been identified, they are referred to the PHC and the district hospital as per their quantum of the abnormality that has been, and where their diagnosis and the treatment initiation will be taken care at the block level or the district level, and then the patients will be further referred back to the their community, and the continuation of the treatment, like dispensing of the monthly drugs, will be happen at the Ayushman Arogya Mantra. So these are the 5 common things we are doing, and in addition to that, recently we have a newer budget announcement of the establishment of the daycare cancer center at the district level. These cancer centers will be linked to the State Cancer Institute, and treatment will be follow-up chemotherapy treatment will be given at the daycare cancer center.
Right, sir. And what we have seen, I'll come back to this issue again, is that people are getting screened, but what happens thereafter is there's a huge amount of dropout and loss to follow up. Yeah. So you might have screened X number of people, but what do you think should be the way forward in trying to ensure that there is continuity of care and that people actually come back to the system? For example, somebody is diagnosed with diabetes, gets treatment for a while and hypertension, and then disappears. So the fact that you are using the CBAC form, the fact that you have ASHA workers, do you think there's anything in the system that we can kind of employ to ensure that these people follow up, that they have continuous treatment?
So as far as the NCD data is concerned with government system under program data, so there is no much gap between the number of patient diagnosed and the put on treatment. However, as sir correctly identified, that we have facing the issues with, there is huge gap between the about the follow-up or the under control status. Those patients who are diagnosed and initiated on treatment, whether they are getting regular treatment, and as per the protocol, every 3 months their necessary investigation are being conducted. So there is a gap, and we have been identified. Currently, we are trying to, through ASHA and A&Ms, they are supposed to have a monthly visit to these diagnosed, basically hypertension and diabetes patient, and medical officer at the PHC level. They are expected to undertake the necessary investigation. But despite that, we are not able to, so recently we identified and we are trying to breach that particular gap. In that situation, we had that we need to further strengthen our referral linkages. If patient is referred for NCD, first point will be the acceptance that I need the treatment, and after that, once the patient is diagnosed at the PHC, there may be a chance that patient usually go for the second opinion to the private sector. So that particular gap we have identified, and we are trying to bridge that gap through, there is a NCD portal and through the community health volunteer. However, we need further what we call as a further efforts to bridge that particular gaps.
Thank you. Dr. Vivek, every time anyone talks about UNICEF, it talks about a lot of things rather than health, because UNICEF is such a big umbrella. And even if we talk about health, in terms of UNICEF, people talk about infectious disease, immunization. So tell us that bit first about the entire spectrum of UNICEF before we talk about NCTs.
Thank you, Dr. Sujoy. But before that, I apologize. I want to do something unconventional. I want to ask if anybody in the audience has deliberately come to this session knowing that it's going to be talking public health?
Great.
There are quite a few.
Great. My
Thank
job
you.
is done.
Great. My job is also done. Two things. So I work for UNICEF, and I'm assuming that a lot of people know about child rights and what United Nations Children's Emergency Fund stands for. So I can vouch that myself and Dr. Shobna Gupta, who leads the child health in the country, we work traditionally in child health, and we are here in an endocrinology conference. I was just speaking to her on this because of a gentleman, Dr. Sujoy Ghosh, who's moderating the session, and I want to link it to why UNICEF and why we are sitting here. So Government of India is signatory to a convention which is the most widely ratified legal document called the Convention of the Rights of the Child. India signed it in 1992. All the countries in the world except United States of America are signatory to this rights convention, and they give all their children certain rights. These rights are around survival, development, it's about participation of children also, and their protection. These rights are given by, like our Sarva Shiksha Abhiyan, right to education, right to health, universal health coverage, and UNICEF exists because governments have agreed that UN can support them in ensuring these rights for their children. Why I want to relate this to UNICEF, and I want to differ with Dr. Sujoy in one thing. He said, I want to be reincarnated not as an endocrinologist but as a public health physician. I would correct you. We would want to see your endocrinology excellence again. You can be an endocrinologist and still be a public health professional. Exactly. So what we want is that as UNICEF, what we realize, I'll take the example of type 1 diabetes and close. When you are treating a patient with your excellence, that's your clinical excellence. But the moment you step out and see, it is not just that one diabetes patient that you treated with clinical excellence. We have 70 million on the streets. What can you do as that endocrinologist par excellence to step out on the street and also help those 70 million, or not just the one sitting on your table, right? So I think that's what we want the endocrinologists to do, and we will continue this conversation.
Right. So again, coming back to UNICEF, you know, whenever, at least I didn't know much about the NCD bit of UNICEF before I interacted with you a couple of years ago. UNICEF, you talk about, it's about immunization, right? It's about infectious disease, whenever you talk about health. So tell us about this new hat that now UNICEF has in terms of its thrust on non-communicable disease. Because that's where this audience would be interested in.
Okay. So UNICEF was never about infectious diseases. The burden of diseases in the country were mostly infectious diseases, and we are going through an epidemiologic shift and a lot of other shifts, and that is why non-communicable diseases are now becoming the deprivations that are depriving children of their rights. If a parent dies early, 30 to 40 years with a heart attack, and has 2 children, who suffers? A child suffers. If a child has type 1 diabetes and dies by the age of 25, whereas the same child enjoys same life expectancy as the average or more in Europe, whose rights are being affected? The children's right who's staying in a country where type 1 diabetes dying at 25 vis-a-vis that. That is why the natural shift of UNICEF to align with the government's priorities. And that is why you see also Dr. Tushar sitting here. Government of India is also developing guidance on children and NCDs, and that's the reason for the shift.
Right, thank you. I move on to our own good Dr. Soren, our DHS sir. Sir, please tell us about the initiatives that, you know, in terms of non-communicable disease and through the National Health Mission, what the state of West Bengal is doing. And I am not being skeptical, but I still remember about a decade ago when I first used to go to Swasthya Bhavan to the NCD cell, it was kind of a retirement posting for the director of NCD cell. That was the reality. No one was interested at that point of time. Now we realize that there is a huge shift, that NCD is what is important. 2/3 of our deaths is from NCD. So what is the government of West Bengal doing and what is the plans?
Yes, in alliance with this government of India, we are looking after the NCDs of the peoples above 30 years. But we missed that portions which are smaller, which are smaller in age and smaller in number. But in the West Bengal, with the due respect to our Professor Ghosh, he has taken the initiative of treating the type 1 diabetes patient in a public health manner, not in a single clinical chambers. And with his ideas from the Center of Excellence in this IPGMR, Government of West Bengal have approved these initiatives to take as a public health problem of the type 1 diabetes. And we had started in 2021 as a pilot in 4 districts. And with the success, and success is just by some determined personalities along with the Dr. Ghosh and his members. They started and we have expanded into the peripheral districts. Now in the 11 districts, we have started, and with the aim that we will cover each and every district, we expanding the type 1 diabetes treatment, diagnosis, follow-up, and care, and mentoring and monitoring. And we are in the right path with the guidance from the endocrinologist, and we'll hope we'll succeed.
Thank you, sir. Sir mentioned about type 1 diabetes, ma'am. So in terms of the role of the RBSK, you have quite rightly told us that one of the major things that RBSK does is detection of any disease relatively early so that we can intervene early. So in terms of type 1 diabetes, what is the vision of the RBSK, or what do you think is possibly the way forward?
Definitely, as pointed out, that with the change in the epidemiology and improvement in the indicators, previously we used to talk about the survival. So definitely now India is not talking only about survival, but a good quality of life and an intact survival. So with that, Government of India envisions that there should be, and there is a lot of mandate from the Government of India, and the work is under progress, that how to include this type 1 diabetes in the screening program, as well as to provide that referral linkages so that the child once screened, because as we know in type 1 diabetes, the main problem is that how to catch these children early. Because generally, as you know, they don't land up until unless they have some emergency. They mostly land up in the emergency room. So I think that was the discussion. We had an exhaustive discussion that how to catch them early. Is it possible actually to screen them while going into the schools where the existing program is there? So yes, we are working towards that, formalizing the guidelines so that we can at least formalize. We are working mainly on the 3 areas. First, to have that screening mechanism at the platform where we find children, that is our schools. Secondly, it's very important to, to link them to the concerned facility so that they do not lose to follow up. So to have that, we need to have, first of all, the logistics. That is, we need to have the, relevant drugs, insulin, and the other things at our district hospital, as the program National Health Mission mainly caters till district hospital, and then we have medical colleges. So have that good appropriate linkage, because it's very important that people like you who are actually working at that level, whether public or private, they need to be involved, because these children require a lot of care while starting the treatment, and a normal pediatrician who is not been working in these diseases won't be confident anytime, to treat these children or even to start a basic, especially when it comes to the children, because the dose calculation, the preparations available, everybody, just even in a medical college, I have seen my colleagues and faculty, they were not comfortable. Every child was referred to one particular doctor. So to have that capacity through referral linkages for initial assessment and starting the treatment, and then maintenance and follow-up. So that capacity building at the district level of our pediatricians, because there is already an NCD clinic which is running at district hospital and CHC. So to formalize that, institutionalize that system, that once a child comes, it can be referred to have a, that center of excellence where he can be started, assessed, and then the follow-up treatment at the nearby district hospital, whether in liaison with the NCD clinic, a pediatrician can go there, or, at the pediatric department. So that kind of thing we are trying to link up. And regarding the question which you, offered, that the children are all mostly lost to follow-up. So we have a digital mechanism in RBSK where we do entry of the children who are being screened. And now we are already working to establish that referral linkages so that those child can be tracked. Definitely we need to do that digital entry at every level for that child. So we are working that how to close the loop. So we are hopeful in next 1 year we should be, able to, and India is a huge country. We have 25 CR children from 0 to 18 years, so you know how much is the load. So I think key is to start small, start with some districts like Dr. Sujay already shown, start with small districts, then expand and scale up, and then ultimately the whole country. So we are definitely, with the guidance of the, a lot of push from the, at the highest level, we are working on it.
Thank you, ma'am. Dr. Tushar, the adult NCD program hardly talks anything about obesity. You will see two sponsors outside making millions, Novo and Lilly. So technically speaking, in the adult NCD guideline, we still don't talk about obesity as a disease. Now, in terms of both adult as well as children, obesity is the major driver of all NCDs that we are talking about. So what is your views, and what do you think we should be doing as endocrinologists? And what do you think the public health policy should be in terms of prevention and management of obesity?
So recently, last year, 2024, there is a publication from Lancet. It says that around 44 crores individual will be either overweight or obese by year 2015 India. So almost 1/3 population will be obese in our country, and that particular paper has pushed at the ministry level to further think about what can be done. So currently, under NPNCD program, we have population-based screening, and at that CBAC form, we already having the provision of the waist measurement of the waist circumference. That one thing. In addition to that, at the health facility level, body mass, BMI and the weight calculation, weight measurement, that particular facility is already there. So we are capturing the data, but then we are not taking any action till now. But then recently there are certain developments, and accordingly at the every Ayushman Arogya Mandir, yesterday only we had one meeting with the how community can be involved into this particular management of the obesity through preventive management, like lifestyle changes, nutritional changes. So involvement of the self-help group and other community organization to make awareness or to create awareness among the community whenever there is a overweight or the obese individual has been identified. In addition to that, ministry has running a school health program, and under that school health program there are school health ambassadors and the school health champions, teachers and the students has been identified, and they are being trained for the health education. And through that particular scheme, we are also trying to incorporate the chapter or the module of this obesity with respect to dietary changes, lifestyle modification, exercise, and so this preventive aspect is being taken care through this particular two initiatives.
Right. I think the school health program, at least in my state, also needs to be strengthened a lot. A lot needs to go in, and the students are studying X number of subjects, but what is important in terms of physical activity, diet, that is neglected to a great extent. And more importantly, the screening bit of things in school health program, I think, needs to be strengthened even more. And just for the knowledge of the audience, what the ASHA workers are doing at this point of time, because I think they are the best healthcare workers in India, not us. They have all been given a tab where they have a CBAC form where they are collecting the data, and that for example, one of the things that we have discussed in our state is whether we can put in an additional question, do you have a child with diabetes at home? Because you need to pick up these people and track them to the clinics that you've created. Otherwise, no one gets to know as to what is happening where. Ma'am, would you like to add more to the school health program? Because I think that's one program that all of us need to be aware of, and we all need to provide inputs to how we can make that program better, because that is the program that will ultimately change the health of our nation. Just to give you a background, in Singapore, there's something called the Singapore School Fruit Program. All the schools in Singapore, which are government schools, are funded by the government, and the funding depends on the health of these kids. So if your children in school are fat, your children will, that school will get less funding. And in school, the only thing that you're allowed to have is water and a fruit. No McDonald's, no KFC. And when these kids go back home, they tell their parents, what you are eating is junk. That's much more likely to work rather than, being pedantic and trying to tell people this is good or this is bad. When the kids tell the parents, I think it has an impact. So something like that, if we can, ma'am, you can highlight the school health program.
Yeah, definitely. The school health and wellness program, basically, nobody talks about the preventive and the promotive aspects.
Exactly.
So like RBSK, one hand is talking about the early screening and the, providing the services. So school health and wellness, the prime objective is to have the preventive and the promotive component within the school. So there are school health ambassadors, which are among the teachers only. And there are, the students are being chosen, there are health clubs. So they are being given training that how to impart that training about these aspects to the children. And if there is any issue, that program converges with the other various programs, like there is a mental health, district mental health program, the RBSK team. So they converge with other programs as well as you are making them accountable. So I think it's high time, like for the obesity or for the hypertension, whether it is a child or an adult, we know the behavior change is the key thing, which is the most difficult thing. We can always give, because recently I had, just wanted to share with you, recently I had a friend's husband, who consulted. They have started taking some injection for weight loss, which has come, but they don't want to change their behavior with respect to diet or physical activity. So if a 45 or 50-year-old is so difficult to change, so that imparting that habit right from the, early age is very important. Yesterday, even at the airport, I saw a mother having his 2-year-old kid or 1.5-year-old kid asking, bribing that I will give you noodles, I will give you pizza, you go through this on the airport, and that was the bribing. That means it is a good thing if you're getting for doing something good. So I think that behavior needs to be changed of the family. Otherwise, I don't know where we will land up, how many medicines we can give.
True. Dr. Vivek, so can you tell us the exact touch points where UNICEF is interacting with individual governments, whether it's the state government or the central government, in terms of non-communicable disease? What are those areas? For example, the activities in school, in terms of, for example, you guys are helping us with our type 1 program itself. So what are those areas that people need to be aware of, where doctors in here can actually take or seek help from you to try and strengthen things in their own states?
So again, not because you're moderating and I have any bias for this invitation, but I want to use this association as an example. UNICEF works with the government in an agreement in 23 states. And with government of West Bengal, Dr. Sujoy Ghosh is leading that. In Bengal, we are supporting the same scale-up of the type 1 diabetes program. At the same time, also documenting, and the reason you see the chiefs of child health and NCD sitting here, everybody is trying to learn from these programs. As we are learning for the country to scale it up, we are trying to learn from the early starter states. So while the guidances, Government of India, we know health is a state subject. While the guidances come from Government of India, health and to what extent things will be implemented in the states will remain a state subject. So you can champion. You can be the same champion, and I'm sure Dr. Shobna and Dr. Tushar will not mind, at least one clone or one champion with all respect to everybody sitting here, even if we have one champion in every state like you, where we can associate as the government and UNICEF supports the government, where we can learn a few things. That is one. I would want to add one thing which is out of the question, not out of syllabus.
Right.
See, if you are a clinical person who is a clinician par excellence, and I'm being mean also here, there's so many people who have diabetes today. Somebody who's sitting in a position of power and can change things may have diabetes. And you may be the endocrinologist. Health is a state subject. How did you start things here? How can you influence things here? Do you think you can reach out to some of the bureaucrats, some politicians who are change makers, who have the power to change things? Use that. And I won't take names here. I've seen your fraternity do that. And that helps us also sitting in the union, be it the state, which is the government, or the UN, that you can champion things. So for example, and this is where Dr. Shobna can correct me if I'm wrong, even in RBSK, southern states are early starters in some small pilots on even congenital hypothyroidism and some of the other issues also, where guidances are being, things which cannot be taken to scale in a country like India because of the cost and other factors. You know, how do you prioritize? But it can be taken maybe in another geography. Kerala has a newborn mortality of 3, whereas the highest in the country has 30, that range. So there are things that Kerala can do. And if there is a champion sitting in Kerala, please go and work with the state government. They'll take guidances and do that. So champion in your own space, and we are there in 23 states working with the governments. Like here, first program that we started is with Government of West Bengal, which is you. But same can be done with the respective, regardless of whether UNICEF or any other partner is present there or not. Because you have to work with the government and you can offer your championship to the government. Thank you.
Right. Sir, West Bengal is probably one of the very, very few states who are providing outpatient care, including the drugs, medicines, investigations, everything for free for diabetes, adult diabetes, type 2 diabetes. So would you like to tell us about that bit of the success story?
Thank you, Sujay. The states, as Sir said, it is a state subject, along with the support from the government of GOI. We are providing each and every person's free of cost, whatever they need. In respect of the type 1 diabetes, we are also providing this diagnostic cost, treatment cost, and we are also trying to involve this one test, one cost, so that we can include these tests that is required for the type 1 in this.
As well as adults.
As well as
all
adults.
Adults are getting all
in
this
the HB1C, we can include it. So we are thinking of it, and we can integrate this HPLC machine that is for the thalassemia control unit. If we can use it, so our patient will be benefited.
Right. Ma'am, coming to congenital hypothyroidism, I think Delhi has done part of the work, has at least standardized bits and pieces in terms of how to go about it. So would you give us an idea of what we at the state levels, at individual state levels, we can think of doing in terms of screening for congenital hypothyroidism? What would you suggest as pilots, at least in states?
Yeah, as you know, Dr. Vivek has highlighted that India is a heterogeneous country of 36 states and UTs with such a wide variation. And the load we are having, because in congenital hypothyroidism, if you say that we have the test available, to do later on, but here I suppose we are talking about the newborn screening to be done at birth for the universal newborn screening. So there are few states which are doing it right now in a pilot basis. Kerala is one of them. Delhi has one project NEE which is being supported, so under that they are doing. Few districts are doing in other, some of these states, here 1 or 2 districts, they have taken it in a piloted mode. Actually, when it comes to congenital hypothyroidism, since it is a universal, so yes, to start with, as a state, it would be best to, best to start with 1 or 2 districts where you think, because right now we do not have any Indian data on the prevalence, which is, more in which state and not, or there any high risk criteria we can use. So right now to start at the national level, we do not have a concrete data from India. That is one of the hindrance factor, because normally we start right from there. When we get something, to start, that it can be started. So that piloted, if can be done with 1 or 2 districts, we can see the processes, how the process of, collecting doing the sample, then moving it further to the main lab, those transport issues, who will take the sample, because there are many logistics issues. However, there is no doubt that you require, that it is a, most treatable and easily diagnosed. But when we actually thought about it, all the implementation challenges, the availability of the kits right at a delivery point, at every delivery point, the capacity building of those people who are taking the delivery, because 30-40% delivery are still happening below district level. Then the transportations, adequate optimal transportation of those samples at the higher facility, and subsequent the confirmation, then again the follow-up of the child. So that requires a lot of process building. So that kind of pilot, if can be started in the with 1 or 2 districts, that will actually pave the way that what are the potential challenges which are going to come, and those can be plugged beforehand. And with the other things of the logistics and the capacity building, they can be built up along with that. So that's how we start at the national level. So that would definitely help us. And if there is other things we can get from the state, we actually ask the state to pilot and to show us the results, and then we can take about, and that gives us a base also to think further on that direction.
Right. So the only major data that we have from India about congenital hypothyroidism is the ICMR study, which kind of suggests that the prevalence is anywhere between 1 in 1,200 children. Now that's
and that was also done in more than 34 weeks of children. That was the cohort taken, but no justification was.
Right. And the fact is, if you go back to your community medicine textbook, what disease is worth screening. This is one disease that will probably tick all of the boxes, but the major challenge as of now is how do we go about delivering it. So what ma'am has suggested is, I think many of us in different states, in different government hospitals, we should be thinking of a implementation model of what we actually want, so that we generate data, we find out where the roadblocks are, what the bottlenecks are, and if it then succeeds, then we can think of state-wise policies or even national policies.
We should do IR on that.
Yes. So the other thing that I would ask Dr. Tushar is, because, how do you go about doing anything like this? So I think very few of you know what is PIP, Program Implementation Plan. So I would request Dr. Tushar to tell us, because those of us who are at least working in government hospitals, if you want to do something, you need a starting point, right? And that is the PIP. So if Dr. Tushar tells us about it.
So PIP means Program Implementation Plan. So currently every 2 years, maybe every year, from the state give a budget proposal to the Union Ministry for this is basically for the National Health Mission, the programs which are being implemented through National Health Mission. So for that, budget requirement is there, and that budget requirement proposal is given to at the national level. At the national level, mission directors, additional secretary and mission director, after discussion and with the state, a few proposals are being approved. So there are certain already prescribed norms which are being given by the mission steering group, which approves that and that particular norm. Accordingly, state proposes the budget. For example, how much incentives can be given to the ASHA for doing maybe one delivery, or if the state want to establish a NCD clinic at the district hospital or the block level hospital. So what HR should be there and what equipment should be there. So all these, there is a prescribed budgetary norms are available. So these are, and accordingly state proposes. But in addition to that, certain state proposes which is not a part of the national guidelines or national policy norms, but then state as themselves have their own innovation or maybe a new pilot. For example, state of West Bengal has proposed for the type 1 diabetes 2 years back, and that particular proposal has been approved for, accepted and approved for the, initially for a few districts, and after an additional of 11 districts that has been approved. So such kind of innovation, there is a scope of innovation in that particular PIP. So every 2 years a full proposal is being submitted from the state to the union ministry, and annually there is a midterm review, and based on that maybe something additional has to be proposed or some things has to be omitted. That is being done through this NHM's PIP mechanism.
So I think that's very, very important. So if any of the states, for example, wants to do something on type 1 diabetes, whether it's congenital hypothyroidism or any other endocrine initiative that you want to take, the first thing that you think of is a pilot. And you submit it in a proper format as a project in innovation. And therefore, if you can show or demonstrate that you are doing something good, which is actually making a change, then that can be scaled up. But documentation is very important, how you do it, and then what data you take. That gives you two things. First of all, of course, the central government gives you funds for that. Secondly, it gives you credibility. You know, if you are doing something at the state level only without, because the DHS sir loves me, if I ask him something, sir will say yes to it. But the thing is, we all want to make things which are sustainable, right? The next DHS might not like me. So it might not be sustainable at that point of time. So if you're trying to create systems, it is best you create innovation with the help of the central government through PIP. That gives you credibility. First of all, that means you're doing something good. And then if you're thinking of your model is good, which will be then scalable at the national level, the central government will say, this is a project that we supported. So this is something that we are also part of. So that could be one way of actually trying to sell the work that you are doing, because that's important. And what we can do as endocrinologists, and I'm quite happy to help coordinate, those of us who are working in government sector in different states, even if we think of, for example, the congenital hypothyroidism, that, you know, these are the 3 states, or these are the 4 states where we are going to do a pilot. We choose one district from each of the pilot district from each of these states, and we can send individual proposals, and then we can collate our data and exchange our learnings so that we can actually formulate an implementable model. It's all about implementation science. It's not that you and I don't know what needs to be done for type 1 diabetes. We know what needs to be done, right? We know it has to be basal bolus insulin. We know you have to check things multiple times. You know that there has to be a continuous supply of insulin. But how do you do it? You need to document that, and you need to have a model. Otherwise, for the policymakers also, you know, how do they trust you? That you might be a great endocrinologist yourself, but the document that comes out is not necessarily, you know, a vetted or a tested document, which is actually going to work at the level of a district hospital. There you don't have an endocrinologist. You have an MD medicine and an MD pediatrician. That too, in some of the districts, even that might not be there. And what we as endocrinologists can do in each of these things is mentoring, hand-holding. For example, Shomik is sitting here for the type 1 diabetes project. He's an assistant professor of NRS Medical College. He has done the hand-holding for Imambara Hospital, the district of Hooghly. So we need the endocrinologists to be involved in public health service delivery, whether it's capacity building, whether it is starting an idea, whether it is supporting, because otherwise, you know, if we just sit back and, because how many endocrinologists are going to be there in a district hospital across India? You don't even have enough in the government sector. Forget about, you know, in a district hospital. Most of us are in tertiary care hospitals. We are not going down to the districts. At least we can give back to society what we should be doing is my view. Dr. Vivek, coming back now to you again, the PEN Plus program. Can you tell us about the PEN Plus program?
PEN is an acronym by WHO, the package of essential interventions for NCDs, and basically primary care level. Not like the primary as the PHC, but primary health care means communities at the center, services as close to the communities as possible, and multi-sectoral actions. What are the essential interventions? that should be available at a district level, at close to the communities. So in many African states and parts of countries which are far ahead in development like India, parts of countries, wherever the health system has such capacity that districts will have to be augmented to have at least those essential interventions, WHO had a strategy called PEN. They added plus to it recently, and plus was for children. And this plus came from a report of the Lancet Poverty Commission. So 4 disease conditions were chosen for PEN plus to use as markers for universal health coverage for NCDs for childhood onset conditions. And these 4 conditions that were chosen were type 1 diabetes, congenital conditions, congenital heart disease, especially those that can be life-saving through a single surgery. Then there was sickle cell, asthma. And then there was COPD asthma, because poverty, still people burning fossil fuel in their homes will have these children. So these 4 conditions were added so that focus on NCDs can be also brought to children and not just adults. Because unless you start early, life course, mother eats healthy, the hypothesis that children early, whatever you do, will decide NCDs or no NCDs. So that is why, to shift the focus also on the life course in children, PEN plus was added.
Right. I think before I open up the session for discussion, we have still about, 10 minutes. Ma'am, I would request all of you all to summarize and say, what do you expect from this audience? Because this is the most powerful endocrine audience that you can find in India. And I'm sure they will be happy to actually take responsibilities to try and help and support the public health system of India.
Yeah, I think like I mentioned previously also, India, I think our country has the most brainy and the hardworking people, no doubt about it, whether they are working in private or the public. Ultimately, we are all catering to the same children. No matter, and the same child goes to the government hospital, he's being referred to the private for, services, then he comes back to so it is the same child, same cohort we all are talking about. So I think, as we know, you people, actually the number of endocrinologists are actually very less in the country, and that position is in the medical colleges. So we would be really requiring, if we really want to upscale, whether it is type 1 diabetes or congenital hypothyroidism, and in coming, time as we will progress, there will be many more diseases, metabolic diseases we would be, taking into account and moving. So the one thing we really need is a good capacity building at the, district level hospitals of our pediatricians and the physicians, especially in the states where, mostly are being concentrated in the metros. So the people who are actually working at least adopting or, adopting an area and a liaison with the local district hospitals. It's a very, easy. You don't have to actually approach always to the government. You can easily talk to the medical superintendent of those district hospitals and adopt 1 or 2 district hospital or the facilities which are in your area, just to have this once a month kind of thing. If you can, devote that thing for the awareness, even you can take awareness sessions for those healthcare staff which is working at the ground level and at the facility. That would actually go away. One is the awareness of the ground level, so that they know they can talk about it while they go with the families. And one is at the facility, how to maintain. It's not that difficult, which doses to be prepared. Because as mentioned in essential drug list, insulin is very much there. All the medicines, our essential drug list, more or less, has many things available. The diagnostics are all there in the government setup, free of cost. The main thing is that when the state has to take it, the hospital at the level, they see that what all things they require. And many a time there's lack of knowledge that, okay, I might be requiring this pediatric dosage. Like for the antibiotics, for the insulin. So even that simple hand holding of, so connecting with your local public health facility at any periodicity which is being suitable to you, I think once a month or, once in every quarter, with simple issues of what they should have as per the available checklist, what should they need to indent, what capacity building is being required at the local level. We have our documents, being available at the national. So simple, those documents can be referred to. That in simple things they can be explained, and the awareness they need to create, even the nearby PHC or CHC, while the ASHAs and the ANMs and the medical officers, that they need to tell about these, danger signs, so that they don't land up in the emergency, whether it is hypothyroid and how important it is to have a follow-up. That awareness actually, as I'm saying again and again, we have to make our people accountable. So our society accountable that, getting the preemptive checkup is important rather to always land up with the complications and have a setback. So that kind of liaison I think we need to create and involve everyone. We cannot go alone.
Thank you, ma'am. Dr. Tushar.
So, ma'am already discussed about the capacity building. So, to continue that, capacity building of the physicians or the medical officer of the district hospital or the block level, from your side it is expected, like that is very important. Suppose a patient comes to the tertiary care hospital, he has been diagnosed by you and initiate the treatment. So, as a good endocrinologist, you initiated the treatment, everything is fine, you have given the protocol. But at the same time, whether that patient is in position, or his parent or her parents are in position to come back for the follow-up. Most of the time, the patient from the poor socioeconomic strata, he may not be able to visit again the medical college or the tertiary care hospital. So capacity building of the district hospital or the block level medical officer will help that they at least follow up treatment routinely. They can be taken care at the their nearest hospital, and in cases of complication, that medical officer can refer to the tertiary care hospital. So this capacity building is very important thing. For diabetes or any of the NCDs, these are the chronic diseases. Patient diagnosed in the early 40s, he may survive around 80, 90 years, and almost 30 to 40 years he has a lifespan. And during that period, the complication increases, and it requires a clinical set which you have, but then that peripheral medical officer may not have. So at certain point, you need to delegate few of the things to the peripheral hospital, so that the load of your hospital also reduce, and also the patient is able to get the treatment, proper continuous treatment. Third point is the advocacy. You are being a clinicians, and very well screened, you have your opinion matters very much. You can easily advocate to the opinion makers or the policy maker for the newer initiative or anything you want to change in the system. Your advocacy is very helpful. A positive criticism that always help. Like it is the advocacy in such a way that there should be a solution. It will not be helpful if you say that something XYZ thing is not going wrong. It is not useful to the system. You can say like this particular thing is not working, and this can be corrected by this way. So this is a positive criticism or positive feedback will help the change the system. Otherwise things will go on only, this is not working, this will not be helpful. Next part is the advocacy and awareness. Awareness, madam already mentioned that how awareness is important. Another point I missed with respect to advocacy. Now I am facing few of the issues at the national level. There are, because we are in the information technology era and AI area, newer and newer diagnostic AI technologies are coming up, and everybody comes up with this technology should be adopted. But until and unless it is a cost effectiveness and the larger population effectiveness has been demonstrated, kindly do not advocate. Otherwise what happens, something has come up, and after putting XYZ amount of money, we get to realize that this cannot be used in a larger population. So that can be kept in the mind whenever we are advocating anything new.
Thank you. And my last word, I would again say that many endocrinologists are in, I would repeat at the cost of repeating, in many powerful committees. You are connected to people who can change and move things in polity and in bureaucracy. So please champion that. And we are in the age of GLP-1, where if you go to Mumbai, the billboard says obesity is no longer your problem, we'll tackle together, it's a disease. So we all know that, we can champion this, that I would rather use the analogy, like in endocrinology, it's the harmony across all the glands and this. So it's the harmony of all these determinants outside when we step out. Built environment. We need cities where we can be physically active. Good food, healthy diets, all of this. And who else? If the diabetologist says this, endocrinologist says this, people will listen. It's like the lived experience. I mean, as far as I remember, I would close by saying when around the time when insulin was invented, diets was still being discussed. People were talking about the diets, and suddenly the wonder drug came, and then it became the disease and the wonder drug, and then the diet somehow disappeared. So championing this, and more public health programs are coming. Endocrinologists are a rare commodity in the public health system. So please support the states. Thank you.
Thank you. So we can open up the floor for discussion if there are any questions. Right, so if you all could use the mic there at the back.
Thank you. I'm Dr. Ajitesh Rai. I'm pediatric in charge of RKMSP VIMS Institute, Kolkata. So I have two questions here, and maybe from my end, this is the comment. So we do see lots of patients of Turner syndrome. So this is the XO karyotype. The patient presented to us at the age of 13 years, 14 years, maybe 16 years. But actually, whenever patient went to pediatrician in the childhood age, the patient was not being picked up by pediatrician because actually they are not looking for the height. They're actually looking for LRTI or upper respiratory infection. So in government settings, I am from village. I know I just cater all the village population and the urban population too. I do not know why it is not happening in these days, but the proper weight and height measurement is not done in any school, particularly in government school. But in CBSE or ICSE school, they are doing, not in a good way, but at least they are trying to do something. Now, when the parents came with the kids, they tell that there is no problem, patient was absolutely fine, and at this time you are talking that she has only 1X. What is that? In this meantime, I just consulted with at least 10 pediatricians in our time. So I think it is not the problem of the pediatrician. In a busy schedule, he or she is catering 100 kids in a day. So at that time, it is not possible to check height in every cases. But that has to be done. But actually, it has to be done from the school level, I think so. The school mistress or the teacher, they will inform parents that he is not gaining or she is not gaining height or weight on the regular basis. So this is a very simple tool, just a stadiometer, and that will suffice to check. And this is the...
Ajitesh, I think they would have understood the question. Okay. If you could respond, ma'am.
So no, under RBI scheme, when they go for screening, there is a, they have to take the height, weight, and a BMI is calculated. And when I was talking about, then they will do the online entry. So automatically the BMI will calculate, the obesity part also, and if the child is not stunted or, so that will be auto-calculated. So we are working towards so that we can do the online entry of every child. So even sometimes it happens that they do calculate and that interpretation they do not do themselves at that time. Even in the Anganwadis, the less than 6 years children, the Anganwadi worker, they actually, in the portion tracker, they take the height and the weight of every child and they have to track. That is the line listed data of every child. It might not be 100% or there might be quality issues depending on the area, but it is very much there, and through the digital mechanism, the quality would be much more stringent, because through the digital, ultimately that's why digital is important, that you should be able to track the child, and that will do those calculations for which you require right now pediatrician will do. So that will actually give you the result that there is some problem. It will, flash red. So at least I think that pickup would be better.
Maybe the implementation is not in a correct way, but if it is that, that is fine, that's good news, definitely.
So I'll be very quick. So metabolic programming in the first 2 to 3 years determines long-term outcomes, often setting in permanent changes. And we are beginning at the school level. So what more can we do to improve this nutrition in the first 2 to 3 years of life? Any plans that you have?
Definitely, as you know, for the nutrition, there is a lot of focus is being put to improve the nutrition, especially as you know, we have highlighted that you know the simple intervention of starting early breastfeeding and continuing sustaining till 6 months and the follow-up of the complementary feeding. So as I once said that with the Ministry of Health along with the, and this is the Poshan month also going on, September being the Poshan month. So there's a lot of government efforts are actually going on with Ministry of Women and Child Development, Ministry of Health being the major stakeholders, that they are working jointly. We have, you know, at the center level also we are working jointly that how we can improve and fill the gaps if there are any. Because Anganwadi worker, ANM and ASHA, the AAA team, they are actually working. First is the home visits through which the ASHA goes to the home. Till the 15 months of age, there are quarterly home visits with a focus on nutrition. Another important platform is your Village Health and Sanitation Day, where they all come together along with the family and they give counseling for the nutritious food. And then the Anganwadi, being the main hub where the height and the weight is taken, the ration is being given to the mother, lactating mother as well as to the child, and hot meals are being served. And even in the schools till 8th class, through the Ministry of Education, PM Poshan Abhiyan, there is a meal is served. So I think all these efforts collaborated with the other aspects will take care of, we should be able to see.
Sir.
Well, I just want to touch to one topic raised by Tushar and Vivek both, and that was in NCD, the role of obesity. The biggest study in this country about obesity in children has been done by Dr. Anup Mishra. And it was eye-opener for us to see that obesity is more common in children going to the government schools rather than in the private schools. And that has been an eye-opener. So I was thinking that there will be some action taken at the central level. Rather than the obesity is being blown up now after the Prime Minister's reference on obesity and the pharma trying to capitalize on that.
Sir.
Well, if you are not comfortable with the question, I can withdraw it.
Definitely see, this is advocacy. If it comes from the highest level, that means, you know, now everybody knows that obesity is not good. You know, me know, and we have doctors who are not very healthy, very fit, you know, everywhere. But when it comes from the highest level, that shows the commitment towards it. And you know, that reduction of oil by just 10%. Even my cook was telling me that, you know, the another household has asked me not to put any oil because PM ne bola hai. So imagine the area it touches. As government versus private, I agree. I don't think there is any, I have not been able to, you know, I have not studied that study you are talking about. But that's true that the junk food and the habits, they are being, I told you, that's a social change we are having. Even at a village in a tribal area, I went to one of these states. The child was having a packet. So it's more of a marketing, advertising, how we are rearing children. So as doctors, we can only counsel and advocate, but we need to change our homes and the society and, develop that, avert that fanciness towards these things. So obesity definitely is not restricted to any particular group. It is, I know it is uniform, but we have the two spectrums. At one time we are talking about nutrition and another, we have the obesity. And in RBSK, just we take the height and the weight, and as I mentioned, the BMI will be auto-calculated and those children will be, then can be followed up. So that is the work.
My second and the last comment is about the
Sorry, I have to interrupt, sir.
Okay.
Right. Just one last question from you, sir. Very, very short, very quick.
Very short.
We've overshot time.
Thank you, Sujoy. Myself, Dr. Mondal, Deputy Director of Health Service, West Bengal, looking after non-communicable diseases. My question directly to moderator. You have discussed so many things, a lot of discussion on obesity, diabetes, etc., thyroid, hypothyroidism, hyperthyroidism. What about osteoporosis? Considering demographic transition, at this point of time, not less than 11 to 12 crore% of people above 60 years. So osteoporosis is probably not in our consideration. What public health intervention you people are suggesting for those 11-12% of population, those who are older, getting older and older? One question, one suggestion to Shobhana ma'am, you have explained in different way, but I suppose RBSK team, there are 6 members in each block. They may be utilized in a much better way. Health promotion and prevention, especially obesity management, lifestyle modification, they are doing only screening. No talk on health promotion, no talk on obesity management. They just taking weight and measuring height, calculating BMI. What intervention they are doing? They are not referring them to any PHC or BPHC because this is not a disease. Thank you.
Right. I think we should be talking about osteoporosis. That's again a major point that you've talked about. I think ISBMR was also talking about. At least from Endocrine Society of India, there are 2 things that ma'am has asked for. One, help for capacity building, and the other is advocacy. With this 2, I think we will have a plan and we'll go to the government. Last one word and then we finish.
Okay, We've already run out of time.
I must share one thing. Long back, Professor Fuster done a job where the very young children were made to exercise before the age of 6 years. Subsequently, they are continuing exercise in their later part of life.
Point taken.
Those who have started late in the day, they cannot continue. The most important thing is that I am from a subdivisional town. It is hardly any place for the children to play over there. There is no place to play excepting the school field. And there is no park, etc., where I can. You must be knowing Dr. Mohan earlier done a walking zone for jogging, and the change of the diabetes incidences were changed. And lastly, as regards to diet, should we not be having a chapter in children's book? What is good diet, what is bad diet, and how
Point taken, sir. That should be in the school health program as well. I think we need to close. I think we've shot over by 12 minutes, sir. Thank you, sir. Thank you. I think the panelists were excellent, and I am grateful to all of them for having taken time out from their extremely busy schedule and having come to our meeting at ESICon, Kolkata. Thank you very much. And members of the press who have been here, if I could request all of you to follow Dr. Shomik to go to the brass room, please. And request the panelists to come along to the brass room, please. Thank you very much. And I hand over to the Orundhuti.
Suppress kar
I would like to thank our esteemed panelists and moderator, sir, for this excellent comprehensive session on public health. Now, from public health issues, we move back to adrenal. The next session will be on perplexing adrenals. So for chairing this session, I'd like to invite on stage Dr. Purushottam Chatterjee sir and Dr. Salam Ranvir sir. Over to you, sir. Thank you.
So for the first talk, I'd like to call upon Dr. Muthukumaran Joypal. He'll be speaking on fetal-placental sterogenesis, clinical implications. So Dr. Muthukumaran is CCT Indo and Internal Medicine. He is a Managing Director and Consultant Endocrinologist at ARCA Center for Hormonal Health Private Limited at Chennai. He is the President of Endocrine Society of Tamil Nadu and Puducherry. So over to you, sir.
Thank you, Chairman. Thank you for the West Bengal Endocrine Society for the invite. It's my pleasure to be here, and we move on from prevention to something which is even more important. My task for this afternoon is to give you a broad overview of this topic, fetal-placental steroidogenesis, and we are going to look at mostly the clinical implications of this. First of all, it's my duty to remind you of physiology, what we did in medical school, and what we are referring to as fetal-placental unit is a functional relationship and interaction between fetus, placenta, and the mother in steroid biosynthesis during pregnancy. So this is what we are looking at. And primarily, we are going to look at how the fetal adrenal evolves, how the fetal liver helps in the primary steroidogenesis, and how it correlates or coordinates with the placenta in making this whole endocrine cycle a possibility. So the key hormones in this axis is estrogen, progesterone, and other hormones. And the whole primary function of this entity is to maintain pregnancy, supporting fetal development, regulating maternal and physiological adaptations. So primarily we are going to talk about placenta, the fetal adrenal glands, and the fetal liver, which we say as a fetal-placental unit. And in the fetal-placental unit, it all starts with the fetal adrenal glands, which are the primary source of dihydroepiandrosterone, which is the DHEAS, what we call as, which is primarily metabolized further in the fetal liver and placenta to produce wide variety of estrogen. So the primary estrogen comes from your fetal liver through DHEAS. So this is one thing which is very, very important. And further on, the placenta grows and takes over the system. When we talk about adrenals, pregnancy, we always think about CAH, but there is a lot more to other things than just CAH or androgenization. So here we look at the maturation of the Graafian follicles and ovulation. The HPA axis maintains the folliculogenesis, and whereon post-ovulation, the Graafian follicle vascularizes and the granulosa cells become luteinized. The corpus luteum first is the initial process where progesterone is secreted. 17-alpha-hydroxyprogesterone, estradiol, and androstenedione hormones are first secreted from the corpus luteum. This is where it works like, and the corpus luteum maintains sufficient hormones to maintain the initial stages of pregnancy, and from where on, from the corpus luteum at 6 to 8 weeks, there is a change for the placenta to take over. So this is what we call as a luteal placental shift, where primarily the corpus luteum is a temporary endocrine organ, where you move on to the placenta, where multiple hormones are secreted, and there are hormones which act like a pituitary hormones. There are hormones which act like a hypothalamic releasing hormones as well. The pregnancy hormones as such are two types. One is the protein hormones and the steroid hormones, as enlisted here. But primarily we deal with the top four here: HCG, HPL, estrogen, and the progesterone. HCG, we are all aware that it's a glycoprotein, and it acts as stimulus for secretion of progesterone by the corpus luteum of pregnancy. And what it basically does is rescues and maintain the corpus luteum till 6 weeks of pregnancy, and it also stimulates the Leydig cells of the male fetus to produce testosterone. It also has got an immunosuppressive activity, which may inhibit the maternal process of immunorejection if there is a possibility. And due to time, I'll just skip this. And HPL is another hormone which is synthesized by the syncytiocytiotrophoblasts of the placenta, and is in the maternal serum first detected from the 3rd week of gestation. And progressively it rises, and it's proportional to the placental mass. And its function is it antagonizes insulin action, and high levels of maternal insulin ensures that adequate protein synthesis is maintained during pregnancy, and it also causes maternal lipolysis and promotes transfer of glucose and amino acids to the fetus. And it also promotes growth and differentiation in the breast for lactation. Progesterone, we are all aware, but it's from the corpus luteum. It happens prior to 6 weeks, whereas the placenta takes over later, and there is adequate amount of progesterone secreted throughout pregnancy, and it's maintained at high values, and it rapidly comes down after delivery. So the two primary hormones which are responsible for maintenance of pregnancy is your estrogen, progesterone, and they also sensitizes the myometrium to oxytocin and prostaglandins. Progesterone, along with HCG and decidual cortisol, inhibits T lymphocyte. Again, it just avoids tissue rejection. And in summary, this is our first part of the talk. You have progesterone. Estriol is the major estrogen produced from the placenta, and this all happens through the fetoplacental unit, comes through the fetal liver and the adrenal gland, which estriol primarily comes through the DHEAS. So what is your normal placental development and function? The primary function is trophoblast invasion, where early trophoblast cells invade maternal spiral arteries, remodels vessel architecture to ensure adequate blood flow and nutrient delivery to the developing fetus. So this is a primary aim of normal placental development. There is a lot of vascular heterogeneity, how these things develop, and these can be regulated by long-chain fatty acids. And if any derangement in these mechanisms happen, then you run into problems with the fetoplacental unit. And any adverse influences early on during pregnancy will cause altered programming, and you are at an increased risk of developing cardiovascular diseases, diabetes, or even chronic diseases. So what are all the problems we face with fetoplacental unit dysfunction? We commonly encounter things like fetal growth restriction. We encounter preeclampsia. We encounter premature birth, placental abruption, and fetal hypoxia. So these are all primary problems what we face with fetoplacental dysfunction. How can we identify these? These are multiple biomarkers which are currently available, which can tell us whether our fetoplacental system is working adequately. And these things have been tried and tested, including PAPE is widely available now, and reduced PAPE levels are noted to be strongly correlated with IUGR. Not only the biomarkers, we have got combining the biomarkers with your Doppler ultrasound helps you identify problems early on, or even negatively demystify things like where you can just differentiate a small gestational age from an FGR baby. So kind of these things help. But again, there are lots of limitations with high false positive rates, measurement errors with these methods. So we move on to the problems, clinical implications. What are the conditions we are going to look at here? Primarily, the first one, what we are going to look at is preeclampsia, which is an altered fetoplacental dysfunction. And here, as I said earlier, there is inadequate trophoblast invasion resulting in poor spiral artery remodeling. If you look at here the picture, the top panel is your normal panel. This lower panel is your preeclampsia histology, where there is inadequate, poor spiral artery remodeling leading to reduced blood supply to the placenta, which triggers a lot of anti-angiogenic factors causing widespread maternal endothelial dysfunction. So this is where primarily the problem arises. Early on, if you develop eclampsia before 34 weeks, it's a lot more severe. Later on, preeclampsia is slightly less risky. So this is primarily due to abnormal trophoblast invasion. There is significant placental ischemia. The placenta is unable to compensate for the placental hypoperfusion and chronic ischemia. And thereafter, there is a lot of release of anti-angiogenic factors causing problems and fetal implications. And the fetal implications are that there is decreased nutrient and oxygen transfer to the fetus. There is risk of IUGR. There is risk of preterm birth. So these are all problems in a preeclamptic mother and the baby. So again, this leads to oxidative stress, secondary mitochondrial changes, which causes altered expression and activity of mitochondrial oxidative phosphorylation complexes. And again, the long-chain fatty acids, which are supposed to protect you, are significantly deranged and are unable to protect you from the dysfunction. So what are the clinical consequences of having fetoplacental dysfunction in preeclampsia? Fetal impact, there is placental insufficiency leading to fetal growth restriction and preterm birth and higher perinatal morbidity. Maternal consequences are severe hypertension, proteinuria, potentially life-threatening multi-organ injury requiring medical intervention, and then finally long-term risks both to the mother and the fetus with elevated risk of cardiovascular disease, which might last for a lifetime. Moving on, gestational diabetes is also a well-known disease which is caused due to fetoplacental unit dysfunction. And here, the maternal hyperglycemia during progressive stages of pregnancy causes fetal hyperinsulinemia and abnormal placental hypervascularization, which leads to endothelial dysfunction, causing placental endothelial damage and oxidative stress, causing adverse pregnancy outcomes. So this is gestational diabetes on its own. Again, as effective as your preeclampsia, here the problems are the placenta produces several of hormones which increases insulin resistance in the mother, including HPL, estrogen, progesterone, and cortisol. There is placental hormones which are increased, causing hyperglycemia resulting in GDM, which further on causes aggravation of the glucose metabolism, causing a higher glucose gradient from the mother to the fetus, causing fetal hyperglycemia, which further aggravates fetal hyperinsulinemia and macrosomia. So this is a cyclical problem with dysfunction due to the fetoplacental unit. Sorry. So there are then feedback mechanisms of the placenta which causes increased placental weight, which is a common problem with GDM, altered vascularization, and increased oxidative stress and inflammation. So here, the clinical implications of GDM in the fetus is macrosomia, hypoglycemia after birth, due to the persistent hyperinsulinemia during pregnancy, and increased obesity or type 2 diabetes later in life. What about the maternal effects? You have risk of preeclampsia, you have increased chances of cesarean delivery, and again, post-delivery type 2 diabetes in the mother. So finally, fetoplacental unit alterations are permanent in a we talked about gestational diabetes. Here we are going to talk about type 2 mothers who are getting pregnant. So here the alterations are even aggravated further and there is permanent changes in this mother's pregnancy. So there is chronic increased nutrient exchange, there is abnormal gas exchange, as well as abnormal hormone regulation in a patient with type 2 diabetes already. So here there are significant structural changes in the placenta, which are mostly macroscopic changes, which causes increased placental weight and thickness, enlarged surface area for nutritional exchange, altered placenta to birth weight ratio, and the microscopic features of increased placental weight is increased syncytial knots formation, villus edema, vascular malperfusion patterns, and altered villus maturity. So here, primarily endothelial dysfunction is present all the time and already there before the pregnancy even starts. So what is the clinical impact of pre-existing type 2 diabetes? Fetal macrosomia is a very, very high risk in these patients. Excessive nutrient transport, metabolic complications in the neonate with high risk of hypoglycemia, again hyperinsulinemia, metabolic disorders. And there are again long-term effects of having born for a type 2 mother with changes in the placenta leading to metabolic dysfunction. So to conclude, the human placenta or the fetoplacental unit is a unique organ, facilitates fetal exposure to many hormones and regulate pregnancy. The placenta is, as thought to be by most of us, is not a passive organ, and it facilitates transfer of energy, metabolism, and hormones throughout. And obviously, I couldn't have much time to talk about the EDCs as well in this topic, but EDCs are also a known problem with contributing to fetoplacental dysfunction. So we need to increasingly focus on chronic disease states from the start of pregnancy to avoid any malinterruptions or maladaptations of hormonal function. Thank you so much for listening.
Thank you, Dr. Jayapal. We'll take question after the end of the session. Okay. Now we are moving to our next talk. It will be on a very important aspect of adrenal disorder, which often confused us and stumped us, that is pheochromocytoma. And to talk about that, we have Professor Nalini Shah. I think Madam needs no introduction, so it is over to Madam.
Can I have the slides, please? Can I have the slides, please? Well, good evening, ladies and gentlemen. I stand here in gratitude to the scientific committee for this particular opportunity, and I must put on record the massive efforts put together by the organizing committee and the organizing team to put together this huge mammoth task of arranging Endocrine Society of India's 2025 show in a rather seamless manner. My hearty congratulations and thank you very much for this opportunity. I think the talk for the day is centered around how does one really navigate the different aspects of biochemical diagnosis, which is rather important not only from the diagnostic point of view, but also from the monitoring point of view in this particular set of arena. The learning in this particular area comes from my superb colleague and current faculty members of Department of Endocrinology, and not to mention the endless number of discussions that we have in the department, like over here, that we are arguing over a case or a diagnosis or a management, and with our superb postgraduate students who continue to teach us every single day. I must say that learning continues in institutions and departments like this, which has a focus on adrenal disorders, and by now on our data set, we have something like 600 patients with pheochromocytoma and paraganglioma. And I must say that every case brings in a new learning point that we go through and sort of become enriched in the process. The learning in this context, I must put together against the deranged pathophysiology, and we all have understood in a rather hard way, especially a person like me who has gone through the whole navigation system of the diagnostics, and I'd like to allude to that catecholamines as a parent compound are no good for the diagnostic test at all, because they are very random, they're very erratic in their secretory nature. It's only the COMT-derived derivatives, which we talk about, the metanephrines, which are the test of the day and which should be what we should be alluding to in our clinical practice. We don't even want to talk about perhaps the urinary parameters of diagnostics, be it total or fractionated metanephrines, because there's a huge admix of components secreted from the gut, and that dilutes the signal strength which originates from the tumor. So we are talking about this dark black line represents metanephrines, and that too we are talking about free metanephrines, which are the direct descendants and a signal of the tumor, and which is most useful, rather than the parent compound shown here in the gray line, which are catecholamines, which are rather random and erratic in their secretion. Some of us have lived through the diagnostic changes which have been brought together in this segment of pheo and paraganglioma. We started off with something like a VMA, which is a very poor test in terms of its sensitivity, and we marched down all these areas of urinary total, urinary fractionated metanephrines, and now we've come to rest on plasma or urine free metanephrines. And I must say that in our country, as of today, we have plasma-free metanephrines. We do not have urinary-free metanephrines. And I must give you a slight bit of a background related to this. Up until 2007, we did not have plasma-free metanephrines in our country. And as we sort of put together, as pheo as one of our area of interest in the department, we started sort of discussion with multiple laboratories to convince them that this was a test which needed to be brought in our country. And 2010 is the one where this test was brought in our country. We sort of accrued our own learning curve and published this data. Vijay, a very, very bright postgraduate, published our data and showed that it's a rather sensitive test, which kind of does miss few data points here, but it still gives you a sensitivity of close to 94% and does not leave behind too much of false positives at the end of the day for us to handle. And we realized then that plasma-free metanephrines is the test that you want to go by. We also learned along the course of event with work of very active and seminal group of people like Eisenhofer from Dresden, Germany, that when you look at data points with plasma-free metanephrines, you read it in context with your pre-test probability. You cannot read these data alone as a freestanding numbers. And in context of high-risk individuals, you want to work with a very sensitive test because you don't want to miss these lesions. Whereas in a low-risk population, which is what we deal with in many of these anxious individuals and so-called postmenopausal women, you want to not generate too much of a false positive data. Even then, we realize that even with sensitive tests like plasma-free metanephrine, we still leave behind 5% of false positive data, which needs to be further sort of enhanced and dealt with in clinical practice, and we'll just refer to that in a minute. What we also understand is the platform on which you do these biochemical tests is extraordinarily important. You cannot equate the results which you accrue on LCMS, which is the platform of choice, and data generated from that vis-a-vis a data which is generated by immunoassay. What we learned very recently, and that's extraordinarily pertinent, is that immunoassays, and right now in our country we work with enzyme-based immunoassays, they underestimate the level of norepinephrine and methanephrine to the tune of 60 to 40% compared to the LCMS-based data which is generated, and that's a design of an assay. It's a design of an assay which only estimates the L enantiomers and cannot estimate D enantiomers, and that's a design which we cannot rectify, really speaking, and that essentially means we are underestimating a given test as a number when we do it by enzyme immunoassay, which means that we need to correct the data which is generated by the ELISA to LCMS-based data system, where we need to not only correct it for the negative bias which is generated by the assay, but we need to apply age-specific norm-based corrections, because we know that norepinephrine from, say, let's say about 5 years of age to 65 years of age, it shows doubling of numbers in a normal individual. So you want to read it in context of this age-specific numbers. So when you read ELISA-based numbers which are generated by immunoassay, you need to use this formula to know where does your level stand, to understand whether it is pathologically elevated or otherwise. And that's a very important segment of information that I'd like to leave behind with all of you. We also need to realize that we need to adhere to and respect the pre-analytics when we are looking at this particular sample-based assays, right? It is rather important to realize that the time of the day is not important. You can collect a random sample in this patient, and that's a big relief because it has several pre-analytics that need to be addressed, and you really don't want to add one more pre-analytic of time of the day as well. So if you can notice over here, both methanephrine and norepinephrine as an assay system can be applied on any time of the day. It doesn't matter if there is a menstrual cyclicity, because that doesn't alter the level of metanephrines per se, and metanephrines plural stands for combined metanephrine and norepinephrine. It is sensitive towards the collection system, whether you use serum-based assay or a plasma-based assay, whether you collect blood on heparin-based anticoagulants or EDTA-based anticoagulants, and how do you store your sample. It is sensitive, and it is good practice to liaise with your laboratory to ensure that the cold chain is maintained in this particular sample collection. Time after venipuncture, thankfully, is not very important and not significant enough to alter the numbers which are generated, which is important. Otherwise, we would have to work with invalid catheter, which adds to the logistics of the test performance also. But we definitely need to work with the posture of the patient. The blood collection has to be done after being in supine position for 20 minutes. It cannot be done in sitting and standing position, and that's definitely important. We also want to avoid caffeinated drinks because they alter the norepinephrine-based levels, and we understand that norepinephrine, if at all we had to curtail the cost of this test, because this is an expensive test to be generated, and if we are using norepinephrine, which is a very good screening tool, we want to avoid caffeinated drinks. Food as an item with or without enriched compounds of DOPA-based system, which is a precursor to catecholamines, is something which is extraordinarily important for when you're looking at 3-methoxytyramine-based assay systems, but for norepinephrine and metanephrine, it is not important. Post-exercise, there is some amount of change, so you don't want to collect the sample after a vigorous exercise in a given individual. So what does it mean in a practical setting? In practical setting, it means supine position of 20 minutes and maintaining a cold chain and avoiding caffeine and heavy bout of exercise. This is what it translates into in our practice, and this is what we should be looking after. But there are certain scenarios which generate a false negative data set, and that's extremely important to us as clinicians, and we should be aware of it. Look at this patient. He is a known case of hepatocellular carcinoma. And as a part of staging of the disease process, the CT scan is done to show you that tiny tumor which is sitting in the right adrenal bed. The question was it pheochromocytoma or was it metastases from HCC? And we all know that HCC-based metastases are very bright. Radiologically, you cannot distinguish between the two. The patient's number, which was generated as test of plasma-free normetanephrine under due pre-analytic was in the range of 150, whereas the upper range of normal for that particular age group is about 200. Now, we need to respect one thing. Tumor size is a determinant of level of plasma-free normetanephrine. And this is the work which has been done several times in several papers based from 2000 to 2010, and it is extremely clearly shown, which means that the small tumors, you will miss the diagnostic number of signal being generated. That's first scenario of false negative. The second scenario of false negative that you can walk into is a cystic pheochromocytoma. Depending upon the size of the cyst, and in other words, the size of the solid tissue which is left behind, the plasma-free normetanephrine will be equally challenged or reduced in this case scenario. And in this particular patient of ours, it was elevated, but it was so very borderline that one was worried whether it is really pheochromocytoma and whether you take the patient through all the pre-surgical management which we need to do routinely in patients with pheochromocytoma. The other scenario which you get false negative are giant pheochromocytomas. They are generally functionally extraordinarily challenged tumors, and you can get very poor or non-secretory nature of this tumor. However, you need to realize that biochemically so-called non-secretory doesn't mean that you'll not walk into the complications in the perioperative period, and you still need to be conscious about it. This particular patient of ours operated, proven histopathologically to be pheochromocytoma, had a level which was extraordinarily low. This is one of the scenario of false negative data. False positive data is equally challenging, and a most important scenario which emerges over here is drug-related. There are several groups of drugs which either increase the sympathetic output or change the metabolism of the sympathetic output, which is norepinephrine and epinephrine, towards either being sort of reuptake gets inhibited or the MAO gets inhibited, enhancing the COMT pathway and giving you falsely elevated results. So we need to be very conscious of that. Acute illness is one scenario where you cannot interpret data related to normetanephrine, and this is a scenario which holds as an exception that imaging is far superior to give your answers rather than work with biochemistry, because all acute illness will give you same amount of elevations which cannot be differentiated from any kind of cutoff. Not all normetanephrines or metanephrines which are elevated come from pheochromocytoma. And here is an example, hugely elevated, 14,000 picogram per ml as an elevation of normetanephrine. But we were very worried about this patient. And why were we worried? This patient showed a huge jump in the size of the tumor in matter of 3 months. He came in as very sick individual with ascites. Pheos, even malignant pheos, do not behave like this, and we were worried whether it was something beyond that as a dedifferentiated cell line like a neuroblastoma, and sure enough it was. It was a neuroblastoma, and patient was offered new adjuvant therapy, shrinkage of the size of the tumor which was surgically considered to be inoperable, and now he awaits his turn for surgery. What we need to learn as a lesson is even neuroblastoma, though it comes from an undifferentiated cell line of chromaffin cells, does have signal intensity which is very good for norepinephrine with 3-MT as a diagnostic test, unlike what we used to think previously of just doing HVA and VMA. No more we think like that for that particular tumor as well. False positive data generated, which we do encounter as a challenge, like in this particular patient with ovarian malignancy and a small tumor sitting as questionable paraganglioma, which is what we had to answer again for the staging purpose of the disease, and the biochemistry, which was sort of what we were wondering whether it was false positive. We may need to resort to clonidine suppression test, and clonidine suppression must be read against a context of age-appropriate data, and what we kind of read it as clonidine, which is not suppressible in an age-wise manner, is important, and that's one of the modification of clonidine suppression tests that we should be aware of. CKD as a state changes the levels of metanephrines, and that was a learning that we went through in one of our recent patients with pheochromocytoma, which presented with CKD stage 4, and we realized that we needed to use the scale of upper cutoffs, which are almost 1.5 to 2 times the normal levels, depending upon the level of CKD staging, and these cutoffs are available and should be used to read the data appropriately. Pregnancy is a challenging state. You want to consider a possibility of surgery safely in a second trimester, but we do not have any cutoff in pregnancy. We use pre-pregnancy cutoff itself for this particular set of patients, if at all we are challenged to encounter this scenario. Diagnostic utility of norepinephrine stands as a screening test, but metanephrine has its own potential and has its own utility, which emerges is what I'd like to suggest. And reading metanephrine secreting tumor, or calling a particular tumor as a metanephrine secreting tumor, there are different ways which are suggested in the literature. One of the way which was suggested back in 2005 and 2010 is what I've suggested over here as a formula. And the importance of understanding that comes from the fact that metanephrine secreting tumors and norepinephrine secreting tumors behave very differently vis-a-vis the age of presentation, the location in which these tumors are present, and the tumor behavior in terms of their possible metastatic potential. So you always want to know the nature of this tumor to be a little more vigilant in planning your post-operative course in these individuals. The constant thinking and learning that we have gone through is metanephrine is produced only by adrenal pheochromocytomas in presence of adjacent glucocorticoids which stimulate PNMT. Can I take a minute? Thank you.
Yep.
But here is an example of Chinese data set produced in 2020, a very handsome number of paraganglioma as a set that they produced, where they showed very clearly that if a paraganglioma has clustered 2 mutation, which inducts metanephrine secretion. Even paraganglioma can secrete metanephrine, which is what they showed in 30% of their set of paraganglioma. And that's one of the major learning that we went through, and we'd like to share it with you as well. 3MT is useful. It's a useful diagnostic tool. And now, as you know, in LCMS, you get it as a panel. And we have started learning this. We still don't have our data assimilated to talk about it, but it's a good tool to learn towards enhancing specificity towards malignancy. There are many future alternatives which are emerging, like spot urinary metanephrine, salivary metanephrines, and biomarkers of blood sample itself. If I was to conclude the data, respect the pre-analytics, use normetanephrine as a screening test. Metanephrine allows you to enhance your understanding of the behavior of this particular tumor. Start learning the use of 3MT is what we have told ourselves, and we have started assimilating this knowledge as well. And lastly, I'd like to just acknowledge the work of all my brilliant postgraduates who published in this particular segment of pheo and paraganglioma over the years, 36 publications from the department, and we still continue to learn with the help of this brightest of the bright colleagues from our department. Thank you very much.
Excellent presentation, Madam. As usual. Madam, please come and. Okay, next, I'd like to call upon Dr. Anurag Leela. He'll be talking on mild autonomous cortisol secretion management and update. Dr. Anurag is additional professor in endocrinology at SEGS MCNKM Hospital, Mumbai. His area of interest is pituitary, adrenal, and gonadal disorders. He has got more than 175 papers in peer-reviewed endocrine journals. Over to you, Dr. Anurag.
Thank you. I'll be speaking on mild autonomous cortisol secretion. In our department, we have been working on Cushing's as a subject, and that's our area of expertise. We would have managed around 700 cases of Cushing's as of now, of which still the number of mild autonomous cortisol secretion is very small. We might be missing them, or it is an ethnic difference, is something I don't know. It could be both. So we have to keep our eyes open for this condition. So the first 3 cases have presented to us as patients, and then it was obviously they had florid signs of Cushing's and they were overt Cushing syndrome. And we did a scan, and the adrenal was found to have some pathology, which could be ACC, PPNAD, or an adenoma. As against the last 3 cases, where a scan was done for an unindicated or some other indication, and then we picked up an adrenal mass. So it's an adrenal incidentaloma. When the mass seeked us, we were not seeking the mass. And then these cases, when you look at, they are very subtle. They don't have any obvious discriminatory signs of Cushing's. And this is what we call as mild autonomous cortisol secretion. And in these cases, if we do a ODS cortisol and it is found to be more than 1.8, it classifies to be MACS. In this category, we have hyperplasias, adenomas, and carcinomas. The carcinoma is not kept in this category because the management is straightforward, where you have to do a surgery. When it comes to hyperplasias and an adenoma, we have to decide between the medical management and the conservative approach or the surgical approach. So the last 2 categories of adrenal pathologies, which can be hyperplasia or adenomas with mild autonomous cortisol secretion, which means they have an ODS cortisol of more than 1.8 and don't have distinct signs of Cushing's, are the last 2 cases which we are going to discuss today in this topic. So the definitions have changed from mild possible autonomous cortisol secretion to preclinical Cushing syndrome. So the last guidelines have given a definition of possible and an autonomous based on up to 5 cutoff. 1.8 to 5 was possible and more than 5 was autonomous. Now that distinction has been taken away, and it's kept very simple that any adrenal incidentaloma, you have an ODS of more than 1.8. and the distinct signs of Cushing's are absent. Distinct signs means the catabolic signs of Cushing's, which affects the skin, muscle, and bone, would be absent in such a scenario. So the MACS prevalence, again, I always say that many of us during COVID got screened with CT chest, and adrenal is a part of that. And still we didn't pick up many adrenal incidentalomas in our scenario. So again, I say whether it is an ethnic difference that the adrenal incidentalomas are less common in India, or we are missing them still, we don't know. The conservative cutoffs are like at least 1% of the scans at least will have an incidentaloma, of which 10% would be mild autonomous cortisol secretion. So it boils down to 10 lakh population of India will have MACS if we are 100 crores there. So are we missing these cases? Are we overlooking these cases? Is something I leave it to all of you to understand. But still, even at KEM, we have a small number of patients which we have managed with this condition over a period of time, which constitute less than 5% of our cases of Cushing scenario. So the first case is overt Cushing. The lady who presents with Cushing's, we do a scan. It's an adenoma. It's straightforward surgery. There's no questions asked. The second case, the elderly person presents with constipation. Scan is done. Adrenal adenoma was found. A reference was generated. ODS was done. It was found to be 3.45. Now the question is our diagnosis correct? So what is the false positivity of ODS cortisol? So the false positivity of ODS cortisol, when you talk about Caucasians, is up to 20%. So if you do 100 normal people, 20% of the people will have false positive result. And if you apply that 20% result to the background of MACS, so 20% of your adrenal incidentaloma will turn out to be MACS. So that has to be taken into the background. Luckily, in our scenario, the specificity of ODS with a cutoff of 1.8 is very high. So when we did it for 1,000 patients of diabetic individuals, ODS cortisol, 96% of them suppressed it. Only 4% who didn't suppress got suppressed on LDDS. So luckily it is very less for us, so we are less likely to misdiagnose these cases. How can we increase the specificity? Can we use other tests? Yes, if the DHES is also low, if the ACTH is also low, it is corroboratory that it is an autonomous cortisol secretion which is suppressing ACTH, and the DHES is a HbA1c of ACTH, so that can also be done, and these are easily available on LCMS assays these days. While doing an ACTH assay, we have to be very careful about the platform we are using, because we have burnt our fingers of diagnosing ACTH independent cases as ACTH adult cases having a high ACTH on Imulite platform. So we have to be very careful. You are using a Diasorin or a Roche platform when you are using a ACTH. So adding DEX plus tests like ACTH, DHES, or other tests like midnight salivary cortisol or LDDST can increase the specificity. So in our scenario, I would recommend LDDST behaves very good. So we can use LDDST in a scenario to prove that we are dealing with the autonomous secretion. So this is a Lacroix protocol, which as a resident, I have done this for this patient of bilateral hyperplasia, which we have seen. He was admitted in a surgery ward for some other indication and was found to have hyperplasia. ODST was high. He didn't have any sign of Cushing's. So it was MACS with hyperplasia. And these tumors have various ectopic or eutopic receptors, and you can try to stimulate them. And the vasopressin stimulation was seen and the ACTH stimulation was seen. But these tests usually will not change into patient management unless until you have a food-dependent Cushing's, in which you can have a different genetic etiology for it. And today, with the use of GLPs and the GIPs, if someone is gaining weight on these drugs, please think of this scenario. Maybe we may see these scenarios in future if you have an adrenal incidentaloma or hyperplasia who is having these receptors. So in our case, what we did a LDDS cortisol was high, LNSC was high, So we know our diagnosis is correct. We are dealing with an adrenal incidentaloma with a MACS. Now the second question which comes to the patient's mind and our mind, the patient will ask, is it a malignancy? Is it going to grow? So that's the first thing when you have, it is an incidentally picked up. Patient was hale and hearty and you have picked up a tumor. And the first question comes to our mind is it a malignancy? So to rule out malignancy, the ACCs is very, very rare. So the pretest probability of it not being malignancies is very high. But when you are asked this question, you have to be very sure that you have not missed a malignancy. So in that scenario, this 3 cutoffs can be used. If the mass is less than 4 centimeter in size, if the basal HU is less than 20, and then they have done a urine steroid metabolomic showing a low risk. So if all 3 are met with, the risk of ACC is very rare. So, and in our scenario, we have not been doing urinary. We have largely depend on the radiology. And if the mass is lipid rich, and if it is lipid poor and good washout, that means it is not ACC. And we use a cutoff of size of 3 centimeters because last 40 ACC patients, 3 were between 3 to 4 centimeters. So we want to use a conservative cutoff of 3 centimeters instead of 4 centimeters there. And the steroid metabolomics are available with us now. So discriminate ACC from other lipid poor adrenal masses. We have the LCMS panel of steroids, of which we can use the 3 steroids to our the androgen pathway, and one is a steroid precursor of 11-deoxycortisol, and we got these 3 steroids, and we have derived an equation on which this can be used. It is an unpublished data as such, and we can rule out or rule in ACC when we are dealing with such a scenario. Coming back to our case, the size was 1.9 centimeters, the basal HU was 11, the DHES was low, so we can convince the patient that we are not dealing with a malignancy, it looks like an adenoma. The next question will be, will it grow or become overt? As an endocrinologist, the first thing even a non-functioning adenoma comes, we keep screening the patient over a period of time, it may become overt. But basic pathophysiologies of these tumor doesn't change over time, and they don't change their nature, they don't grow very fast, and their biochemical nature also doesn't change. So the natural history of these situations, as per the numbers is so, the increment more than 1 centimeter was seen in only 2% of the cases, and only 0.1% of the MACS will turn into overt Cushing's if followed over a time. So I can make sure this patient that this is not going to change its character over time, and this is not going to grow at a very fast pace. So let's be assured about this scenario. And so this we have answered that it is not going to grow or become overt over a period of time. Are the comorbidities due to MACS? Okay, so this person had diabetes and hypertension, and his wife also have diabetes and hypertension. So the hypertension and diabetes of the wife is also because of the husband's adrenal incidentaloma? No, correct. So very clear. So why my diabetes and hypertension is because of this incidentaloma? So because this is a process, this is an aging population when you get these incidentaloma. To answer this question, so at this age, diabetes, hypertension, osteoporosis, dyslipidemia are very, very common. So, but still these patients have diabetes and hypertension, which is more common than the normal population at that age. So yes, MACS do contribute to the metabolic syndrome things, but it is very subtle, and you have to accept it with a pinch of salt. And the second question will come, will diabetes and hypertension get cured after correcting, or if I do the surgery? If it is contributory, yes, it should get corrected. Otherwise, it would persist if it is just because of the aging process. So like an endocrinologist, we do see they are like metabolic syndrome mimics, which will be there. And the osteoporosis and the low bone density will also be because of the cortisol excess. The second question comes in Cushing's, we have seen they are frail, but these are like subclinical or subtle Cushing's. Are they equally frail, or do they have certain degree of frailty? The frailty is defined in the geriatric population based on various criteria, and these patients not only at a higher risk of diabetes, hypertension, cardiovascular risk, cardiac arrhythmias, CKDs, muscle weakness, falls, and the sleep quality is disturbed. So they have a high frailty when you look at these conditions. So the comorbidities are because of MSCS, answer is yes. Is the medical treatment approved? So the treatment would be surgery or medical treatment. So the medical treatment for the comorbid conditions like you're managing diabetes, hypertension, osteoporosis, that will go in parallel. But will you be directing, will the medical treatment be directed towards cortisol? So are you going to give a cortisol reducing medicines? So the cortisol reducing medicines have not been approved in such a scenarios because the data sets have been very small. So the drugs which we can use is metyrocon, ketoconazole or mifepristone as we have been using in other Cushing syndrome. Oscillodostat is not available with us, though there is a clinical trial going at Mayo Clinic on this with 1/4 the dose of oscillodostat, which is 4 milligram, which they use in the routine Cushing's. They are trying to use 1 milligram of this. And this drug may found to be useful. What we have with us is ketoconazole, which is available with us, so which we have been using in certain subsets of patients, like this lady with bilateral hyperplasia with an ODS cortisol of 3.25. She has been managed well on ketoconazole, and her metabolic control has been better over a period of time. So medical treatment has not been generally approved. You can use it as an off-label indication in certain scenarios, and ketoconazole is available with us at present. Will surgery help? No? Okay. So surgery, it's a big question, will surgery help? So post-surgery, there is data now to prove that the diabetes improves, hypertension improves, dyslipidemia improves. Like now we have to balance it like an asymptomatic hyperpara cases where we were conservative in the past, and now over a period of data has accrued, and now the threshold for the surgery has gone down. Similarly for MSCS, the threshold for surgery is going down now, and we have now available good surgeons. Surgery is feasible, laparoscopic approach can be done. So surgery is helpful. Low long-term data on morbidity and mortality still need to be accrued. So it's the same principles we apply for asymptomatic hyperpara when we are deciding for the surgery will be applied for this condition, because this is mild autonomous cortisol secretion. Age, functional status, what is the imaging characteristic, what is the degree of this problem, what are the comorbidities, is the surgery feasible? And when as a doctor we are not very sure, we always take patient's opinion and put patient preference on board as well. So these are the characters. So our patient have undergone surgery, and post-surgery he required a ventilatory support, so we were little again dicey whether what we did was right or wrong. But on follow-up, his diabetic and the antihypertensive drugs have been taken off, and he's doing fine. But he looks more elderly than before because the Cushing was giving him certain chubby look, which has gone away with the weight loss. So whether post-op adrenal insufficiency doesn't happen in most of these cases also. So the degree of cortisol, the suppression of the other adrenal will decide whether the post-op cortisol suppression will be there or not. So 50% of these cases may not have cortisol suppression, but again, it is directly linked to the baseline diagnosis. If the severity of hypercortisolism was more, you are going to get into post-op hypocortisolism, which we have to manage. And the duration of post-op hypocortisolism will also be directly proportional to the baseline severity. Certain scenarios, if we have bilateral masses and we have to think of surgery, so which mass we should be operating? So now this brings us to a situation like cons, where AVS has to be done in certain scenario. So this was a bilateral tumor with MSCS and Cushing. So there is a hyperaldo, Cushing's, MSCS, and bilateral adrenal adenoma. So which adrenal tumor to be removed? So there is a role of AVS in such a scenario. So the adrenal venous sampling, what we do for cons is with ACTH stimulation. Here we do with X suppression. There we correct for cortisol. Here we correct for androstenedione. So in this scenario, the larger mass was found to be Cushing and the smaller mass was found to be cons. And the Cushing tumor was removed and the cons was managed medically, because we could manage cons medically at present. So yes, surgery helps in certain scenario. AVS may be required, but we have to modify the techniques of AVS before doing it. And the last question is it a genetic condition? Because you have found an incidental mass in me, will it be there in my siblings, my kids? Should we be doing a genetic test in this regard? So when it comes to an adenoma, so usually when there is an overt Cushing, we get into PRKACA, somatic mutations. And when it is an MACS, it is a CTNNB, beta-catenin pathway mutations. So it is not likely to be a germline mutation in our patient. But if you have bilateral hyperplasias, with overt Cushing's, ARMC5 mutation is seen in 1/3 of the cases, but in this scenario, it can be seen in up to 10 to 20% of the cases. So with bilateral hyperplasia, we should order a germline test of ARMC5. And now we are diagnosing many ARMC5 families where the index patient was overt, but many of the family members are very subtle, and they may have a ODS cortisol which is very mildly elevated, and they are not very clinically evident. Just in our setup, as I said, we have less numbers of MACS. In our series of PBMH or BAMD, what we call it today, many of them were non-secretory. Maximum were MACS. There were 11 out of those 22, and very few were overt. And we had 2 MEN1 patients who had MACS. One was non-secretory and one was mildly secreting and falling into an MACS category. ARMC5 was seen only on the overt cases in our scenario. So yes, it is a genetic condition. With an adenoma, it is a somatic mutation, but when it is a hyperplasia, we should order a germline test at least for ARMC5. So just to summarize, an MACS in the adrenal mass, ODS cortisol more than 1.8 and no overt features. Specificity of ODST is high in our scenario, in our ethnicity, but it can be further enhanced using DHES, ACTH, or other tests. ACC can be ruled out based on the imaging characteristics with the size and the HUs and a LCMS steroid panel. These masses rarely grow. These masses rarely change their character over time, but they are a risk of metabolic syndrome and osteoporosis and frailty. If you have hyperplasias, yes, it could be a genetic condition, and we have to individualize that treatment. We have to recognize it and put it into perspective. And thank you.
Thank you, Dr. Anurag Leela. I would request all 3 speakers to come and join over this podium for a few question and answer. So if you have any question, please identify yourself and ask the question.
So I'll start the question first with Dr. Anurag. So you said that there is no approval for medical therapy as of now, but surgery helps in some of the patients. So in which category of patients will recommend surgery? In which category of patients? Because we cannot advise surgery for everyone also. Though surgery has been shown to be useful, has shown benefit in terms of reduction in blood glucose and blood pressure and lipids. So do we suggest surgery for everyone or for selected group of patients?
So if the age is lesser and the patient have a longer... Sorry, sir. I'll repeat the question. The question was, which subset of patient will you recommend surgery? Is a question. So again, which subset of patient will we recommend surgery for asymptomatic hyperpara? In the same lines, if we think, we can think. If in a younger age, if patient have a lifespan of next 30 years, definitely a long-term follow-up, the surgery will be most beneficial. In a 55-year-old versus an 85-year-old, that is the one thing I would take care. Second, severity of the cortisol and the comorbidities. So if the ACTH is low, the DHES is low, that means it's an autonomous cortisol secretion. In that scenario, surgery will be done. Surgery, yes, the centers where I have feasibility of doing the surgery, that is one thing which we have to take care of.
I have a question to Professor Shah. Whether the availability of LCMS is going to make our job easier. Sorry, I can't hear you. Whether availability of LCMS is making our job easier or complicated in background of pheochromocytoma.
No, I think LCMS is making our job definitely more certain and perhaps easier as well. So I would say that if it's very expensive, it's about even with whatever concessions and all that you talk about, it costs nearly 6,000 rupees per test.
Yeah.
So if you had to repeat and monitor and so on, it kind of has a fair amount of accrued burden of finances for the family. But if I take out the logistics of the finance and, you know, sort of shipping the sample for cold chain and all that, if choice is there and if LCMS-based data system for metanephrines, inclusive of 3MT, is going to be available, that would be the test of choice.
One question to Madam. Madam, you said there should be age-specific. We should be considering the age. What I was intrigued is that because it was gradually increasing, but after 65 it is plateauing. So any explanation for that?
No, I don't know the answer for that. I don't know whether his question was audible. He wanted to know that 5 to 65, you're showing increment of the levels in norepinephrine, but from 65, why is there a plateau of the data points? So I really don't know the answer to that. Anurag knows the answer. So whenever in our department, the dictum is, if you don't know the answer,
No,
ask
I
Anurag.
don't know, ma'am. I don't know.
Okay, see if he doesn't.
If there is no...
I'm audible. Dr. Shah, it's very nicely explained, ma'am. We have a complicated patient who is a patient who is waiting for the renal transplant, his CKD5, and on imaging he was found to have an adrenal incidentaloma. In that case, as you told, the 3 times the values we have to take for the non-meta. So the values were quite high. So how do we proceed for this case?
So from what I understand, it's a case of CKD.
Yes.
And there is an incidentally detected adrenal mass lesion.
Yes, and the non-meta values are very high. Basically, but it is the assay is not an LCMS assay. It is done from Dr. Lalpath Lab. I think they do by...
Lalpath is LCMS.
Okay. Even it is a LCMS also, then how we go for this case?
So I would consider this...
it is more than 3 times, as you told, that we should take more than, for the CKD patient, probably we took more than 3 times the normal value cutoff. So if it is more than normal cutoff, then we presume that it is a few...
And what's the size of the lesion, please?
Size of the lesion it's a big one. I exactly don't remember. It was quite sizable, maybe around 4 to 5 centimeters or so.
I would consider this to be a pheochromocytoma, and I would sort of look at it from the possibility of patient's GC permits, and if the surgery is feasible, I would consider surgery to be done as usual pre-operative management or betterment of blood pressure control. And blood pressure control, one of the drugs which we find very useful is calcium channel blockers, amlodipine in particular, as an antihypertensive to be used. Even then, even if the blood pressure is controlled, 2 things will have to be looked after. A, post-operatively, intra-op and post-op fluid management and the renal status management. Nephrologist will have to handhold the patient, point number 1. Point number 2, even if pre-operatively the patients are controlled vis-a-vis the blood pressure available data, inclusive of ABPM, which is what we routinely do for our patients, we still find intra-operatively the blood pressure fluctuations in some of the patients. So anesthesiologist has to be prepared with both vasodilators, and as soon as the vascular pedicle is clamped, vasoconstrictors. Both ways, the anesthesiologist will have to be ready and very experienced in managing PO, intra and post-op.
So it has to be done before the transplant is done, it has to be operated.
It should be done. It will perhaps allow your patient to stabilize better. And before undertaking transplant, which is a very major surgical process that you are undertaking, PO will have to be addressed.
Okay, thank you so much.
DOTA scan can be done to confirm it, just to add. A DOTA scan can be done too.
Absolutely.
Sir,
Yeah, I don't know whether you could hear what Anurag said. Yeah.
Sir,
My question is to Dr. Anurag.
Sir, if a patient is having
Can I ask?
and
Jindal.
My question is to Dr. Anurag. Recently, a study, catalyst study was published in which it was found that in difficult to manage, difficult to control diabetes patient, substantial number of patients had hypercortisolism. So
Yes, sir.
should we screen those patients also for MSCS?
So, sir, exactly, sir. So, all these studies are from in Caucasian, sir. So, that was a study we have done for 1,000 patients in our OPD, and we didn't find any MSCS in them. So, that's where the question comes, are we ethnically different, is the question.
Sir, sir, in continuation with the same question.
Last question.
Anurag, sir. Sir, if the patient is having if a diabetic obese patient is having non-suppressed ONDST, non-suppressed LDDST, but normal cortisol, normal ACTH, adrenals normal, so should we label MSCS or pseudo-Cushing?
Okay, so now the question of pseudo-Cushing is stress-induced Cushing's. So in such a scenario, you can do a ODS ACTH. If the ACTH is suppressed, that means it is not pseudo-Cushing's.
Okay, sir.
So in the absence of ACTH, if the cortisol is being made, it is autonomous.
Okay, sir.
Okay, we'll close the session now as the time is up. Thank you.
Thank you very much.
To the organizers.
Thank you, sir and ma'am, for an insightful session. Next, we have an international speaker program. To chair this, I would like to call Professor Dr. Nilanjan Sengupta, sir, and Dr. R.N. Mehrotra, sir. Over to the chairs.
Well, where's Dr. R.N. Mehrotra? This is the last scientific session of the day, but I think probably the most interesting and intriguing one, because we know oxytocin only probably in obstetric practice and problems in childbirth. But as per the topic, it suggests that it is something beyond parturition. So let's invite Dr. Miriam Christ-Crane from Basel, Switzerland, to take us through oxytocin deficiency, really a new endocrine disease. Let's see. Over to Dr. Crane.
Thank you very much for inviting me again to the stage. So it's my pleasure to talk to you about oxytocin deficiency and the question whether it is a new endocrine disease entity. I finished my last talk this morning, which was about AVP deficiency, with this slide, which shows you that in AVP deficiency we treat with exogenous desmopressin. Usually all symptoms like polyuria, polydipsia are rapidly resolved, but still these patients have some neuropsychological symptoms. This is data from our survey in more than 1,000 patients with AVP deficiency, where we found that patients with AVP deficiency, be it isolated or be it in combination with anterior pituitary deficiency, have these increase in anxiety levels, have problems with sexual arousal, with trust, and in total have a lower quality of life. And therefore the question arises, could these symptoms be due to an additional oxytocin deficiency? Now why? Because oxytocin and vasopressin have a very similar structure, and they are produced in the same nuclei in the hypothalamus. We know that the action of vasopressin is mainly the water resorption, so it's the hormone, the main hormone involved in water, in our water and fluid balance. And oxytocin classically, as my chair just pointed out, is involved in giving birth and in breastfeeding. However, oxytocin has several other actions. not only the reproductive actions that we are well aware of, but also metabolic actions, neuroendocrine actions, cardiovascular actions, actions on bone, and this is the topic today, also psychological and social actions, because it increases empathy, trust, attachment, and it works anxiolytic. So coming back to this graph, if we have any disease, be it inflammation or tumor or another, leading to vasopressin deficiency, this could also, because these two hormones are produced in the same nuclei, this could also lead to oxytocin deficiency. Now, whilst we are well aware of the symptoms of vasopressin deficiency, polyuria and polydipsia, and how to diagnose and how to treat, oxytocin deficiency is not really known. We don't know the symptoms, we don't know how to diagnose, we don't know how to treat. So therefore, this is my question. Does oxytocin deficiency really exist? And if so, how can we diagnose and perhaps how can we treat this disorder? So the first studies that aimed to look at oxytocin levels in patients with AVP deficiency looked at baseline levels. So this is a study in craniopharyngioma patients, in survivors of childhood onset craniopharyngioma versus controls. And what this study found is that oxytocin levels, baseline oxytocin and postprandial oxytocin levels, here measured in saliva, in those craniopharyngioma patients with hypothalamic involvement were slightly lower than in those without hypothalamic involvement, but were not different from controls. Also showing the controversy here for baseline oxytocin levels. The left panel shows a study from Boston, from Liz Lawson's group. They looked at pooled oxytocin, which is measurement of oxytocin every 5 minutes for an hour. And they found that in AVP deficiency, here in black, oxytocin levels are slightly lower than in anterior pituitary deficiency only and in controls. However, on the right side, this is another study published in Pituitary. This study found actually the opposite. So oxytocin levels at baseline were highest in patients with AVP deficiency, higher than in patients with anterior pituitary deficiency or controls. So what does this show? It shows that baseline oxytocin levels are actually unreliable, and we cannot use baseline levels. We have, again, like in adrenal insufficiency, like in AVP deficiency, we have to do a stimulation test, like in many endocrine diseases. So one stimulation test which has been looked at is exercise. This is again craniopharyngioma patients before and after exercise compared to controls. And whilst oxytocin in healthy controls increases slightly, but only 25%, it does not in patients. So we can stimulate oxytocin with exercise, but this increase of 25% is not enough to really be used as a standardized stimulation test. We then looked at different established pituitary stimulation tests, such as hypertonic saline, arginine, methylmorelin, or glucagon in healthy volunteers to see and to find an appropriate stimulation test for these patients. Now, as you see on first sight, arginine, methylmorelin do certainly not stimulate oxytocin. There is rather a slight decrease, but that was not significant. Hypertonic saline increases oxytocin, but again, only around 50%. It's better than exercise, but still not enough. And you see also there is a large inter-individual variance. And also glucagon did not clearly stimulate oxytocin levels. And these are more recent data where CRH was investigated. It did not stimulate oxytocin. Kisspeptin, yes, it was statistically significant, but 18% again is not enough to be used as a stimulation test. And the same is true for melatonin, a very recent publication by a Spanish group, but again only 26% increase, which is statistically significant but not clinically relevant. So if I summarize first the physiological stimuli that are known for oxytocin, food intake, psychological stress, physical activity is around 20 to 50% increase. Hypoglycemia has been shown to increase oxytocin, but we do not want to do the insulin hypoglycemia test in all these patients. The strongest stimuli that we know physiologically is breastfeeding and labor, but of course this is not useful for a stimulation test. Pharmacological stimuli is summarized here. Glucagon, melatonin, kisspeptin, CRH is not enough. Hypertonic saline, slightly better, but also not enough. Estradiol, there are older data showing that estradiol increases oxytocin, which is expected in a way, and more recently data are ongoing. However, so far we do not have data really proving it as a stimulation test. So if I take together these studies, then we can conclude that single baseline measurements, pooled baseline measurements, exercise-induced measurements, and established and new pituitary provocation tests do not reliably stimulate oxytocin. And ideally, we would have a combined psychoactive and biochemical provocation test. And this brought us to the idea to use MDMA, which is also known as ecstasy. And ecstasy, as you might know, is a psychoactive substance which increases empathy and pleasure. It works anxiolytic, it improves emotion recognition, and increases trust and closeness to others. So part of the effect of ecstasy goes via an increase of oxytocin. This is already known. It's quite a strong increase of oxytocin, which is not seen, for example, with LSD or with amphetamine. So then our question was, can we use MDMA as a new stimulation test for a potential oxytocin deficiency? And this is what we did. We did a randomized, placebo-controlled, double-blind crossover study in patients with MDMA versus placebo. So we included 15 patients with a vasopressin deficiency and 15 healthy controls, well matched for BMI, sex, and age, and contraceptives. I can tell you it was very easy to find these healthy volunteers for this study. And they all underwent a first group of study of MDMA versus placebo, then they had a washout, and then they underwent the respective other treatment. So the primary objective of this study was, and the hypothesis was, that oxytocin would increase in healthy volunteers, but would not, or to a less extent, increase in patients with AVP deficiency. Secondary objectives were to see the level of anxiety, depression, and alexithymia at baseline, and also at the maximum effect of MDMA to look at emotion recognition and empathy, so the patients and healthy volunteers had to interpret the faces that you see on the slide. So this is the baseline characteristics. Very briefly, the patients were, and the healthy volunteers were around 34, 35 years old, and you see that the main etiologies of AVP deficiency was either idiopathic or a pituitary, post-surgery pituitary adenoma. So it was actually the usual etiologies of AVP deficiency. At baseline, the psychological tests revealed that patients with AVP deficiency, here in red, compared to healthy controls in green, had a higher level of alexithymia, which is the inability to identify or describe emotions. They had a higher level of anxiety and a higher level of depression. So this confirms actually what we found in the survey, and which was also reported in other studies. These patients, despite an adequate treatment with desmopressin, have psychological problems. Now, what about the main results of oxytocin? And this is shown here. In blue is healthy controls. So we found, as expected, a significant and strong increase in oxytocin in these patients upon MDMA. But in red, you see patients with AVP deficiency, and they had no increase of oxytocin at all. So this is the raw numbers. You see at baseline, again, very similar numbers, which proves that you cannot use baseline levels of oxytocin to diagnose oxytocin deficiency. But upon MDMA, there is this 8-fold increase in oxytocin in healthy controls, which was not seen in patients. Also, we did this STAI, which is a measure of acute anxiety in the beginning of the study, which showed that in both groups, this was a bit increased because of some nervousness of patients on what will happen in the study. But then at the maximum effect of MDMA, there was this known anxiolytic effect of MDMA in healthy controls, but this anxiolytic effect was absent in patients with AVP deficiency. Also, if we looked at the subjective effects of patients and controls upon MDMA, you see that, again, controls in blue versus in red AVP deficiency, any effect was stronger in controls, a good effect, the liking effect, the feeling high, or the satisfaction, and conversely also said the happiness, trust, etc. All these subjective effects were more pronounced in controls than in patients with AVP deficiency. What about safety and side effects? So you know that MDMA has some side effects, and that was also shown here. There was a slight increase in systolic and diastolic blood pressure and in heart rate. There was also some slight increase in body temperature, but otherwise, and also the known effects of fatigue or lack of appetite, but otherwise, this was very well tolerated, and the side effects were really transient. Let me show you one study participant with a previous MDMA experience. So this was a 20-year-old male patient who regularly took ecstasy in his teenager years with a pro-social effect, talkative, open, he felt pleasure, and he was relaxed. Then at the age of 19, a large hormone-inactive pituitary adenoma was diagnosed. He got surgery and post-surgically had a complete vasopressin deficiency. 1 year post-op, and despite desmopressin and a good polyuria and polydipsia control, he came to us and he said that he felt socially isolated, little closeness to his girlfriend, and he preferred actually to be home alone. So he was also included in the study, and you see here his oxytocin is completely flat. In blue is his healthy counterpart. And also, he did not feel any effect of MDMA anymore. And interestingly also, the patient told us that he tried ecstasy again at a party, and he did not feel anything compared to his friends who had the usual aspect, the classic effect of MDMA. So therefore, this is the editorial written by Dr. Verbalis, who said this new study convincingly demonstrates a deficiency of oxytocin in patients with vasopressin deficiency. And he raises the question, is oxytocin deficiency now a new human disorder? So to find that out, we do this intervention study, the Oxytocin trial, where patients with AVP deficiency are randomized to get either oxytocin via nasal spray or placebo via nasal spray, twice a day for 28 days with the endpoint of emotion recognition and anxiety. So we aim to include around 130 patients in many countries in Europe, and we have included now around 50 patients, so this study is still ongoing. Also, other diagnostic and treatment studies are ongoing. I will show you some examples. First of all, I have shown you this MDMA study, and this is 100 milligram, which is approximately the party dosing, but maybe a lower dose of MDMA would also significantly increase oxytocin levels, but without any side effects. So what we do here is that we give MDMA only 25 and 50 milligram in a study where we also include not only patients with AVP deficiency, but also with anterior pituitary deficiency only. Then we also do the OxyPleasure trial, which is the effect of oxytocin substitution on sexual well-being in patients with AVP deficiency and healthy controls. So basically, this is the flow diagram of the study, and without going into details, there is a part A where there is oxytocin given for 7 days in a naturalistic setting at home, and its effect on sexual well-being and satisfaction. And part B is a clinical setting, once a single dose of oxytocin on subjective sexual arousal, perception of fear, empathy, and physical and hormonal responses to visual stimuli. Then there is the OxyMotion trial, which is also ongoing, which aims to evaluate the effect of a single intranasal dose of oxytocin compared to placebo, again in patients with AVP deficiency and controls, on emotion recognition and empathy, and on the cortisol response to the Trier social stress test, which is a psychological stress test. And my last point is oxytocin is very difficult to measure. It's even more difficult to measure than vasopressin. And as you have seen, the baseline levels are also not reliable. And if we go back to these two hormones, which are very similar, I have shown you in my talk this morning that pre-pro vasopressin is spliced into neurophysin 2, vasopressin, and copeptin. And we can measure copeptin to mirror vasopressin. Now, the same is actually true for oxytocin. And pre-pro oxytocin is spliced into neurophysin 1 and oxytocin. And this neurophysin 1 is, as copeptin, very stable and reliable and can be measured with a commercially available immunoassay. So that is what we looked at in our MDMA study. On the left side, you see oxytocin, which increases in blue in healthy controls versus patients. And the exactly same is true for neurophysin 1. And you see the very good correlation between oxytocin and neurophysin 1. Which means that if we measure neurophysin 1 again, we have, like copeptin and vasopressin, we have a marker, a surrogate marker, which mirrors oxytocin, so which could make life in oxytocin research much easier in the future. So in summary, is oxytocin a new endocrine disease entity? Several patients with AVP deficiency have psychological problems, so they have a possible oxytocin deficiency. At baseline, oxytocin levels are not reliable, as they are not upon standard hypertonic saline, arginine, methylmorelin CRH tests or new tests. And we have shown that MDMA as a biochemical and psychoactive stimulation test reveals an additional oxytocin deficiency in patients with AVP deficiency. And this lack of oxytocin was associated with the clinically relevant pathophysiological findings. So intervention studies are ongoing to investigate whether oxytocin treatment improves psychological symptoms in these patients. If you invite me again in 2 years to your beautiful country, I can show you all the results. And further diagnostic studies are also ongoing. And lastly, neurophysin 1 is a simpler method to measure oxytocin. Thank you very much for your attention.
Thanks, ma'am, for a wonderful presentation. The session is open for discussion. Any question from the audience?
Yeah, before the audience comes, this is a fascinating thing. So my question is, in AVP deficiency, we are using copeptin as a surrogate. So oxytocin is difficult to measure. Can you use something as a surrogate which would be a more easy to assay or more robust agent for oxytocin deficiency, number one? And number two, can you envisage any situation where there will be isolated oxytocin deficiency, maybe theoretical, without any AVP deficiency? And third, AVP replacement like DDAVP or something, do they have any therapeutic benefit on oxytocin deficiency features?
Thank you. Very important question. I hope I remember all of those. So the first question is do we have a surrogate marker for oxytocin? And yes, this is neurophysin 1. So we can measure neurophysin 1, which mirrors oxytocin, and neurophysin 1, which is the good news, is a commercially available assay. And as for copeptin, it's very stable. It's also at room temperature. You can measure neurophysin 1. So I think in the future, we will measure neurophysin 1 and not oxytocin anymore. Also, it can be measured in plasma, and for oxytocin, it's a bit controversial whether it should be measured in CSF or in saliva or in plasma. So it makes life easier. Second, is there an isolated oxytocin deficiency that, in absence of AVP deficiency? That is extremely interesting. I don't know, but I think yes. But this is really something we have to investigate in the future. There has been suggestions or the hypothesis that oxytocin could be lacking in autism spectrum disorders. And there was a large intervention study in patients with autism spectrum disorders, which was published in the New England some years ago, and basically it was negative. So it had no benefit. But many psychiatrists say that perhaps a subgroup of autism spectrum disorders might benefit from oxytocin and might have oxytocin deficiency. You can also imagine that some other people, like anxiety disorders, have some oxytocin deficiency. So we are on the way of investigating this, but so far it has not been proven. And the last question, whether AVP replacement has a spillover effect, has a benefit on these patients. Basically, it also has not been really investigated. What we know is that if we treat the patients with exogenous desmopressin, they still have these neuropsychological symptoms. Whether these symptoms are better before and after desmopressin treatment has not been investigated. And it's also a bit difficult because how to differentiate from the burden of polyuria and polydipsia. But it's a very interesting question.
Ma'am, when used in females, can oxytocin produce uterine contractions in therapeutic doses? When used in females, can therapeutic doses of oxytocin can produce uterine contraction?
Yeah, also a good question. Not in that dose. We give it as a nasal spray, and it's a very low dose if you compare it to the dose that gynecologists give to their patients. So no, it should not have any of these side effects.
I had a couple of questions. Dr. Mukherjee.
Yeah, your choice.
I think one of the questions was addressed by the chairperson of isolated oxytocin deficiency, but the other one, in some of your studies where we were trying to look for a stimulation test, have we considered the possibility that the psychomorbidity could be leading to oxytocin deficiency rather than vice versa? Psychological comorbidities or those symptoms, if somebody has certain psychocomorbidity or morbidity, can that result in oxytocin deficiency?
Psychological comorbidities leading to oxytocin.
Is that a possibility?
I don't think so, but it's an interesting thought. I mean, as we discussed just before, there is actually no oxytocin deficiency described beyond AVP deficiency. So that I don't think that psychological disorders, whatever it is, would in the end induce oxytocin deficiency. There is no data for that.
Yes, madam, can I ask a question? Because when younger days, when I was doing MBBS, MD, I was taught two hormones do not cause the deficiency, melatonin and oxytocin, right? Today it was a very interesting topic, but something came to my mind that when we have the panhypophysitis, they may present with the DI and they will present with the acute or subacute oxytocin deficiency. So in your study, have you ever had the case of the panhypophysitis presenting as oxytocin deficiency, or it was an isolated DI where you investigated?
So I hope I understood. You're question is whether there is a difference between like hypophysitis, which induces like solely AVP deficiency, or a hypothalamic disorder, which like leads to many different pituitary hormones. That's a very good question. Basically, this was only 15 patients in our study, and we had some with hypothalamic involvement and some with isolated AVP deficiency. And there was no difference in our study. But that's exactly also what one reviewer asked, and it's a correct question. So maybe, and that would be the hypothesis, in our larger study, which is ongoing, patients with a hypothalamic involvement may profit more of oxytocin treatment than those with a just isolated AVP deficiency due to hypophysitis, for example. But we will know when we have the data.
Okay,
Thank you.
because as the Professor Sengupta has already asked, because you pointed that patient with the oxytocin deficiency, when they take the MDMA, they don't get the effect which they were getting. So among the healthy controls, those who are on MDMA and those who are not getting their effect, will they be investigated for oxytocin deficiency isolated? And it may be a good hypothesis that those patients who are taking MDMA and not getting the response with that may be due to the isolated oxytocin deficiency, because oxytocin absence has decreased the effect of the MDMA. Your view?
Yes, I mean, we don't know about isolated oxytocin deficiency because all these patients had AVP deficiency. But of course, yes, and that's what we do at the moment, that we look at patients with anxiety disorders, with autism spectrum disorders. We give them MDMA, and the hypothesis would be that some of them, a subgroup, does not increase. Exactly, and that's your point, yes, I agree.
Ma'am, I had a question. Is there any difference in gender in the oxytocin deficiency and the presentation, clinical presentation, between males and females? Was there any difference in the cohort you studied, in the clinical presentation?
Yeah, thank you. The gender difference was the question. Yes, that was not seen in our study, but it's a very interesting question again, and also what maybe relates a little bit to that question is whether there is some problems in AVP deficiency patients with giving birth and breastfeeding. And that is something we didn't look at, and where there is no data actually. There is just some case series pointing out that these women they have problems with breastfeeding and with giving birth. But to your question, no, there is no gender difference.
Have a question.
Was there any difference in the psychological presentation with gender difference?
No, but I have to say, I mean, 15 patients, half of it male and female, is a bit difficult statistically to really see something. It's too small, yes.
Yeah, what's the impact on weight? Did you find any reduction in weight? Because oxytocin nowadays is being used for weight reduction.
Again, very interesting. No, we did not find any difference, and there was a study recently published in the New England Evidence by the group of Liz Lawson, who treated obese people with oxytocin, a bit a higher dose than we give, and she did not find any effect. So it seems a bit strange because it has metabolical actions, but it seems not to work, at least in obese patients. And I don't know about you, but in my experience, these patients with AVP deficiency are not having obesity, or they are not metabolically, I don't know.
For example, you have a patient with craniopharyngioma. So in them, will it work?
Exactly, and that is a study which is ongoing. Maybe in craniopharyngioma patients, that might have an effect, absolutely.
So last question
Yes.
from the floor.
Ma'am, because you have difficulty in stimulating the oxytocin with the provocation tests, like which one to select, then it's better to take the patients who have delayed uterine contractions during pregnancy, who are given oxytocin to induce uterine contractions. Though they have hypopituitarism.
If you have a question, or you are making a comment. If you have a question, be brief.
Yeah, questions. So whether like though they have hypopit or they don't have hypopit, is that population is better to consider in your study? Because there is no other better provocation test than the physiological thing during pregnancy.
You mean that those patients who have problems with giving birth, whether they have...
Because we didn't measure oxytocin in them until now.
Yeah, I mean, that's what I said before. There is unfortunately almost no data on that. There is some survey data that imply that these women have problems with giving birth and breastfeed. However, probably oxytocin is not only produced in the posterior pituitary, there is also oxytocin from the placenta. So that might be the reason why some patients with pituitary problems can easily give birth and others not. But that is basically a lack of data there.
Any experience of oxytocin deficiency in patient of anorexia nervosa? If somebody has tried them?
Not that I'm aware of any data, but I mean, it would be a bit counterintuitive because these patients do not eat enough and are underweight, and they should not receive oxytocin. But still, I think there is no data available.
Okay, so thank you for an excellent, scintillating session, and it raised many questions, naturally because it's a novel topic. I thank Dr. Mariam and my co-chairpersons, and over to the organizers for the next session. Thank you.
Our next program is the inauguration of ASICON 2025. So for that, we need some arrangements for a few minutes. So please be seated for some few minutes before we start the inauguration program. Thank you.
সাউন্ডের এটা কোথায় সাউন্ডের দাদা ভাই টপিকটা বাড়ছে সাউন্ডের ও এই যে বলে বলে দাও বাড়বে হ্যাঁ একটু বাড়বে বলছে দাদা ভাই একটু শোন ভাই তুমি আমার সঙ্গে থাকো এই যে একটু বাড়বে হ্যাঁ একটু বাড়বে বুঝতে পারছেন ব্যাপারটা এটা কি আউটপুট দিয়েছো একটু শার্ট করুন দাদা একটু শার্ট করুন ওকে এই কোনটা একটু দেখে দাও ওকে মনিটর একটু দেখে একটু দেখে নাও একটু দুটো বলছি মনিটরে দেয়নি রে মনিটরে দেয়নি
ACCON 2025. So for that, we need some arrangements for a few minutes. So please be seated. মনিটরটা চেক করে নিন
Hello.
Hello. Hello.
Hello. Hello. আমারটা আসছে না। Hello. Hello. Hello.
কিন্তু তিনজনের জন্য মাইকটা দেবো না
না আরেকটা দিন না আরেকটা ব্যবস্থা করে দিন হ্যাঁ বলেছি হ্যালো
হ্যালো হ্যালো
হ্যালো আসছে কোথায়
সামনে গেলে তবে শিওর মাইক না
আমাদের কথা কি হচ্ছে না হ্যালো অনেকটা দূরে
শিওর মাইক সামনে যেতে হবে
Hello, check 1, 2.
হ্যালো হ্যাঁ হ্যাঁ ঠিক আছে
ঠিক আছে, হ্যাঁ ঠিক আছে, হ্যাঁ হ্যাঁ ঠিক আছে, আচ্ছা হ্যালো শোনা যাচ্ছে, শোনা হ্যালো হ্যালো এখান থেকে ঠিক আছে, হ্যালো না না না
ভয়েসটা ক্যাচ করে নিলে একটু বাজে হবে, কনসেন্ট্রেট হয়ে যাবে। এটা আছে। হ্যালো এটাই আসছে।
হ্যাঁ আসছে।
হ্যালো
Hello, check. Hello, check.
হ্যালো এটাতে লাগিয়ে দিলে হয় না? ওইটাই বলছে এখানটা একটু লাগিয়ে দিন না। এটাতে লাগিয়ে দিলে
Hello. I would now like to invite Dr. Nilanjan Sengupta, sir, the organizing Vice Chairperson, ESICON 2025, for the inaugural ceremony.
Dear senior and junior members of the Endocrine Society of India, friends and students.
Hello. Hello.
So welcome to Kolkata, welcome to City of Joy, welcome to ESICON 2025. I, on behalf of the organizing committee, now invite you to the formal inauguration of ESICON 54th Annual Conference of Endocrine Society of India, that is ESICON 2025, for which we have worked for the last 2 years, and the time has come to formally inaugurate the conference. So may I request the dignitaries to take the dais. To start with, may I request Dr. Kaushik Pandit to take the dais and Dr. Biburanjan Khare to usher him in. Next, may I request Dr. Shapon Soren, our chief guest, who happens to be the Director of Health Services, to take the dais, and Dr. Biburanjan Khare, please accost him to the stage. May I now request Lieutenant General Dr. Narendra Kotwal, our National President, ESI, to come to the dais and show me to accost him to the dais. May I now request Dr. KVS Harikumar, our very dynamic National General Secretary, to take the stage, and again, Bivu, please help him usher into the stage. Now, may I request Dr. P.K. Jabbar, our immediate past president of ESI, to take the stage, and Bivu, will you please accost him to the stage. May I now request Dr. Pradeep Mukherjee, Scientific Chairperson of ESICON, to take the stage, and Bivu, please help, sir. Last and not the least, may I request the most energetic, active, and dedicated person behind this ESICON 2025, Dr. Sujoy Ghosh, Organizing Secretary of ESICON 2025, to the stage, and also the President-elect of Endocrine Society of India. Now it's a pleasant duty to felicitate the dignitaries with a small token of appreciation. Dr. Ruhi Nanda, please felicitate our chief guest, Dr. Shapon Soren, Director of Health Services. Next, Sapan, you be ready. The saplings, yeah. Somebody, Obik, please help with the saplings. Be fast. Yes. Help Ruhi to felicitate our chief guest, Dr. Shapon Soren. Sapan, be there. Please go near the stage. Arundhati, you be ready for the next felicitation. So, may I request Ruhi, yes. Dr. Sapan Vijay Kumar Shah to felicitate Dr. Narendra Kotwal. Next, Dr. Arundhati to felicitate Dr. P.K. Jabbar. Bibhu, be ready. Done. Next, Dr. Bibhu Ranjan Khare to felicitate Dr. KVS Harikumar. Dr. Shaumil is there. Dr. Shaumil will now felicitate Dr. Kaushik Pandit. Arundhati is there. Dr. Arundhati Das will next felicitate Dr. Pradeep Mukhopadhyay. And Bibhu Ranjan Khare again would felicitate Dr. Sujoy Ghosh. Thank you. Thanks, sirs, for accepting the felicitations. May I now request Dr. Kaushik Pandit, Organizing Chairperson of ESICON 2025, to deliver his welcome address. You can speak from there if you are comfortable, yeah.
Good afternoon. It's my very proud privilege to accord a warm welcome to all to this 2025 version of the annual conference of the Endocrine Society of India, the ESICON 2025. It's indeed a rare opportunity for one to don the dual hat of the organizing chairperson and the president-elect of the society simultaneously. As the organizing chairperson, it is my prerogative to greet our distinguished faculty, esteemed delegates, and guests from across the globe. This year's conference brings together thought leaders and practitioners in endocrinology to share the latest research, exchange groundbreaking ideas, and foster collaboration. Over these days, you will experience a dynamic program featuring insightful lectures, interactive sessions, and hands-on workshops, all designed to enhance learning, innovation, and very importantly, exchange of ideas amongst experts. We enthusiastically invite participation and hope ESICON 2025 will enrich your professional journey. Beyond the scientific aspects, we, the organizing team, tried incorporating the local flavor in the form of the visual, musical, and cultural aspects, Hope you would enjoy. I'd like to thank each one of you very much for joining us. Let us make this event truly memorable.
Thank you. Now it's a time for the inaugural song. May I request the participants from the Shaboni Shen Music Academy with the inaugural songs. For your information, Shaboni Shen Music Academy is a training center of Robindra Sangeet set up by Shaboni Shen, a renowned Robindra Sangeet exponent herself, which has 7 branches in Calcutta, has 11 branches in Kolkata and the districts, and 6 online branches which attract even overseas students. The first song would be a Robindra Sangeet invoking goddess Saraswati or Binapani, the goddess of learning. Following this, they will be singing the state anthem Banglar Mati Banglar Jol, which was composed by Tagore in 1905 at the height of the agitation against the partition of Bengal. This song was adopted as the state anthem of West Bengal since September 7, 2023. Thank you. Thank you. That was really mesmerizing. And for your information, this song was composed by Rabindranath Tagore in 1905, and during the Rakhi Bandhan that he organized in 15th October as a symbol for Hindu-Muslim unity in Bengal. At the height of partition agitation, this song was sung during the Rakhi Bandhan that was organized by Tagore. So next is the ceremonial lamp lighting. May I request the dignitaries on the dais, led by our chief guest, Dr. Shapan Soren, for the ceremonial lighting of the lamp, and Dr. Piyash Gargori, Dr. Uttio Gupta, and others, please help them in the formalities. I now request Dr. Narendra Kotwal to give his address. Dr. Kotwal, please.
Respected teachers, esteemed colleagues, delegates, friends. As President of Endocrine Society of India, it is my privilege to welcome to 54th Annual Conference of Endocrine Society of India. You know, our society started somewhere in 1971 at Bengaluru, and since then it has journeyed with few pioneers to nationally vibrant community spearheading endocrine science, education, and patient welfare across the country. ESI remains steadfast in its mission to advance the science and practice of endocrinology, bench to bedside, to community, to policy. Under our collective banner, we have strengthened research grants, expanded student-centric teaching programs, and deepened social outreach in public awareness initiatives. We are equally committed to the health of our planet and our people, embedding environmental stewardship and physical fitness programs into our academic calendar. Above all, we celebrate the growing cadre of young, dynamic endocrinologists who bring fresh energy, skills, and purpose to our shared work. The days of working in silos are over. ESI actively collaborates with sister specialty societies to address the complex, overlapping health challenges holistically, because that is how our patients live and how their problems must be solved. This year's scientific program has been carefully curated to span the full breadth of endocrinology, cutting-edge science, practical clinical wisdom, and real-world implementation. ASICON is also a festival of community. Our Walkathon Plantation Drive, which is tomorrow morning, carries a simple message: healthier people, healthier planet, one step and one sapling at a time. I thank the scientific committee, organizing team, faculty, delegates, and partners whose dedication has crafted this academic feast and collegial gathering. May these days leave us cerebrally stimulated, clinically empowered, and if I may say, returning home in an unanandamide or blissful state with new ideas, friendships, and resolve to serve our patients better. With that spirit, I extend a heartfelt welcome to ASICON 2025. Jai Hind.
Thank you, sir. May I request Dr. P.K. Jabbar, immediate past president of Endocrine Society of India, to briefly address the audience.
Good evening, everyone. Dignitaries on the dais, off the dais. I don't want to take a lot of time. First of all, I wanted to congratulate the organizing team, Calcutta, ASICON Calcutta. And I want to thank each one of you for giving an opportunity to serve the society for the last 3+3 years. Thank you. All the best. May God bless you. I'm signing off.
Yeah. Dr. Jabbar, please don't go away. You have a pleasant duty to release the book Geriatric Endocrinology. So now the book Geriatric Endocrinology would be released, led by Dr. P.K. Jabbar. So give one copy to each of the dignitaries in the dais. Please help them quick, Abhi, go, quick. And Dr. Jabbar would be leading in cutting the ribbon and releasing the, unfastening the ribbon. So Shormishra has corrected it, not cutting, but unfastening the ribbon and inaugurating the book, Geriatric Endocrinology. Next, of course, I will keep my junior colleague, but Secretary of Endocrine Society of India, KVS Harikumar, busy. First to address the audience briefly, followed by he would be doing the onerous job of conferring fellowships of Endocrine Society of India to the recipients He will be calling them, but I'm just alerting their names: Padma Bhushan, Dr. Amrish Mittal, Dr. Anil Vansali, Dr. Abdul Majid, Dr. Shubhankar Chaudhary, and Dr. Sarita Bajaj. I request all senior endocrinologists be seated in the front so that you can come up once Dr. Hari Kumar call your names. So over to Dr. KVS Hari Kumar for this part of the program.
Good evening, everybody, and welcome to ESICON once again. Splendid show by the team Kolkata for doing fabulous work over the past 2 days, and we're going to see again excellent work in the next 2 days. Now, I represent Endocrine Society of India as a secretary, and a lot of people say how it is working, whatever. As I said, the ESI will do good only if everybody does good. And thankfully, I can say that the best and the brightest are the ones who are joining the society, who are joining endocrinology, and who are willing to contribute to the society. So big cheers to all the members who have joined, who have never said no to anything whenever we ask whatever to be done. So that is what we actually look for, because a society is made by all of us. It is not an individual. So please look at that. How best I can uplift, that is what we are looking for. And that is the only thing what we look for from every member of the society. And without wasting much time, it's our pleasure to honor, in fact, it so happened that it is happening on the Teachers' Day, and the people who are receiving the fellowships are professors to lot of professors. So you can imagine, professors to lot of professors. So it is my pleasure to invite Professor Amrish Mittal sir first to please come onto the stage. They are the fellowship recipients for year 2025. May I request the chief guest and president sir to please give the fellowship to Professor Amrish sir. May I request Professor Anil Bansali sir to please come on to the dais, please. May I request Professor Abdul Majid sir to please come on to the dais. Thank you, sir. May I request Professor Sarita Bajaj ma'am to please come on to the stage. the last who doesn't need an introduction, the Royal Bengal Tiger is going to come, Professor Subhankar Chaudhary, sir. Thank you, sir. Thank you for the felicitation. Over to Dr. Nilanjan.
Thank you. We are really pleased and feel privileged to being able to felicitate the teacher of teachers in endocrinology on Teachers' Day. So there is another book release. Dr. Hari Kumar, you can go and sit. So you have to lead releasing another book, ESI Case-Based Approach to Endocrine Disorders. So everybody in the panel will be releasing, led by Dr. Hari Kumar. So you just help release the book. In the meantime, others be ready with the next book. So a wrong book has been given probably. No, this was the ESI case-based approach to endocrine disorders, but it is the IgM. Okay, never mind. The IgM will also have to be released. You release the IgM. Okay, you release it, release the IgM. So, but the other book, the ESI case-based disorders, you keep that. So this is the IgM is being released. So don't worry, you have a lot of books to release. So it's like endocrine Boimela. So Boimela, Kolkata is famous for Boimela, and we are having endocrine Boimela here. So now let's release the ESI case-based approach to endocrine disorders. Is this book ready? Yeah, I think this is by Gagan Priya and Joe George. So Dr. Pradeep Mukherjee would lead the dignitaries in releasing the endocrine case-based approach to ESI case-based endocrine disorders. So do it, yeah. You do it, and Gagan Priya herself is on stage. That's wonderful. And where is Joe George? Is he there? George, oh, okay, both the editors are there. So that speaks it all. They won't get a copy to officially release. They have to share from others. I think these books can keep you busy through the Durga Puja and Diwali holidays. So you have enough food for thought for the next couple of months. So the book release done. Hari wants to say something.
My apologies. I forgot to mention about the ESI Lifetime Achievement Award for 2025 that has been given to Professor J.K. Agrawal sir from IMS BHU. We will deliver it to him. Sir is not, for his age, he's not here, but we will deliver it to him due. My apologies for missing that.
So our respects to Professor J.K. Agrawal, all from everybody from Kolkata. He had been my examiner too in the DM endocrinology examination. So may I now request Dr. Pradeep Mukhopadhyay, the scientific chairperson of ESICON 2025, to say some very few words about the exciting scientific program that we are into.
Good evening, respected dignitaries on dais, our President, our very favorite Lieutenant General Narendra Kotwal sir, our very beloved Secretary KVS Harikumar sir, Chief Guest Dr. Shapon Soren, and of course my fellow members like Dr. Kaushik Pandit, Dr. Sujoy Ghosh, and obviously, of course, past President P.K. Jabbar sir, and my idols related to endocrinology sitting mostly on the left side, distinguished delegates and other people who have already appeared there. So this year, ASICON, the 54th annual conference, I am being told to say something about the scientific program. The most important thing of this scientific program is very exciting, and this is primarily going to showcase the exciting research. We have actually made another special hall for daily presentation of several researches so that we can have an idea or generate new ideas related to research. Apart from this, I am very sure that the knowledge building and collaboration and improving ourselves through the networking as well as insights from the various national and international speakers will definitely enlarge the knowledge base and the communications between ourselves. And finally, I like to thank all my fellow co-organizers for trying to make this conference successful. Thank you all.
Thanks, Professor Pradeep Mukhopadhyay. Before I go further, there has been a request by some of the students, like Dr. S.K. Singh, for a brief standing ovation for Professor J.K. Agarwal, who has been the teacher of our teachers, my examiner, for his contribution to Indian endocrinology. So let's have and do it. So long live Dr. J.K. Agarwal, and let him continue to inspire us through his words and his action. Thank you. Thank you. Next, of course, we would be having another stalwart from Bengal, Nobel laureate and Bharat Ratna, Professor Amartya Sen. True, he is not here physically because he is now in the United States, but Dr. Shomi Goswami, Dr. Kaushik Pandit, and Dr. Sujoy Ghosh did take the trouble to go and meet Professor Amartya Sen at his Shantiniketan residence when he was there in India last month. And it was then that he was magnanimous enough to deliver a brief message to the delegates and faculties of ASICON 2025, which Dr. Sujoy Ghosh et al. Could record through the mobile phone. So the video quality is not excellent, but it's a good video quality. We have to accept that. So we will be playing the video message of Dr. Amartya Sen, though it would have been better if we could have been physically here, but since we can't have him, we'll be having his video message played.
I'm delighted to hear about the conference on diabetes. It's a difficult disease and treatable, and I'm delighted that this conference will help to pave the way for better treatment for patients and the curing of this very unfortunate ailment. So I send you my very best wishes and warmest hope that things will work out wonderfully well. So good luck, and I congratulate them.
So thank you, sir, in absentia, and thank you all. May I now have the pleasant duty to request our beloved Director of Health Services, Chief Guest of this evening, Dr. Shapon Soren, to say a few words, and following that, he will be releasing the souvenir. Over to you, sir.
Good evening, respected dignitaries on the dais, of the dais, all the delegates who come over India in this city of joy, আপনাদের সবাইকে স্বাগত এই city of joy. It is really a pleasure to be here with you, such a galaxies of personalities. I don't want to wash my hand today because it is with the touch of these professors of the professors. It really fills my heart. You, the peoples, will deal with the 50% of the population of the India who are in distress, who are diabetic, who are with endocrinology disease. My humble request, let's customize our communication with the peoples what they can understand. Because if you don't communicate properly, your complication will increase. And I am really grateful that everywhere in the India, you are the peoples who are serving the peoples of the disease which is slowly growing and leads to a complication, leads to death. And regarding the type 1 diabetes, our Professor Ghosh is the pioneer of making a public health program. It was started with 4 districts, now expanded with 11 districts, and each and every one are getting free of cost medicine. They are tracked and followed up with the app so that and as Dr. Ghosh told, that we have reduced the out-of-pocket expenditure up to 75%. So you save them economically, you save them physically, you save them psychologically. Overall, you protect the health of the personnel. I am really grateful to be here with you all. Hope you all, the expert physician, will jump onto the public health. Coming out from your clinics, I know many of the endocrinologists, and I am one of the patient of one of our expert physician, and I saw the busy peoples, and what he did not allow the lift to be there, because you have to do the physical activities. That kind of innovation you are doing. Innovation in social hearing, what the people are saying, and you are customized your treatment, your counseling, your communication, that leads to decline the complication, that leads to decline the expenditure, which most of the peoples can't afford. So really I am thankful to each and everyone who are taking this effort of saving the expenditure, saving the life, and saving the death by declining the complication. Let's this workshop be a great one. You enjoy this extravaganza of academic fest as well as reunion with yourself. Thank you all.
Thank you, sir, indeed, for your encouraging words. As we come to the end of our inaugural program, may I request Dr. Sujoy Ghosh, the organizing secretary and undoubtedly the most hardworking member. Before I invite Dr. Sujoy Ghosh, again, I would be bothering Dr. Shapon Soren to release the souvenir of the Endocrine Society, to lead in releasing the souvenir of the Endocrine Society of India. Just a request to all of you, please don't leave behind the souvenir on the table. Take pains to carry it home and go through the pages in your leisure time. I promise this would be a collector's item, and this has been the brainchild of Dr. Kaushik Pandit, very much in the stage. I think he has spent hours on it, along with Dr. Shormishta Mukherjee and Dr. Anish Kaur. So they are the main brains behind the souvenir, but the contributions of every single contributor actually meant. You just have a look at it at your leisure and you will understand that it is different from other souvenirs of other conferences. One thing that should strike you, that no two covers are similar. So, as Dr. Shormishta Mukherjee is saying, this is a Baluchari cover, so I think there's a write-up on that also. You go through it, you will understand. So now may I request Dr. Sujoy Ghosh, who has been the most hardworking and most efficient person of this ESICON organizing team, to deliver the vote of thanks.
Thank you, Nilanjana. Good evening, ladies and gentlemen. My job is relatively easy. I just stand here on the podium and thank everybody, because 99% of the job has been done by the entire team. At the very outset, I would like to thank the Endocrine Society of India for having had the trust that Kolkata could host ESICON 2025. And on behalf of the organizing committee of ESICON, I would thank all the dignitaries on the dais who took their time, particularly our chief guest, to come to this meeting. And most importantly, ESICON is a scientific program. And therefore, the entire scientific team led by Professor Pradeep Mukhopadhyay deserves a lot of credit for the hard work that they've put in to put together a scientific program, hopefully with a difference. And to deliver the scientific program, you need wonderful faculties. And I think we have had great faculties, both international as well as national, who have traveled so far from their homes to try and make this conference a success. The various chairpersons, the judges, the moderators, and even today when we had a public health session, people from the government, from central government and the state governments, they, I think, did a wonderful job. When you talk about a program like this, apart from the scientific bit, there's cultural program as well. You heard the inaugural song today. Yesterday, Colors of India, the doctors who participated, did a great show, the Chow dance yesterday. And today, after this program, you have the Tanushree Shankar's World Academy dance program. And tomorrow, you have Shourendra and Shoumodip performing. So thank you to them as well. Big thank you to ITC. You know, I've had great fights with them all through in the last few months, but I must thank them for all the help that they've provided, particularly Rosemary and Aishwarya. The event management team of Rahul and the entire team. And unlike most of the other conferences, majority part of the event management has been done by pharma. We have paid for it, but they have done the hard work. So a big thank you to all of them. And the decorating team, the audiovisual team led by Bulbulda, the printing that you have seen, if you look at the souvenir And all of the printing has been done by Topuda, who has been wonderful, except that he's kept us on the knife edge, whether he will deliver on time or not. And all of our office staff, in spite of no extra incentive, they've actually spent so much of time to actually try and deliver the work that they've done. I would individually like to thank Mr. Topon Pradhan, because Topon went around with me to get that Durga idol. 3 weeks ago, we suddenly decided that we would come up with that. All the idols were sold, and Topon, myself, and my wife, we spent about 4 hours at Kumortuli trying to find one. And of course, the entire organizing team led by Professor Shubhankar Chaudhary and Dr. Kaushik Pandit. No conference is possible without money. And of course, I'm very, very grateful to the generous contribution made by all of the pharma individuals. Thankful to the press and media for the coverage, which I'm hoping they will provide. And finally, the success of conference depends on the delegates. All of you have been wonderful. Thank you very much.
So thank you, Professor Shujoy Ghosh, for your stimulating talk, though brief. So as we come to the end, it is customary to end with the national anthem. So please stand up for the national anthem, and may I request the Sravoni Sen Music Academy to again come to the stage once again to lead us sing the national anthem. Again, this is the third song by Rabindranath Tagore in this program. It was composed by Tagore in 1911 and was published in Tattvabodhini Patrika under the title Bharat Vidhata. And the first stanza of this 5-verse song or poem has been adopted by the Constituent Assembly of India in 1946 as the national anthem of India, which is all too familiar to us. So let's now stand up for the national anthem. Keyboardটা on keyboardটা start.
भारत भाग विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल जमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जनगण मंगलदायक जय हे भारत भाग विधाता जय हे जय हे जय हे
Thank you. And I declare the inaugural ceremony closed. Over to the MCs.